A very good morning, dear friends. Good morning, Professor Totsi, Professor Konings. It is my great pleasure to welcome you. A very good morning. Today, we are on day 3 of this Congress. Congress New Technologies in Diagnostics and Therapy of Gynecological Diseases. Dear friends, as usual, morning starts with an international course on endoscopic surgery. This morning, we shall listen to a presentation by Professor Konings in this morning, some welcome words, some welcome addresses by Professor Tozzi. At 9 a.m., Professor Vattiers will begin necessarily live surgery, which will be looking at live. And then the person who will be moderating, or rather commanding the parade, will be Professor Tozzi, because he is to present two large lectures. I'm very much pleased with what we've been doing for 2 days. About 3,500 people and more were always online for the last 2 days. It's a great success. It is great confidence that physicians have for us, and I would like to wholeheartedly thank you for it. Professor Tozzi, tell me, please, would you like to welcome us? Say a few words. Roberta Tozzi, are you online, please?
Of course I am, Leila. It is my pleasure and my delight to be with you. It is early hour in the morning, but as usual, I'm very happy to join you. And it's an amazing success.
А звук она может дать или так и будет меня нервировать?
So I hope you hear
Приятно,
me.
хорошо. Скажите, пожалуйста, профессор Тозzi.
Professor Tozzi, tell me, please, what are you going to present to us today? What are you going to present to us today in your lectures, which will be delivered later on?
О чем сегодня...
What you will have 2 lectures. Sorry, Professor, there was some technical glitch probably. One of them are ovarian cancer from laparoscopy through genomics to radical surgery. This is the first. And the other, treatment of patients with ovarian cancer and patients with cervical cancer. Tell me, please, for 5 minutes, would you like to present to us what are you going to say to us? What will be going on?
Sure. So the first lecture on ovarian cancer is going to take the audience through the journey that we are experiencing these days. So some time ago, doing surgery was enough. Like, you would do surgery, surgeons were only requested to do surgery, and that's it. These days, it's a new journey has started. You have to know about genomics, you have to know about research, basic research, about chemosensitivity. And through this elaborated and refined selection pattern, then you choose the patient for surgery. So surgeons are these days more imbued in a climate of research, and cancer patient will benefit from a massive panel of experts addressing which are the best person for surgery. So what I'm going to take you through is the journey we're experiencing now. It is an extraordinary and exciting time to be treating patients with ovarian cancer. And I think that these days, this would ultimately end with the presentation of laparoscopic multivisceral debulking surgery, which is something extremely new, which we have just registered in clinicaltrial.gov, which is the site of the American government for clinical trials, and that will be presented today at your meeting, Leila. Same thing with patients for cervical cancer. Cervical cancer is luckily becoming more rare and therefore less of an issue, but there are still a lot of patients who are suffering from cervical cancer. And for this type of disease, there is a type of disease which is still amenable for extensive radical surgery. And these are the large cervical cancer, which are still life-threatening and that could hamper not only the life, but even the quality of life of these patients. For these patients, I think that offering them chemoradiotherapy is an option, but for the handful of skilled surgeons who can still offer radical surgery, I think they had to be preferred, and they provide a way better survival outcome compared with quality of life. So I think the 2 topics are of great interest in oncology, and there is so much argued and debated at this time. So thank you for giving me this opportunity. I'm very happy to present this new data and share them with you.
Dear Professor, Did you see our agenda? What is on the agenda, on our agenda today? What is your take on this? What is your opinion of our agenda, program of the Congress? Could you take a look at the program of the Congress? We have fantastic faculty here, and I'd like to say that your lecture is very much we're looking forward. Please, did you have a chance to?
Just want to say, Leila, one simple thing. There are very few people in the world that can put together such high quality speakers, all being very pleased and happy to be there and to join you. So that is a huge remark on you, Leila, because there are very few in the world who can put together such a high quality panel. So congratulations on you every year for doing such an amazing program of high interest, which is of high interest for everyone. It's one of the few Congress where I stay on to listen to other speakers because it's such an interesting thing. So thank you for doing this.
Мне очень...
It is a great pleasure for me to listen to what you have to say. Allow me, please, to hold this course in this way, this hour. We will ask Professor Konings. He promised to share with us what is new about adhesions in gynecologies, in operative gynecology, what it depends upon. Philip and I did a lot. Some 20 years ago, we worked together extensively, and today we also published several articles. And with your permission, Professor Totse, as part of this course, may we request that Philip Konings, for some 20, maybe 30 minutes, he should deliver a presentation. What is the role of adhesions when we speak about new technology in surgical outcomes? And then we'll see how Professor Mathies is operating, and then you will go live. Are you happy with this agenda? Yes, thank you. Then, dear Philip, are you with us? Philip?
Yes, I'm here.
Да. Дорогой
Everything is
Филипп,
okay.
Dear Philip, a very good morning to you. Are you ready to present your lecture about adhesions? Everyone is looking forward to it. Do you know why? Because a lot of conversations...
everything is okay.
Да, все хорошо. Yes, because everyone is looking forward to this lecture. Because people say there are a lot of anti-adhesion barriers, but in reality, in real life, the problem of adhesions, few people have in-depth knowledge. The floor goes to you, Professor Konings. Please, the floor goes to you.
Pleasure to be here. Adhesion formation is something that every surgeon has to face and the side effects of every surgery. So just let me share what I was sharing at the European Society of Gynecological Endoscopy last year. Adhesions need to be prevented because once adhesions are there, adhesiolysis is not very effective. And then you have to think what I would say, think like a Bayesian. It's not this one factor and a second factor and a third factor. Is this end, which means all together is what's going to make the results. And think what is changing also is p-values. Significance is something which is out. It's something I discussed with Professor Adamian a lot of times. P-values have become probabilities. And the p-value of 0.05 is a probability changes from 50 to 70%. A totally different story. I said this also on Monday. And associations does not mean causality. And we have to use everything which we know. And for instance, barrier surgery is only 50% of adhesions for selected intervention, which means it's not very, very good. And in the slide here, in the image, you see that if you put a barrier, and this was a plastic barrier, in between for a few days, you decrease adhesion by half. This is what we know. The second message I would like to give you is that today we can do adhesion-free surgery. This is one of the papers, one of the last papers, where we did a randomized controlled trial, deep endometriosis surgery. And you see that in those who did not get the prevention, did have a lot of adhesions, and those with prevention have virtually no adhesions. It means that today we can do a surgery without adhesions if you take care. The first thing is heredity and individualization. Well, it's very clear in mice, inbred strains, and so on. Little data in the human, but the individual risk are the family, keloid, those who had already a lot of adhesions after prior surgery need much more attention. One of the things I am close to convinced of is that antioxidants could help. In animals, it does help. And anyway, if you say antioxidants, if the day before surgery you had some orange juice, there's absolutely no risk. And I think it prevents adhesions. Another thing, this is of the last years, this is mainly the microbiota of the vagina and of the peritoneal cavity, which means that if there is a vaginal infection, treat it before you do surgery. And you see, this is not yet what is standard therapy to check vaginal infection before surgery. An introductional remark is that the abdominal cavity does not belong to the core body. It's outside the body. It's like the mouth, it's the outside. And the peritoneal cavity, this is true for temperature. This is the core body is only the head and the heart of the thorax. So this is few things which you have to understand. And then prediction of adhesions. It's clear you have the trauma, what is causing the adhesions. And inflammation and trauma, this is good surgical practice, gentle tissue handling, duration of surgery, insufflation pressure, blood, but also peritoneal microbiome, vagina, intestine, food. The intestinal microbiome is also partially making the intraperitoneal microbiome. And then you have anesthesia. And I'm just going to say a few words about low impact opium-free anesthesia. So you see, it's N. To begin with that, opium-free anesthesia is very clear that the CO2 absorption is less, and that this is very well demonstrated. And we know that CO2 is harmful, and we know all the rest we know, not yet demonstrated, only indirectly for adhesion formation. Opium-free anesthesia, why do all anesthetists use opium to do anesthesia? It used to be in order to stabilize the heart. So today we can do this without. So we do not need opium-free anesthesia. And I think it's one of the new things that everybody, every center should think of. The surgical trauma and adhesions. The repair takes 3 to 5 days after surgery. You need to look at irrigation fluid, at the gas, and at the surgical trauma. So repair, a few things you have to know. All of you have to know. That is within half an hour, which means before the end of the surgery, you already have, of all lesions you make, this kind of neutrophils and macrophages and tissue repair cells, which are there on the wound. Then you have, after surgery, you have a little bit of oozing, a little bit of fibrin, and you have attachment of the wound. and then start already the lysis with the movement of the bowel and with fibrinolysis within an hour and a half. And by day 3, normally everything is gone. Remember, day 3. This is why the first day after surgery is so important. The connection of this is the early feeding, the early mobilization after surgery, those new protocols. But if after day 3 you still have fibrin, at that moment you get infiltration of fibroblasts. And if after day 5 you still have fibrin and fibroblasts, you get angiogenesis and you get these vascular adhesions. If you see this, you know that if you put a suture, which all take more than 5 days to stay there, it means that sutures are always adhesogenic. And if you want to be sure you're going to have adhesions, put a suture. So these are the simple rules. If you coagulate a lot, you're going to have a lot of that tissue, and that tissue needs inflammation in order to remove it. Blood, if you leave blood, you will have more adhesions. And to say, I'm going to wash after surgery, you cannot. You cannot remove the fibrin from the mesothelial cells because it sticks there. You cannot wash it out. Second, it's suturing. There are 2 ways of suturing. This is strangulate with force or just do it superficially. Why does very often the circular stapler for a bowel reanostomosis work better than a hand suturing if you are not an expert? Is because the circular staple does not cause ischemia because they have 2 or 3 rows of staplers. Do not use too much suture material. This was the talk of Armando Romeo yesterday. If you know how your knot tying has to be done, you can use safely thinner suture. And why we use 1 or 2 to close a vagina, there is absolutely no reason. This is history. And 3, keep short tails. You have seen in live surgery, they cut a suture at 1 centimeter. This is because they still not have, and with all respect for the surgeons you are going to see and saw, they cut a suture at 1 centimeter because they seem not yet to have understood that if you have with some combinations like the H3, H2, you do not need to cut them long. Armando explained it. This is the sliding of the knot. Prevent infection and do not decrease fibrinolysis too much. And this is, for instance, the anesthesia. So, but what is more important than this kind of suturing is that the abdominal cavity, because once you put CO2 in, and CO2 is irritative, try this, blow it on your tongue, within 10 seconds, it's going to hurt a lot. So with this irritation of the whole cavity, you get something in the whole abdominal cavity by acute inflammation, which is going to increase adhesion formation. We call this peritoneal fluid enhanced adhesion formation. And this is exactly important for abdominal surgery. And this is true whatever you do in the abdomen. It was very nicely demonstrated. This was Ron Schoenman when he was in Leuven, and he demonstrated that manipulating the bowel in the upper abdomen, you get more adhesions out between the uterus and the wall. And this kind means that there's something in the fluid. That's why a good surgeon has less adhesions. Because if you grasp and grasp and grasp and re-grasp, you have much more manipulation. And a good surgeon grasps once, cut, and has a minimum of. Second, it means do not grasp with too much force. Be gentle with the tissue. And this was very well demonstrated. It's time dependent, it's pressure dependent. All this is true. The mechanism is that the cavity of the peritoneal cavity is lined with the mesothelial cells, big flat mesothelial cells. And then because of the CO2, the irritation, whatever you want, you're going to have this kind of retraction. And in between the mesothelial cells, you see the basal membrane. And in fact, this permits a lot of cells to have more adhesion. This is the reason why you're going to have more cancer implantation. So, and after this, acute inflammation, and or you go to repair, or you go to adhesions with pain, fatigue syndrome. And fatigue syndrome is something which goes for up to 3 months. This retraction is caused by hypoxia, hyperoxia, desiccation, blood and fibrin, saline, higher temperature. I'm going to explain this in a few words. The first thing, key message is saline is toxic. If you use saline to irrigate, all the mesothelial cells float off. And that's why you need something better. Ideal would be something like a culture liquid. This is if you want to read the US patent on this, that's what you should use. But today, I think Rangers lactate is what you would do. Very nice publications from the groups of Poland, where you have in tissue culture, you see that mesothelial cells put pure saline on it, and you get these cells who get loose and start to float. A lot of this work has been done in mice. Why mice? Mice is a good model. Mice are cheap, and you can do 10 mice in a day. If you try to do this in rabbits or in larger animals like pigs, it becomes very expensive, and it's much more difficult to get the numbers. The second thing, what is important for us as surgeons, is insufflation pressure. Lower is better. Lower is better because with an insufflation pressure of 15 millimeters, you already are going to decrease the microcirculation, the superficial. And after surgery, during surgery, you get hypoxia. And after surgery, you have the ischemia reperfusion trauma. Very well illustrated. And conclusion here, the pressure for insufflation should be less than 15 millimeter of mercury. And if you can work with 10, it's even better. So this is a lot of publication. Mainly the group of Clermont-Ferrand has been very active with Michel Canis, Bourdelle, Matsukaki. And this is the story of normoxia. If CO2 has no oxygen, which means the superficial layers have no oxygen. If you have hypoxia, you get two things. You get this process of hypoxemia-inducible factors which start, which leads directly to angiogenesis. Ischemia reperfusion increases reactive oxygen species, same thing as too much oxygen. And this reactive oxygen species increase adhesion, and it gives this kind of bell-shaped curve. Ideal is around 4% of oxygen. And this is not so surprising, because we know that this is just a way of explaining the microcirculation and the ischemia reperfusion syndrome. But oxygen, there's 20% oxygen in air. These are data of the 30s. It's very well known in physiology. And then in humidified air, you have a little bit less, and then. And when you go to the peripheral cell, you have a partial pressure of 10 to 40 millimeters. But 10 to 40 millimeter of mercury partial pressure means 4% of oxygen. So if we would have been intelligent, we would not have done a year experiments to find out that 4% is better. We should have known it. That you get this kind of superficial hypoxia is very well known, very well demonstrated, because if you do this by histology, you see this kind of superficial, and when you look at the peritoneum, is the mesothelium 1 or 2 millimeters of depth. We all say no desiccation and cooling. The industry even made insufflators with heating because they thought it's going to be less adhesogenic. This is an historical mistake. And it's very clear that desiccation, when there is flow through the abdomen, when there's leakage, more flow, more desiccation, more adhesion formation. And then there's something I already would like to point out. If you decrease the temperature, you decrease adhesion formation. And if we put all the data which we had together, it's very clear that you can decrease adhesion with decreasing the temperature. And we did this also in the human, where you can demonstrate that below 31 degrees, which is not a problem for the patient, there is less adhesion formation. And then you need a gas, CO2. Why CO2? Because it's very soluble. But CO2 is painful, is irritative. And painful, I always invite you in operating theater, just blow CO2 on your tongue. You're going to see within 10 seconds, it's very, very painful. And how are you going to prevent this? A little bit with adding oxygen, but it's something which is directly irritating the nerve fibers. And we only had found one way to counteract this pain. This is adding nitrous oxygen. I'm going to show this is the most effective. These are data done by Karina Mailova when she was in Leuven. And we thought if you are going to have nitrous oxygen, why nitrous oxygen? Because it's the only second gas we know which has a high solubility in water. So if we thought if you are going to add, at least we are going to decrease the effect of CO2. But in fact, instead of finding this kind of line, we found an exponential decrease with a half maximum effect of 2.5% and a maximum effect of 5%. Why is this so important? Because N2O has been used for surgery, is absolutely safe. There is no problem to use it, but above 30% can explode. There's an explosion risk, and that's the reason why N2O was never used in the operating theater. However, if you use 5% or 10%, you have maximal effectivity and you are way below the risk of having an explosion. And you see, of all factors which we tested, nitrous oxygen is by far the best. This was an experiment by adding blood and counteracting the effect of blood. How effective is this? If you have the same experiment, mice, you let them with the abdomen open, desiccation and so on, and you have adhesion formation, 20 minutes, or 30 minutes, 60 minutes, let's say with desiccation, 100% mortality. You can reduce this by adding humidification. But look at this, and then you have co-culture with oxygen. That's something, it's significant, but it's not very important. But if you add nitrous oxygen, you have absolute no adhesions. So this is one of I think, the most important, the strongest effect. Nobody understands very well why. It's a patent by Professor Adamian and Karina Malova, because it was basically a Russian idea from Osman Mimbayev, because he was doing these experiments using N2O, because at that moment you needed less anesthesia. And in rabbits, he was not able to have adhesions. So that's where the idea is coming from. We know that blood is adhesogenic. But the important thing for the surgeon is that blood cannot be washed off. This is the reason why but there are no randomized trials and the evidence is not that strong. But I think there are good arguments, certainly if you do fertility surgery, to add a little bit of heparin in the irrigation liquid, because at that moment you will not have any kind of fibrin. And the practical thing for me, when I start surgery, I begin by putting 200 milliliters of Ringes lactate in the patch of Douglas. This means that if there is some bleeding, the blood is going to get in the Ringes lactate, and the fibrin is not going to be attached to it. It's not going to be attached to the mesothelial cells. And then you see dissection surgery today, they say, do not rinse. There's no contraindication between rinsing and preventing the fibrin to be adapted. And then you see that after surgery, this is also important. If you have conditioning, you have a very strong effect of dexamethasone. You have an additive effect with barriers. And if you leave Ringes lactate, how long does it stay? 24 hours, 48 hours, very well demonstrated. But if you leave for 24 hours, after 24 hours, the crucial moments of adhesion formation, at that moment, it's much more important. So in conclusion, the speed of fibrinolysis is the tissue, blood, suture, infection, and then everything what I try to explain. You in the peritoneal cavity, pressure, microcirculation, ischemia, reperfusion, superficial hypoxia with time, desiccation, gentle tissue handling, the surgeon. Which means that if you want to go to no adhesions, add 4% or 10% of nitrous oxygen, cool to 30 degrees, which means room temperature, do not heat the CO2, no desiccation, which means no leaking, or a humidifier, throw away saline, and at the end, for fertility surgery, which is not that important, I would say use dexamethasone. And maybe add a little bit of heparin in the irrigation liquid. With this protocol, we were able to do these experiments where you have less adhesion formation, virtually adhesion-free surgery. And it's not only adhesion, it's logic. You have much less pain. You have a much lower C-reactive protein at the end of surgery. The nurses in the hospital say, don't tell us who got it, because we see it. Most of the patients were independent day one. They wash themselves. The others are still in bed. Their first flatters 1 day earlier than without this. So this kind of what we call conditioning is something what should be used in all surgeries. And there is another thing which is very important in this trial, is the resorption of CO2. You know, all anesthetists know that they have to ventilate more when surgery gets longer. And this is certainly after 30 minutes, after 60 minutes, it began to start. Certainly important after 2 hours. And a lot of surgery for deep endometriosis, for instance, it's quite often up to 2 hours. So it's very oncologic surgery. This is the reason I'm going to explain this, that when you have to do pancreatectomy, Whipples, with surgery of 6-7 hours, at that moment, it becomes very important. So we did other trials for this. You can do laparoscopy with local anesthesia if you have 10% of nitrous oxygen. I have done thousands of tubal sterilization local anesthesia. You can do it similarly with 10% of nitrous oxygen. There was a trial on myomectomy, less pain, less painkiller intake. There is a laparoscopy with the Whipple. Most of the Whipple surgeries have to be stopped if they take too long because of CO2 resorption. Disappears when you have conditioning. There's a trial on bariatric surgery and open-free anesthesia. Results still to be published to have less adhesions. And I said in the beginning, if you have this kind of basal membrane directly accessible, you're going to have less implantation of cancer cells. Very well demonstrated in mice, where you see that you have less tumor metastasis. And this is one of the papers which we wrote. It was an editorial that the LAC trial, where for the severe cancer, the radical cancer surgery, it seems to be better with open surgery, less adhesion. I think it's mainly a story. My hypothesis today is a problem of conditioning. So in conclusion, for adhesion, you have to individualize risk, vaginal infection, vaginosis. You have to individualize, take care of blood and fibrin, throw away saline and use Ranger's lactate or another better liquid, prevent desiccation, throw away the warming. It's better to have cooling, to have an abdomen, and we know very well that you cannot cool the patient by cooling the abdomen. If the patient is cooling, and the anesthetist tell you patient is becoming a problem to keep the temperature, it means you have desiccation. Cooling of the patient is desiccation. It's not temperature in the abdomen. Add 10% of nitrous oxygen, and then be a good surgeon. A good surgeon is gentle tissue handling and a fast surgeon. The longer surgery takes, the more adhesions you're going to have. Use thinner sutures, especially if the knots are safe. At that moment, you can use thin sutures and cut the tails very short. And then also for anesthesia, opium-free anesthesia, what I think is going to be the future. And with this, you are going to not only prevent adhesions, but you are going to prevent also postoperative fatigue. Thank you for your attention. This was a small summary. Thank you, Professor Adami.
Dear Professor Philip Konings, thank you so much for this lecture. We have several minutes, some probably 15 minutes, to have a talk to you. Tell me, please, what operations other than endometriosis or no endometriosis stand as number one, rank as number one in terms of adhesion formations? What are they? Are they endometriosis, myomectomy? What other operations are dangerous in this regard and are risk factors in terms of adhesions formation?
Профессор Тоц.
Professor Totsi, would you like to join too after Professor Koning?
15
but-
минут
We
дискуссии.
have 15 minutes for this discussion. Thank you.
Diseases are very variable, and this is the problem you cannot predict in the individual patient. The group of Van den Broek in Nijmegen, we wrote recently a paper with nomograms. So we try to predict in the individual patient, but I think it's mainly genetic. Also the adhesion formation, you have strains of mice and rats which have very adhesogenic and odorless. This is something, if I would be young, I would look at the genes. I heard the first speaker this morning, my friend Totsi, saying we have to know an idea about the genetics because we have inbred strains. We are so similar, but still inbred strains with a lot of adhesions and no adhesions. So then we can find the gene. The day we can find the gene, we can predict who is at risk. This is for the near future. But today it's for all surgeries. And the longer it takes, the more important it is. And then, small remark, open surgery is worse for adhesion than laparoscopic surgery. Because in air you have 20%. And 20% of oxygen in air is much too much. It's a partial pressure of 150. And we have to go down to 30. So open surgery is worse. Laparoscopy is better. In laparoscopy, it's easier to add N2O. Open surgery to add N2O is more difficult.
Профессор Тоц.
Professor Totsi, are you with us or are you still online with us? Would you like to join us?
Скажи, пожалуйста, дорогой.
Tell me, please, dear Roberto, what operations do you think the highest risk factor are for adhesion formation? We have some 15 minutes to talk about adhesions. Adhesions, which kind of surgery or which kind of disease, when we operate on patients, would produce most adhesions?
Leila, thank you. First of all, let me say congratulations to Philippe, who is amazing. And he says he's not young, but clearly in his speeches, he's younger than any of us because he's always innovative. He's always bringing new ideas, and it's always feeding our brains to think about what we do. So so he's done a magnificent lecture and very little to add. With regards to what I see, clearly, I think that the key issue is the inflammation. Like there is a patient who already has an inflammatory milieu, like an inflammatory pattern, is very prone to form adhesion. With regards to cancer surgery, it is extremely important to understand that adhesions are not only a problem of quality of life and pain, it's also affecting survival directly. Because if you have adhesions and they will have to have radiotherapy afterwards, the bowel will be stuck, will be less mobile, and therefore it will be getting more radiotherapy. So for these patients, what Philippe was saying is even more important. So for cancer patient, you have to try to reduce adhesions as much as you can. And one way, clearly, is using laparoscopy. So that is one of the reasons why I am so much insisting on the use of laparoscopy in cervical and ovarian cancer, because these patients will have adjuvant treatment. These patients will need adjuvant treatment to survive. And the level of surgery you do is something that they will be scarred for the entire life. So if you do good surgery with fewer adhesions, they will have a better outcome, not only in terms of quality of life, but in actual survival rate. So I think I can't agree more with what Philippe said. And therefore, I think that inflammatory surgery with an inflammatory background are most prone in the cancer surgery to develop adhesions.
I fully support what you say, but all things being equal, how does genetics come into play? Is some genetic background behind it? We perfectly know sometimes several patients who you operate 1, 2, 3 times on these patients, no adhesions at all. Whereas other patients, where you do a painless, smallish operation, a very good operation, but she would develop an ileus due to adhesions, no inflammation in this patient. Are there other factors that come into play that have to do with family history, with genetics probably? We work a lot, but it's impossible, of course, to do a prediction, to predict for 100% who would develop adhesions, who won't. It's clear that one has to observe main technical principles of microsurgery, yes, precision of operation, humidification of tissues, microsurgical approach, good suturing material. All these are basics. They are for sure. At least we are confident that this is. What else? What else? All other things being equal. Please, Professor Tozzi, what's your take on this?
I think that one thing that has to be pushed. I like to say, like Philippe said, that there is a genetic predisposition, and I agree that some patients will develop adhesions no matter what. But there's one specific thing that I will take from Philippe's lecture. Why is it laparoscopy better than laparotomy? There are two things to it. One, clearly the less exposure to air. That is clear, no doubt. But there's a second thing, and that I've learned. I myself learned to be a laparoscopic surgeon before being a laparotomic surgeon, and that has improved my surgery a lot. Why is this? Because at laparoscopy, you cannot afford to have small bleeding. So you have to do preventive coagulation. So you have your dissection is preventing any bleeding. And it's not because of the bleeding in itself, which is of course important, but it's because your vision, you have to have a clear vision. So if you want to be a good laparoscopic surgeon, is one that has a clear field at all times, because as we know, the red catches more light. So it will impair and will diminish your vision. As a secondary to this, you will have less small bleeding. All these little small bleedings will be caused for adhesions. There is very little to say. Adhesions are also a reactive process. So if this bleeding have to be taken care by macrophages, by monocytes, they will recruit fibroblasts and they will cause adhesion. So I agree 100% with Philippe on the fact that laparoscopy is better. But the reason for it is because we are, and I'm not saying because we are laparoscopic surgeons, but we are better surgeons in that we have a different type of surgical approach, which is preventing any little bleeding. At laparotomy, if you have a bleeding, you cut and then you coagulate. If it's bleeding, then you coagulate. At laparoscopy, it's the opposite. You coagulate and then you cut. At the end result is that your field at laparoscopy is beautiful. Most of the time, you have very clear field, and that will generate less adhesions, fewer adhesions.
To confirm what Roberto said, but think also in laparotomy, manipulation of the bowels. We never thought that manipulation of the bowels would cause adhesion. Just grasping, manipulating what you do, all this is causing adhesion and depressing fibrinolysis after surgery. It's the second reason why laparoscopy will cause less adhesions.
Dear colleagues, a question to both of you, please. Tell me, please, so much science against anti-adhesion barriers, so much science. Intercede, fibrin glue, and many, many others. Professor Tozzi, since I surely know what Philip thinks about it, may I ask this question to you, Professor Tozzi. And Barnovatiers is also online, has joined us, and it's so great. What a wonderful team to have in the early morning. Thank you for this pleasure. What anti-adhesion barriers do you really think that they work? What would you like to appreciate? What you like best among the barriers, or they are non-existent? What's your take on this? Roberto, what's your take on this?
I have used most of them for many years, and I don't have a winning solution for this. We usually rinse a lot at the end, and rinsing a lot, and we leave water in the cavity when it's a clear field. But I'm afraid I don't have a winning answer to this, of one method that is better than the other one. So no, I don't think I can contribute much to this, as in having one winning card. Sorry.
Дорогой
Dear Philip, then the floor goes to you as the grandmaster in adhesions. I know what you'll say, conditioning. Well, it's clear. We fully support. But what barriers in your way did you meet them? And what do you think works best? What do you think really works as a barrier to prevent adhesions? Please.
I would give an example and make a compliment to you. You look marvelous today. But it's not only go to the hairdressers and not having a little bit of makeup and not having a nice dress and it is all that together. This is the total picture. For adhesions, it's exactly the same thing.
спасибо.
Yeah, the barriers you decrease with 50%. With this conditioning alone, you can decrease up to 70, 80%. The two together, you go up to 95% or more. So it's not what is the winning solution, it's all together. And I would say this is life. You do not, this is the wrong things. This is also what we discussed about Bayesian thinking. We do not surgery because of pain and separately for the dimension and for the clinician does this for all factors together. But this is not in research for the simple reason that you cannot do a randomized controlled trial with 5 different factors at the same time. This is not realistic because it needs too many groups. But the clinician, he uses all these factors together to make decisions, to take decisions also to do surgery. This is clinical work, which I think is very important. It's very different from research. All.
У меня
I have a question to all of you, to all the three of you, to Roberto, to Arnaud, and to Philip. This is a question to you, dear colleagues. How far should you go in terms of dividing the adhesions? Not in terms of indications for operations. No, okay, you enter the abdominal cavity, for some reason or other, you're operating, be it myoma, cyst, or whatever. But look, there are a lot of adhesions. You have to remove them all the adhesions. Is that your take? Or do you think some of the neutral, leave them? Let's ask Arnaud first. Arnaud, what would be your approach? You enter the abdominal cavity when you operate on a patient on whatever disease, be it myoma, cystoma, endometriosis, you name it. And you see in the abdominal cavity a lot of adhesions. Which adhesions you think you will necessarily dissect? And others you say, oh God, leave them alone. Let them be. You don't have to chase them. You may leave them in place. What's your take on this, Arnaud?
Well, I think this is first of all, good morning, everybody. I think I'm quite lazy person. So you have two very clear examples. First example, you do whatever surgery for, let's say, a myoma, and you find on the right side a lot of adhesion with the cecum because the patient got an appendectomy. So obviously we never touch that, except if it's on the way of the trocar, or except if the patient clearly described preoperatively pain on that area. So we don't normally. I do not touch adhesion that do not interfere with the life of the patient, one, and two, with my surgery too. So I mean that now, if I have a curtain of adhesion in front of the uterus I cannot access, I will do the adhesiolysis, but I do the minimum possible according to the symptom of the patient.
Well, I fully support Arnaud. If the adhesions do not stand in your way when you operate, you do the main operation. Otherwise, you could spend for hours on end trying to remove all the adhesions. Adhesions tend to recur if they are there. And in this case, maybe there is no need for that, immediate need. Philip, 1 minute for you to go. How many adhesions do you remove? All and everyone that you see, or some selection?
That's a very difficult question where we do not have good data. And microsurgery, Victor Gomel said 30 years ago, adhesions you have to excise, you do not have to do an adhesiolysis. You have very nice data to say that the fibroblast inadhesions are already a little bit different. That's why I think that the future is going to be to excise adhesions rather than just adhesiolysis without causing more trauma. But this is not so clear. For this whole morning, if everybody would remember at the beginning of surgery, instill 100, 200 milliliters of rinses lactate and decrease the pressure if you can, I think you already have dealt with 30 to 40% of adhesion formation, as much as you would have by using an anti-adhesion barrier at the end of surgery.
И последний вопрос.
And the last question before our Novatiers will show us your procedure. Endometriosis. For example, retrocervical endometriosis, or there is a cyst, and we see millions of endometriosis on a diaphragm, somewhere else. What should we do with this foci of endometriosis? Because if we remove all the foci of endometriosis, which do not cause pain, but we do not know if they cause pain or not, how deep should we go and remove all the foci of endometriosis? I have my own answer for this. Please, you both answer this question, or no?
Yeah, this, alors we tend, alors I understand your question. Alors obviously, when we find we find small foci of endometriosis on a patient which has surgery for another reason, logically, I think we should not touch, but we always remove them or coagulate them. And so that's why the problem is that the anamnesis of the patient is always focused on the pathology you go for. Let's say patient has myoma, so you are discussing heaviness, menorrhagia, metrorrhagia, eventually infertility, but you don't discuss eventually pain or etc. So you come inside for myomectomy and you find some foci of endo. Alors, if the indication is infertility, okay, fine, you remove the foci because you say they may interfere with fertility. But if the indication is menorrhagia, you know, the question is why you should remove the fossa, except that maybe your anamnesis has been incomplete and patient has some pain that you do not, is like the story of the diaphragmatic foci of endometriosis. Most of the time, people do not ask clearly to the patient if she has some shoulder pain cyclically. And so you come, you see diaphragmatic lesion, and you don't know because the patient, you don't talk to the patient. So if the patient has diaphragmatic lesion and no pain, should we remove them? And I think the answer is no. But are you sure that you ask the proper question to the patient? And probably again, the answer is no. So that's why I would say do not undertreat and do not overtreat.
Dear Arno, we will continue this discussion. My answer to this is the following. First of all, we should do our own surgery, our own procedure, for which the patient signed up. Otherwise, we can go too far. Second, as you said, if she has surgery for infertility and there are foci of endometriosis and they are unexpected and there are indications for myoma, so we should remove those foci that can be removed. They are visible. But what is also important is that when we remove them, we should not cause in this process any additional bleeding or any additional complication. Sometimes they can be too far, near the ureter, in the diaphragm. I think that's the right position, that's the right approach. Over-surgery, hyper-surgery is not justifiable because any surgery, especially hyper-surgery, can cause additional complications. How can we explain it to the patient that has no suspicions that she had such endometriotic foci? Philip, do you agree with me?
Yes, I would like to add two small things. What Arnaud said is basically can ties down to asymptomatic patient with endometriosis. The endometriosis should not be treated. I think we all agree that the deep nodule, no pain, no symptoms, don't touch. But when you go for the superficial endometriosis, we know that if you have 10 lesions, only 1/3, 30% is going to be painful, 20%. 1 in 5, which means that there is 1 to treat and 5 to leave alone. But we don't know yet. We cannot see which are the bad. So maybe with someday with spectroscopy, whatever, maybe you are going to see which are the bad lesions. Fertility. I do not think that we have one argument that superficial endometriosis causes infertility. It's a dream, it's a dogma. There are absolutely no data, and we have good argument, I think, today to say it's not true. Randomized trial, it's not better afterwards. It's different when you have a cyst with adhesions. This is causing infertility. But also for infertility, you do not have to remove the adhesions on the diaphragm and so on. So it's the two things we have to understand, and then we know what we have to do. But I fully agree with you. This is the clinician, but the clinician comes after the randomized trials. You have basic science, and then you do trials in medicine, or randomized trials, and we know one aspect. And to integrate all this and to turn this into practice, you have the clinician. And this is what we discussed so many times, the experience-based medicine. It comes after the evidence-based medicine. It completes it.
Спасибо большое.
Thank you very much. And we move on to Professor Arnaud Vatiez, who is with us today. And he is our colleague. This is our international course on endoscopic surgery. And I would like to ask Arnaud Vatiez to start the surgery, introduce the surgery, the patient. Well, post-operative niches, that's the subject. I call post-operative niches diseases of the uterus which had been operated on. Professor Vatiez, please.
Thank you, Leila. So I wanted to show it live, but unfortunately for reason here, I couldn't have this patient today. So I will just start to explain a few things, and then I will show you a live case, and I will comment it. So it's what we call a pre-recorded live surgery, which, by the way, start to be the trend. Because, as you know, we have more and more problems to do live surgery. And at some point that some hospitals now do not allow people to do live surgery. So I think it's a bit bad, but maybe we are going to move more and more on pre-recorded live surgery. I share my screen, and I will start by few data before I show you the movie. I integrate my movie in this. I will show you 5 slides, and then we move to the live surgery. First of all, I mean that what is important to know is, so this niche has different names. So, and mainly we have to understand if we talk all about the same, from isthmocele to Caesar scar dehiscence or Caesar scar defect of uterine niche. So as you said, they are visible in quasi all patients that has got a Caesar section, and that doesn't mean that like the the famous foci of endometriosis. That doesn't mean that you have to remove all niche that you see, but mainly we have to understand which one we have to operate. So here on this picture, you have a magnificent large niche at hysteroscopy. You see that you are at the distal part of the cervix. You have the niche in front of you, and down you see the entrance on the inside the main cavity. So this is a niche, and mainly you see that the structure is a bit. So why niche becomes so popular? I tell you a number. We started to do niche here, very few years ago, and actually we are reviewing our cases, and almost we reached 200 patients. And so it means that we do niches every week, and that's why when Leila, you asked me to do a niche live, I said no problem. We have a ton, but unfortunately, it didn't work like this today. Alors, why it is like this? It's that when you look numbers, if you have one Caesar section, 20% of the patient has a niche. If you see two, is 61, and if you have three, you have 100%. So it means that here, for example, in the Middle East, the rate of Caesar section exploded, and we have quite a number of patients with 3, 4 previous, 5 previous Caesar section. So, and the niche is not only the pathology that we create with these habits, we have a lot of problems. So I want to show you this because you have different type of niche. You see this one, and I don't see my arrow, but if you look at the niche, what is important when you want to make a decision on how you will repair it? You can do it by hysteroscopy, you can do it by laparoscopy. So you have first to know why you do it. And the second thing is to know what is the thickness of the proximal part of the niche and what is the thickness of the distal part of the niche. Because if you have a non-congruence on the two thickness, it's very difficult to repair by laparoscopy, because let's say if you have to suture a thickness of 5 millimeter in the thickness of 15 millimeter, you understand that it will be a defect, remaining defect, and you have to talk to the patient. And so there, we look at the different aspect of the niche, and we have published with Dr. Bidaya a paper with this. So it has been said that you have a lot of different tissue inside the niche, and the two main findings were endometriosis and adenomyosis, and the other thing was elastosis. And so, but unfortunately, when we look, it's a kind of very different pathology, and it's very difficult to correlate one pathology with the symptom. That's why the situation is difficult. So symptoms are there, and most often we have post-menstrual bleeding or spotting, and this is the main symptom. But we may also have dysmenorrhea and chronic pelvic pain, and we may also have dyspareunia, even though it's difficult to correlate with the niche. Now, the most difficult part is to understand and correlate infertility with niche, because most of the referral that we have today for niche came from fertility center that ask us to remove the niche, telling that the patient collect liquid into the cavity, which interfere with the implantation of the embryo. And then you have obviously the obstetrical problem with the niche, possibly, which are mainly scar pregnancy, accreta, percreta, and ectopic pregnancy. So which niche we have to treat? So I think the symptomatic are easy, symptomatic in terms of discharge, vaginal discharge of any kind, more difficult for fertility, and we have two ways to treat them, is either by laparoscopy or by hysteroscopy. And I try to skip those results to move to some detail. So obviously, if you do hysteroscopy, is the least invasive, It's easy. So you have different technique. You have to resect the proximal edge. Some people resect also the distal edge. Then you coagulate or you resect the fundus. That it means that's why people speak about remnant myometrial thickness as a limit to do. So now we use 3 millimeter. So if the thickness is less than 3 millimeter, we don't do hysteroscopy theoretically. And you have some people like Attilio Dispiesio that resect not only proximal distal, but all around, so around the anterior and posterior surface of the niche. I'm not sure it's correct, but this is what is done. And they publish a very good result in terms of symptoms, an improvement of symptom type bleeding up to 100%, and fertility rates or pregnancy rate quite very high, around 80%. So I think that that raised the fact that mainly if you can do by hysteroscopy, probably this is the first choice, and laparoscopy should be reserved to cases which are more larger or more with a remnant myometrial or remaining myometrial thickness very, very small. So niche repair has been described first by Jacobson in 96. So you see it's very recent. It's less than 25 years or 30 years at least. And then you see a lot of niches published. And recently you have this paper of Olivier Donez that's showing the good result on his technique. Alors, laparoscopy, because this is the subject and I want to go to the technique. So we do it most of the time for large niches, retroverted uterus associated, RMT less than 3 millimeter. And so this is mainly our indication. And what we do, we are thickening the wall, reinforcing the wall, and we also have very good results. So let's go to the live case. So this is a case. So we start by hysteroscopy with 2 goals. One goal is to identify the niche, and the second goal is to see by laparoscopy, with the light of the hysteroscope, where the niche is. So here you have a typical case with a very low LMT and with a retroverted uterus. So I think that those two aspects have to be correlated. And the most difficult part first is to dissect the bladder, because obviously this patient got at least one, but many times more than one CR section. And as usual, we start by opening laterally. We don't try to affront the problem in the front. We try to see laterally with the hope that if you go lateral, you will find easily the uterine artery. And then you can go to the other side following the peritoneum. So here you have no risk for the bladder because you don't try, and you are going to open the contralateral laterovesical space. So meaning the space of you have to look at the fat. You see, we always look at the fat. And then when we see the fat, we know that we are reaching the medial part of the paravesical space, and then we dissect. We dissect on both sides. And if you can identify the vessel, you can identify the vagina. So what we can try to do, you see, we try to see if we can reach the vagina on the side, like we do when we do an hysterectomy after Caesar section. Then after it's a mixture of skills and also experience, and that I know that Philippe lack experience, but for example, you can, if you are experienced and you are not afraid with the bladder, which is my case, because you see the bladder very nicely here. So my case, because when you do endo, and we do a lot of bladder endo, so we are used to open the bladder and we are used to repair it. So I'm not very afraid by bladder injury, but nevertheless, you always have to try find your landmarks. Like here, you see immediately, here we see that the fiber of the bladder are very adherent. So I try to find behind, okay? And when I have some information, I may continue to cut, and as long as I am confident, it's fine. And you see, and this is a live case. So I mean, you will get all the bad aspect of the life, the smoke, etc. Now you see that one of the difficulty of this, and that's why sometimes you have to, because we start by hysteroscopy, and unfortunately we cannot push on the uterus with the scope because we have a risk of manipulation. And I don't like to put a manipulator because then I make some injury to the mucosa and I have some bleeding which perturb the hysteroscopic time after. So here we have found the vesicouterine space. So what you have to pay attention to is laterally, the uterine arteries are very close. So you will be surprised to see that Caesar section, make the uterine artery to be very close. And then we come back with the scope, with the light of the scope, and you see that with the light of the scope, we identify the thinner part of the niche. Alors here, this niche is quite high. Most of the time is a little bit lower. So you identify the thinner part where the light is the maximum. And I cut always few millimeters above this thinner part. We keep the water and the light open, and we start to incise until we will see the water spilling into the cavity. It's a very easy technique, and there is nothing difficult here, as you understand. So you see the scope become very light, the light become very strong, and we are going to open at some point and see the water coming. Well, water is coming now. So when the water comes, you have to close the light, you have to stop the water, and we are going to open largely the upper part of the niche. And this is where I introduce a little technical tips, is that I will enlarge fully my opening, and then I will stereoscope with a Foley catheter. I think that this is very interesting point because so here the assistant will manipulate the catheter. So we are inside, you see, and we are going to replace the rigid hysteroscope with a Foley catheter. Why? Is because we are going to keep something in the cervical canal and isthmic canal. So we have no risk we have a landmarks. And then we are still going to be able to open the uterus like a book. You see, it's very important to resect fully the niche. The niche may be very, very, very large, and you have some bleeding on the side. So try to minimize the coagulation. So take the washing and try to coagulate precisely, pinpoint effect. So you see, so this is the Foley. And I help the assistant. The Foley goes in the cavity, you see. We are going to inflate the balloon. And now you see that we have this guide in the canal, but we still keep the flexibility of the uterus. So I can push the uterus posteriorly and see the anterior aspect of my niche and be sure that I have resected totally at the distal part. And then now I will resect the proximal part. And so this is easy because you do it in control. So, I mean, again, pay attention here because you may have the uterine artery or branches. So you may have bleeding, it happens. And so you have to coagulate. So better to be a little bit precise. Voilà. So, and very gentle with, or you can do with a knife, we have done that with a knife, but with the knife, so many times we cut the Foley catheter. So we stop. So we use this energy, which is easy. You can use, I suppose, harmonic. You can probably use scissors. Okay, and step by step, we remove the niche under vision, and you have to be complete. And you will see that it's interesting because here we are going to try to adapt the thickness of the proximal to the thickness of the distal. And so to do that, if we don't have enough thickness, what we do an oblique incision. So we do an oblique incision to gain distance, you understand? So if the lower aspect of the niche is too thin, I will do an oblique incision. So my incision will be oblique in the craniocaudal direction. So I will enlarge the thickness of my proximal edge. I don't know if you understand what I mean, but it's very important, because if you don't do that, you cannot repair it correctly. So you see that we are really out of the niche. The niche is fully resected. Don't lace any niche, and then do the hemostasis, and then it's fine. So if you do this superficial one, is okay. But if you have remaining bleeding, don't take the whole thickness in your bipolar, just do pinpoint effect. Okay, we come to the channel. I didn't cut anything. This surgery lasts for 30, 40 minutes, max 30 minutes probably. And then, so this is the most important part. And with this energy, you can even cut against the foley, and it's okay. So I have this window here. I will change. Okay. So, and we continue the resection. So here we have resected fully, and you see it's very important. Fully the lower aspect, fully the upper part, and we are going to do now the left side. It's a very fibrotic tissue. That's why you have to get forceps with this. Okay. I guide my assistant because it may be a young fellow, so they are not yet very experienced. So, don't cut inside the channel, because otherwise you have a risk to create a synechia, and so it's better it's even better to make a recut at the end if you don't cut enough, but it's better to be prudent. It's very a functional surgery, so you have to remember this. It's a functional surgery. What you want the patient to achieve her goal, which is to get pregnant. Okay? Most of the time. So here, I cut the niche, and I will see if I have to recut the left corner. And we accept a minimum bleeding because it's good for healing to have this. And we keep the niche in the place so we can extract it at the end for pathology. So here, obviously, I still have a piece of the fibrotic tissue here. So I will finish my cut. Okay, and we are going to be careful here. You have seen the small artery, and then maybe I will cut it. I don't know. Wow. Now you see, the trick is this. The trick is to have a flexible tool in the cavity to be able to flex your uterus to access. Probably we should have more traumatic forceps to catch it, because you see it's very fibrotic, very fibrotic. Okay, whatever, we are going to finish the resection. You see how the uterus is open. Huh? It's like a book, so you can access even in very remote places. I have a problem with the energy. I don't know why, but no, it's good. Be careful to the artery. Voilà. So it means that now the niche is fully removed. You see the branch of the artery here, and so you have to secure it. Voilà. Don't do too much. Try to keep the field clear for suturing. Voilà. So you have resected. You check. You may do a little bit of coagulation in the posterior aspect of the niche. I don't like to do too much. And then when you have almost dry, it's time for repair. What is important on this is look the thickness of the distal and the thickness of the proximal. We are very congruent. And then I use suture. I use monocryl 0, monofilament, with a big needle. This is a 36. It's important. And I will do mattress suture. And look, the fact that you can open, you can really take the whole thickness. So it's very important. So if you cannot take it first, you have to be sure to take it and to be as close as you can from the channel, like here. Okay, so you have the full thickness. And as you have this Foley catheter, look where is the catheter, and you see, you can reorient your needle correctly to have the proper angle, and you take also very thick, and that's why you still have to dissect the bladder correctly. So here I am not enough deep, so I will take a little bit deeper like this. Voilà. So this is important to have a large needle. You see, we take the full thickness and we do a mattress suture. So we come back with a thin bite on the surface, okay, and thin bite on the surface. So the principle is to use the mattress suture to be sure that we do not let any dead space. Alors, this is the right notes. So I do it extracorporeal, and I do not, so second tips, we do not close. We do not close now. I just cut the needle, and this part has been cut, and I give the suture on my assistant on the right part of the patient. So you see the first suture is not tight, is open. And I do the same on the left side. So it's not enough. Voilà, it's not enough either. Okay, now it's better. You know, if even you feel it like this, turn your needle. You have the famous flag technique that Armando probably talked to you. And we are going to do the same. And we are going to keep the suture also on now, instead this time on the left trocar. And we are going not to tight now to keep the full capacity of still opening the uterus and driving precisely your needle. You see the two sutures are placed. The one is from the lateral trocar on the right is the lateral trocar on the left. And now we are complete by the third suture. And this third suture will be in the center. So we are going to pass it by the central trocar, suprapubic trocar. And then we are going to pass it under vision. So three suture, right, left, center. So we come in the central part. So we do the introduction with 5 millimeter by backloading your needle holder, as you all know. And then we do the same. And so here you will see, you need really to open. You need to open the book, you see, to see where come. Theoretically, your assistant should take the distal part to make sure that you don't take the Foley. Don't take the Foley with the suture. It happens to me once, but I realize it, so I remove the suture and do it again. So since it happens to me, I pay very attention. I don't want to pass the suture in the Foley, and trust me, especially because we use silicone Foley catheter, you don't feel it in your hand. It's not hard. And so you see here, this is what you should do. Advantage of the Foley, you can reopen the scar. You can reopen the scar, and you can go at the edge. So that's why it's better that if your assistant does it. But my assistant this day was probably a young one, didn't know very much. And you pass your suture, deep bite at the edge of the Foley catheter, not in the Foley catheter, and thin bite. Okay, so we have placed our three suture. And we are going to go out. So to go out, I bend the needle, and we go. So now we have the three suture in place, you see, right, left, central. And I'm going to start to tie the central one, okay, placing the knot, if possible, on the proximal edge. What is important when you do that is your assistant, and especially when you have retroverted uterus, is that your assistant push the uterus anteverted to reduce the tension on your knots. So you have really to affront the knots, and you do the half inches as explained by Armando, 5 sequences, and especially because here is important suture, plus this is a monofilament. So be sure to not be in the loop like here. Go out and finalize. If you have a twist, untwist, okay, and cut. And you will see that that correct and do a very, very strong closure. And we always do an hysteroscopy at the end. And most of the time, there is not even any leakage from the tree suture, only because of the mattressed one. Then we are going to tie the left one. Okay, same, it's always good. So you have to be sure to affront. And again, theoretically, your assistant should lift up a little bit the uterus to reduce the traction on your suture. But again, I think that these assistants these days were not very helpful. It happens, okay? And what we do for the third one, never let your assistant to tie it, even if he knows, because you have to get the certitude that it's well done. So you will take back the suture. So you ask your assistant to reintroduce the suture inside, and you will take it. Voilà, it's reintroduced. Here he lost it, so that's no problem. You can take it, and you pass it mainly on the trocar on your side to suture yourself from left to right. So I mean that you are sure that you do a proper time. Okay, so the niche is corrected. It has been resected, identified, resected, and corrected. But you see that the uterus is still a little bit retroverted. So it means that we are going to get tight on the suture for the time of healing, and it's not good. So I will do, in that case, a second layer. Okay, I will do a second layer in that case. And you will see how I do that. I do a second layer that not only will reduce the tension, will put the uterus a little bit more in anteversion, and will reduce the traction on my suture for the healing. Alors to do so, I will use, when I do that, I don't do that always. To do so, I use Eti-bond, so non-absorbable suture. And you will see. And I put also 3. So I will just show you 2 and I cut. So we stay on time. I don't know where we are. 10 of time, if we are okay. Yeah, we have 5 minutes left for the video. It's okay. And so here I come. You see, this is a filament. This is a polyfilament Eti-bond. It's not absorbable. Huh? There is no problem for a future pregnancy. And then we place to cover the first. That's why you have to dissect the bladder. So you see, we take the thickness of the cervix under the scar, okay, and we take the thickness of the uterus above the scar. Big bite. You have to make big bite, huh, because you are going to pull. You will see that the result of this is quite nice. We control all our patients. After 6 weeks, we do an ultrasound, and then we measure the remnant thickness wall. And we are so far we are quite happy with not only the result, functional result for bleeding, but also for fertility. And we are raising anatomically because we see that the thickness of the wall, the scar. We never remove fully the mesh. So you have to inform your patient, because otherwise they may be disappointed, that very often you still have a small defect. And my understanding is probably due to the lack of endometrial lining at this level. And so you have to better to tell to your patient that she may have another lining, another small niches, but it will be totally asymptomatic. Voilà. So now you see that we do the first one. And you see that already the uterus start to take a better position. And then we do another one. When you tie, you have to pay attention to not cut the uterus, because it's a monofilament. So that's why you see here the assistant will pull, really pull to, and you use a pulley to avoid you see this pulley avoid that you cut the fibers. And then when you will tie, you tie slowly and your assistant should pull the uterus on your face. And you see, we cover the first scar fully, using the serosa of the uterus. You see, the assistant pull up and you tie slowly. First half inch is not tight, no issue at all. You bring the second one on the same leader. Okay, just be sure that you're on the same leader. So if you have a deduct, you look closely. You see, you untwist, voilà. And then you tie slowly. Voilà. So you see you are fully covered. And then you do the same. It's not tight yet because you are still. So you do a third one on the same leader again, and then you tie it. Right. So as long as you are not tight like the way you want, you have to stay on the same sleeping end. Okay? Then when you are okay, you cross and you intervene sleeping and active, and you tie like this. Okay, 5 sequences minimum, and then you cut. You see, be careful to untwist. Don't tie twisted thing because you don't achieve a stable knot. Okay. So normally we do 3. So here we have done 2. I think we do 3. You see, I do the other side. Well, I have cut this part of introduction just to shorten because. Alors, it's not a difficult technique. A part of sometimes the bladder dissection may be difficult. A part of the fact that you have to secure the same thickness on the proximal and distal edge, and you have to approximate the two closer. So this is the final result. So you see that the uterus has been repositioned in the better position, even though it's not fully anteverted. And we have no tension on the scar. The niche is totally disappeared. And this is the final vision of the surgery. So I have cut probably 10 minutes of this video. So you see the video lasts for something like 25 minutes. So total of the surgery is 30-35 minutes. Again, it's not a long surgery, providing that you use the small tip and tricks that I mentioned, because it helps a lot to ease the technique. So this is what I wanted to show you. So Leila, I think that I am on time.
Да.
Yes, exactly. Dear Arnaud, I'd like to say that was wonderful that you were in time, but the thing is not about this. The thing is that why did I ask you in particular to demonstrate this operation? Why? Because nowadays it's becoming a problem of the century. C-section, nobody knows who does it, where they do it, what are the indications, why do we see these niches rising, whether it depends upon the dysplasia of the connective tissue or maybe comorbidities come into play, whatever. That's why we had 2 PhD theses. One will soon be defended, 500 women with niches, and we have, very much like you, the same laparovaginal approach. And I would like to, so that several questions, Q&A, short Q&A session for this topic. Thank you so much. The first question, and I'm sure you'll give the same answers as I do. Do we always need to operate on these post-operational scars and niches? What are the criteria for selecting the patients for this operation? Who do you operate or who you do not operate?
But easy to answer, the one you do not operate. If you have patient that has completed their family, have no symptom and as a niche, you don't touch. But actually, this group is quite easy to define. Then more difficult are, easy to define, the patient that you may operate are young patients that desire procreation, not now, but eventually in the future, that got already 1, 2 baby and one eventually other baby later, and are symptomatic in terms of bleeding, discharge, spotting, etc. Those, if you eliminate any other cause of bleeding and you just have the niche, those also you can propose to operate, and you can propose to operate by hysteroscopy. Easy group also. The most difficult group for me is the secondary infertility, because it is very difficult to correlate strictly and easily the infertility with the niche. Alors, the fertility center, IVF center, when they do stimulate the patient, they observe that they find liquid in the cavity, but most of the time is during the stimulation. So that's why I tell them, do we have liquid in non-stimulate cycle? And the answer is most of the time no. So I say, in that case, why not to freeze the embryo and to transfer the embryo either in natural cycle or moderate stimulate or endometrial stimulated cavity. And in that case, you avoid the operation and you have obtained the pregnancy. And last, the very difficult decision is patient that wants to get pregnant and has a large niche with a very, very thin residual myometrial thickness, where you fear for two things: the risk of scar pregnancy and the risk of rupture of the uterus during pregnancy. And so that we do not have the data because it's very difficult, and Philippe will explain to you that we would need at least 300 cases repair versus 300 cases non-repaired to compare the outcome. So I think we start to have a clear vision of who we will not operate and who will certainly operate. And we have still in the middle, let's say, a shadow zone where indications are not black and white.
Dear Professor Vattiez, I practically profess the same religion as you do. Niche, if it does not, the patient has no complaints, no bleedings, no spotting, no endometritis, and the woman is not going to have babies anymore, well, let her carry this niche, let her live with this niche. The problem, of course, arises when and where all of a sudden she doesn't get contraception and then she gets pregnant within the niche. This is a very different story, a very different pathology. Anyways, she has to be told that given this niche, if she doesn't want to be operated on, and we're not keen to operate, we do hysteroscopy, we localize the situation, and in reconstruction, there's no need in reconstruction, in repair. You are quite right. The situation where the patient does want to fall pregnant, especially if she wants to get pregnant using IVF, and our specialists on IVF, they would never take up IVF patient, or we would not even stimulate. Anyways, they would not do embryo transfer. In this case, of course, we come to help them. And the operation takes very much, like you showed us. I just wanted to show you. I have here pre-recorded 2-minute film. It looks like you are operating or the other way around. Anyways, we first do 2 approaches: hysteroscopy, laparoscopy, then we identify the zone where the niche is. Sometimes there may be suture material detritus. We clean And if we have other comorbidity inflammation, then this is where we avoid complete repair. We would later admit the patient for further operation. This PhD thesis, which is now completed, we identified the indications of the thickness from the fundus of the niche to the myometrium. And what is the length, what is the width, what is the... But that requires a lecture in its own right, because it has to be, you have to leave residual diametrium beyond the niche. Ultrasound helps here, 3D, 4D. Woman should know that she has an operation ahead of her, and this operation should be done in the first phase of the cycle, 3 layers, to ensure that we repair the uterus. But this, again, I think is not enough either. Every woman should be properly informed that this is not really a cure-all. It is not a panacea. During pregnancy, she may see some situations because we cannot predict what sort of tissue she has, how it would repair, how it would restore. We do what we do. We operate on the patient. We do surgical coaptation. We repair the uterine wall. We prove it, amongst other things, using MRI and ultrasound with objective picture that we get. But we should tell this woman this is a high risk in case of future, so that she should not try to spontaneously deliver, or should do it together with us if she should want to do it. What is post-operational management of these patients? What do you recommend? Okay, you operated on the patient. Do you send her home to go to the reproductologist? Or do you also follow up on the scar if a patient fell pregnant, or maybe before the pregnancy? What is post-operation care of these patients?
The post-operative care is quite easy. We follow the patient and we ask the patient to not get pregnant before 3 months post-op, and we follow up by ultrasound to see if we have repair and how is the thickness of the wall all along the anterior wall of the uterus and the cervix. And then when we pass the 3 months, at the end of the procedure, we put some gel. You were speaking about anti-adhesion. We put some anti-adhesion gel inside the cavity, and we remove the Foley at the same time post-op, and we don't let the Foley. We replace by gel. And so far, we have done some probably 200 cases. I mean that I never have seen a stenosis of the cervix, and that makes me, by the way, a little bit amazed, because I thought that we will probably get some stenosis, but we don't. And then after 3 months, when we check and we have a good healing, good thickness, we authorize the patient to go for pregnancy, either IVF or spontaneous. And then she has a report of the surgery to produce. In my opinion, she will be stronger after the repair than before the repair. So the fact to repair the niche is not a risk factor for the pregnancy. In my opinion, is a benefit for the pregnancy. And so, but nevertheless, the obstetrician knows that she has had this, and I have no idea if all those patients should deliver by Caesar section systematically, or if we can authorize in certain conditions the try to deliver spontaneously. So I have no idea on that. I know that in France we are quite liberal in the try of natural delivery and being ready to do a Caesar section in case. But here, for example, in Dubai, they do Caesar section systematically.
Уважаемый
Dear Professor Vatjes, I didn't mention any, so to say, scars. What I meant to say that after operation care, after operation management, post-operation scar looks great, No strictures, I didn't mention that at all. What I did say this, it is exactly how do we follow up on this patient before we refer her to, say, what do you do within a month after the operation? Then we ask her to show up a month after the operation, we ask her to show up 3 months, but we allow her to fall pregnant in 6 months. And if it is another delivery and she has a delivery, it is the decision of the obstetrician where he has to take part. And we don't tell 100% C-section. No, we never say so. We just give a warning to the patient, so she should be aware of this, that it's not just simple, and she has to take it seriously. And post-op care, we also use gels, right? But do we believe that this helps? Well, there's no convincing data, as you realize, not available, unfortunately, but nevertheless, that's great. That's great. That in this regard we can help her. Dear Arnaud, thank you so much for being with us today. For 3 days in a row, this is fantastic. This is a gift for all our delegates who are listening online. At this time, yesterday, we had 3,800 people online, always online. This morning, when we started, 3,200 nowadays, 2,800 people. It's too early morning while the course is on. This shows great respect for us, a great compliment to you and to us all. Thank you. Thank you so much. Well, it's a pity that we cannot celebrate it in person sometime, go to the theater, go to a restaurant, but this time we'll come back. Thank you so much. We love you. We love you so much. Thank you. Dear colleagues,
Hello, Roberto.
Спасибо.
So lovely to see you.
Дайте, пожалуйста,
Every
дай
time
минуточку.
something to learn from you.
Да,
Always
дайте,
something to learn.
пожалуйста, клип.
Thank you so much.
Bye.
Bye, Leila.
Клип.
Thank you so much. Now we would like to have a video fragment on. Please have it on.
Дорогие коллеги, дорогой...
Dear colleagues, dear Professor Totsi,
Это директор департамента
Next to me is the Director of the Department of Medical Care for Children and Public Health, Helen Sheshko. She's a unique person. We've been working together for many years, and it's a great honor for me that healthcare and women's health here are in the hands of this wonderful person. Elena came to welcome us. Dear Professor Totsi, several minutes, and we will see you. Say hello to Elena, Professor Totsi. Can you hear us?
Good morning. Thank you for being here. It's such a nice atmosphere, and you join in very well. So thank you so much for being here. It means so much to us. Thank you.
Спасибо.
Thank you. Elena, please say a few words. Well, good morning, dear colleagues. Good morning, Professor Totsi, my dear colleagues, OBGYNs. Well, I'm very happy to welcome you all here at this wonderful International Congress. It's the third day already of this Congress, and it has been filled not just with professional presentations and lectures, but these presentations are unique, the speakers are unique, the participants are unique. And Leila Damian, I would like to thank you on behalf of the Ministry of Health. Mikhail Murashka, the Minister of Health, welcomed you here personally via live streaming. And it's not just an educational congress, it's not just a scientific congress, but Leila Adamian just determines the trajectory of development of Russia's healthcare as far as mother and child health is concerned, adolescent health is concerned, female adolescent health. Colleagues, this is a unique opportunity to discuss global trends in the development of obstetrics and gynecology, to discuss new technologies for diagnosis and treatment of gynecological diseases. Thank you very much, Leila. Thank you, Gennady Sukhik, the head of the Kulakov Center. He is the co-chairman of this Congress. The Kulakov Center has done a lot, and I would like to thank all our wonderful professors who got connected from different parts of the world, and I wish you good luck. Thank you, Helen. Thank you, Elena. Yesterday we had 3,800 people online. Just imagine the total number will be significant. 60 stars from other countries in the field of obstetrics and gynecology, surgical specialists, wonderful presentations, 3 days of live broadcast, live surgeries from different countries. Just imagine that. I'm very grateful to you so that we have this kind of alliance, practice, science, healthcare management, well, the project Reproductive Health, we're trying to do our best to achieve good results. And you also made a significant contribution to that, because it's much easier for us when the head of this direction in Russia is not just an OBGYN, but also a wonderful healthcare manager who treats all our colleagues with respect. Thank you very much for being with us. Thank you for your understanding. You are a government official, but you are a government official with a human face. So, Professor Totsi, Roberto, my dear Roberto, you have 30 minutes for your presentation. That's your first presentation. Then Mr. Puntambikar from India, and then there will be your second lecture. So, dear colleagues, it's a great honor for me to have in this audience Professor Totsi. We've been together to the operating room many times, and we worked in Italy Roberto Tozzi is the head of the Department of Women's and Children's Health of Padua University. He is the chief gynecologist in one of the major universities of Italy. He is a star in surgery. He carries a lot of authority, especially in the field of oncology. Roberto Tozzi will make two presentations today. The first one is called Radical Surgery in Patients with LACC, Surgical and Survival Outcomes, and after Professor Puntambikar, he will make another presentation. Well, radical surgery in patients with LACC, surgical and survival outcomes. And the first presentation, I'm sorry, is anatomic laparoscopy in today's treatment in patients with ovarian cancer. This will be the first presentation. I'm sorry. Professor Tozzi is not just a gynecologist and a surgeon. He is a mega star. Well, he can be in charge of a multidisciplinary team. He can perform any kind of surgery, whether it's a thorax, diaphragm, exoneration, etc. Well, this can be done by Professor Tozzi. So what's your first presentation, in fact? Professor Tozzi, please.
So good morning to all the participants, and thank you, Leila. It's always a dear pleasure to be with you. As I said this morning, you are one of the very few people in the world who can gather such a magnificent audience all together and all being very happy to be with you. So I would start with my presentation. Can you see it? No. Wait.
Yes.
Сделайте широкий экран.
Yes, we need a full screen. We can see the slides, but they're small. We need full screen.
Yes. Okay. Okay, there you go. So the first lecture is about ovarian cancer. And as I said this morning, it is a great time to be dealing with ovarian cancer in these years. So years ago, ovarian cancer was mostly treated with surgery and chemotherapy. This day, the role of surgeons has changed a lot. So it is a multidisciplinary approach, which is not only a theoretical stuff, it's something that is so practical. So we call this a journey, and it takes you from laparoscopy through genomics, finally ending in surgery. It is a transitional medicine journey in ovarian cancer. This is my journey, as you know, Leila, has been very long. I've been many places in the world, and journey has been consistent in my life. So this is the University of Oxford, where I've been 12 years. I've also consulted in Sicily while being in Oxford. I was doing a week a month with this beautiful operating theater overlooking the Mediterranean. This is where I am now. This is the Anatomic Theater of Galileo, the oldest anatomic theater in the history of the world. This is our Aula Magna, which is where we have the professorship is given. Going back to ovarian cancer. So as we all know, ovarian cancer is usually found in stage 3C or 4. That encompasses 75% of those patients. The standard of care has been for years, debulking surgery, platinum-based chemotherapy, and that has been for almost 30 years consistently the same. Most important prognostic factor was the amount of disease left behind. So optimal debulking, considered as no residual disease, has been the standard of care and has been the aim, the only sensible aim to achieve. This is a review by the Memorial Sloan Kettering, where they see the difference between 2 centimeter no residual disease in overall survival is tripled. So no residual disease is our aim. Nonetheless, these were the survival curves, very gloomy, as you see, at 60 months, very gloomy. These are our personal one, but they are not very different than what it was for others published in the literature. So this is the overall survival, slightly better, but as you see, at 5 years, we would have had possibly 20% of the patients being alive. Then in 2018, a new course, a new era started with introduction of PARP inhibitors. This was published in the New England Journal of Medicine and with olaparib being the first one. And this has changed dramatically the experience of patients with ovarian cancer. These are the curves now. Okay, so this is a very different scenario. We have at 60 months, we have 50% of the patient not only are alive, but they are disease-free, which is a fantastic achievement. We now have the 7 years outcome, the 7 years update, and still we haven't reached the median overall survival for the arm which is going into the EPARP. So that is extraordinary. So this ovarian cancer, which was a lethal disease, has now become, if not entirely curable, it's a very different prognosis, and we're all very happy about it. So these are things we have to be very familiar with. PARP inhibitors. What are PARP inhibitors? Polyadenosine phosphate ribose polymerase inhibitors. It's a type of drug that stops the PARP, which is an enzyme, which is very important in repairing mutation or repairing defects in DNA. So HRD, homologous recombination deficiency, is when homologous recombination is the most common system to repair double-strand DNA double-strand defects. And when the cell is deficient, it means that it can be exploited with PARP inhibitors. And then synthetic lethality is the mechanism which is supposed to be presiding on the functionality of PARP-E in HRD patients. So this is the vocabulary that we all have to be very familiar with. So dear Leila, as you see, it's not only surgery, we have to know a lot, and we have to know all the time a little bit more. That's our platform. We have created a platform for ovarian cancer, dedicated to ovarian cancer, which, like the hobbits in the Lord of the Ring did a long journey to Mount Doom, we have to do the same to finally deliver the ring and manage to treat ovarian cancer more successfully. So what are we doing in this? And this is a platform for ovarian cancer, which includes 7 different groups. So we start with an exploratory laparoscopy. At the exploratory laparoscopy, we do multiple biopsies, not only for histology, which is very important, but to calculate the GIS, genomic instability score. What is the genomic instability score looking at? It's looking at BRCA, HRD, immune microenvironment, CRS score, CD3 immune phenotype. So the pattern of lymphocyte invasion. This part is extremely important beyond the histology, because it will tell us which is the right weapon to use to treat ovarian cancer. So next thing we do is extract, based on the immunophenotype, we extract the TILs, tumor infiltrating lymphocytes. And that is an aspect not only of research, it has direct clinical implications. So it is very relevant. We do spatial transcriptomic. I'll take you through what spatial transcriptomic is, and tissue and organoids. And finally, we do the organoids. Organoids is an in vitro system that perfectly mimics what happens in vivo. So from here, we can create the patient own organoid on which we can test chemosensitivity, do spatial transcriptomic, and also test the immunoinfiltrate. And those patients, we then do the ultralap, which is our clinical trial, which we'll discuss in more details later on. It's a laparoscopic trial of multivisceral surgery in ovarian cancer. And finally, 2 new chemotherapy protocols, which we have devised and are now subject to business plan and ethical approval, which will probably help patients with ovarian cancer even more. So very quickly now, chemotherapy response score, very important to understand in patients who have undergone neoadjuvant chemotherapy, what is the best result. So which are the patients that are meant to have surgery first. This is the original paper. This is the type of response. So a CRS1 is no or minimal tumor response. CRS2 is appreciable tumor response with viable tumor, and CRS3 complete or near complete response. So this is based on the fibroinflammatory changes and on the presence of tumor in sheets, streaks, or nodules. So based on this pattern, the anatomopathologists, the pathologists can tell us which patient have responded best to chemotherapy. So it's not only no longer anymore just chemotherapy response, yes or not, but it's the type of response that matters significantly. Tumor infiltrating lymphocytes. We have this, since this classification was brought in, we assess tumor infiltrate lymphocytes in solid tumors. And there is now a standardized international immuno-oncology biomarkers working group, and which we have been part on ovarian carcinomas. And we determine the type of inflammatory infiltrate, particularly with infiltrating lymphocytes. So we have classified tumors based on the type of infiltration in cold, excluded, or hot. Hot are the one we're most interested in, because it's the type of tumor in which T cells infiltrate the tumor epithelium. So not only the stroma, as in the excluded, whereby the infiltrates is only in the stroma, but these are going into the epithelium. So this is the type of classification that we're counting on. And why do we do this? Because, as you may know, immunotherapy has been particularly unsuccessful in ovarian cancer. We're now trying to understand why this is. There is a lot of immune response, there's a lot of inflammation, and we don't understand why immunotherapy hasn't worked. So that's one area we're working on. So this is, we do it before chemotherapy, after chemotherapy, and this is the sort of area we're going to check. So we do an extra staining for immune infiltrate in the inflammatory, in the tumor microenvironment. So this is the change, how it is before and now after the chemotherapy, and that will address our next course of treatment. Immune therapy comes into the picture again in ovarian cancer. Finally, patient-derived organoids. So patient-derived organoids are an ex vivo active model. Why do I call it active? Because it's actually the most reliable and sensitive and trustful system mimicking the in vivo environment. So what we do here is there is a disease model, and then we had a patient-derived cancer scaffold. To have to study what cancer does in vivo, it is imperative to check, to replicate, to mimic what happens in vivo in vitro. So once we have that, thanks to tissue engineering and disease models, we can study the cell-environment interaction, study the cancer development, and of course, studying drug screening tests. So patient-derived cancer scaffold has been the base for this. How do we do this? We have samples of the tissue and of the cancer tissue. We decellularize, so the matrix is decellularized and is grown with a specific matrix, which is derived separately from the cancer, so that there is no interaction with the in vitro environment, but it's all derived separately from the patient directly, so that there is a model which is mimicking perfectly well what happened in the patient herself. So what we do here is creating a gel which is made from the patient in herself. So her own material is feeding the organoid, so that there is nothing that affects the growth of the organoid, which is deriving from the in vitro growth. So how is this going? How this is working? We do it with drug screening. We do it for extracellular vehicles, and eventually we would love to bring with biomimetic nanoparticles, bring drugs into the cancer directly. So this is the aim of the patient-derived organoids, and so far we have 18, and it's working incredibly well. So we are very proud of this. It's costing a lot of money, but it's definitely worth what we're having. Spatial transcriptomic, finally, is considered the technique of the year by the journal Nature, is considered the technique of the year in 2020. And the difference, just to understand, bulk genomics is like a fruit shake. You will know there is, with flow cytometry and bulk genomics, you will know what is the color, what is particularly expressed in the milkshake. So just for you to understand, this is what we have with bulk genomics. Very interesting, but you will not know the single pieces. With single cell genomic, which is a step forward, you will know what was in the milkshake. So you have the single part of the fruit. So you will know there is kiwi, there's banana, there's pineapple, there's strawberries. You will know what are the components. With spatial transcriptomic, which is the ultimate technique, not only you know what fruit you have in, you know where they are in the cell. So you know that the strawberries are on the outside, you know that the blueberries are on the inside, the kiwis are in the middle. So you know exactly not only who is there, not only how much they're represented, but where they are, which is the final bit to understand what's happening in the functional way. And this is we're very proud of. So these are examples in ovarian cancer. We identify clusters, and as you see, we compare with the anatopathologists to make sure that the clusters are corresponding to cancer areas, so not to cancer, but to stromal areas. So we can differentiate tumor from stroma, and we can identify exactly, okay, where the clusters are. And if, as you see, beautifully enough, what we anticipated to be extremely important is corresponding to tumor and stroma. So the resemblance is extraordinary. So again, very important in ovarian cancer, spatial transcriptomic. We're not going to go into all the details, but again, this is something that will certainly foster extraordinary results in terms of research. Going to the part of clinical research, the standard of care for ovarian cancer has been visceral peritoneal debulking. So do as much surgery as you can to leave the least possible cancer behind. So important preoperative assessment, we improved the CT scan with doing an explorative laparoscopy, centralized cancer care so that the caseload is higher. We have multidisciplinary team meeting, which is mandatory, and the highest rate of complete resection is linked to subspecialization and multivisceral surgery. We do recommend all of this. Published a lot on this, how to expand the surgical portfolio and how to make sure that patients are left with no disease behind. So these are typical images of ovarian cancer. As you see, full pelvis cleaned with anastomosis. These are the specimens. These are large specimens. As you see, descending colon, sigmoid, rectum, uterus, bladder, peritoneum, pelvic peritoneum, all together in one block. Diaphragmatic peritonectomy, the liver is mobilized towards the left, and this is the diaphragmatic disease we go to remove. Chest is open, we go to remove pleura as well as peritoneum, and then we close it again nicely. You see disease on the pleura separate from the peritoneum, quite well acknowledgeable. Disease of the porta hepatis, this is on the entrance of the porta hepatis into the liver. So this is all these dots have to be removed. You see the biliary duct, the main hepatic artery, and behind the portal vein. Lymphadenectomy of the celiac area. So we have porta hepatis, common hepatic, celiac trunk, left gastric, and splenic artery, and big most commonly the lymph nodes, large lymph nodes are found there. Cardiophrenic lymph nodes are also to be removed, and it's something that we do in about 7% of our patients. But if they build a bulk of disease, they have to be removed. So what's next, dear Leila? What could we do next? The next thing is to reduce surgical morbidity, but maintaining the rate of complete resection that we had in ovarian cancer by laparotomy, and maintain the survival outcomes. So how do we do that? We created and designed a trial called the UltraLap trial, which is a phase 1/2 trial, which is a laparoscopic multivisceral debulking in patients with stage 2C to 4 ovarian cancer. So these are patients which have large chunk of disease, and we wanted to know if we could do it by laparoscopy. This is now registered with the clinicaltrial.gov, which is the website of the American government, which records clinical trials. This is the number if anyone wants to look up for it. So how do we do it? Very quickly, we started as interval surgery in Oxford. after neoadjuvant chemotherapy, and then we went up to upfront surgery before chemotherapy. We have a prospective data collection, and we only accept a complete resection of all visible disease. If the disease is not completely resected, we will then move to laparotomy. These are the inclusion criteria and exclusion criteria, which are the same as for laparotomy. So we operate on almost every patient. The only thing that we don't operate is when you have diffuse small bowel serosal disease or porta hepatis encasement. But other than that, we operate on almost everything. If there are exclusion criteria, they go to neoadjuvant chemotherapy. Response to neoadjuvant chemotherapy is based on GCIG and RECIST criteria, and it's based on CT scan review. So ultralab trial endpoints are feasibility, safety, and efficacy. Feasibility surgery ended with a complete resection, and safety, percent of complications specifically caused by laparoscopy. Rate of patients with an early recurrence compared to laparotomy. So safety, efficacy, and feasibility. Now, going further, primary aim is to identify, we ran a pilot study before starting the trial to see which group was best suitable to have laparoscopy. This is the surgical technique. Two parts of it has already been published. The M-block resection of the pelvis was published on Gynecologic Oncology. This is the type of disease. So a frozen pelvis with the disease behind the uterus, above the uterus, and on the pelvic side wall. So what we do, we mobilize the splenic flexure. We do a bowel resection straight away, helping with silicone bends. Reticulator, which is very useful. Reticulator proximally to the sigmoid. And then distally. So you see this is the stapler line with the reticulator. Then we go on the presacral space. So this is the uterus and the sigmoid mobilized towards the bladder, and we're going into the presacral space. This is anteriorly, we open the vagina. This is the cervix, and we now only have the rectum to cut. This is the vagina open, and we have the distal part of the rectum to cut. The specimen is extracted through the vagina, so we don't open her abdomen as per laparotomy. This is the entire specimen removed. And this is a video clip of the removal of the specimen. You see there is an endobag, so there is no spillage of any stuff inside, even though there is already disease in a 3C patient, but we want to make sure that everything is removed intact. So I'm going a little bit faster. As you see, there's an endobag here, and I am taking the specimen out from the endobag. And now the entire bag is coming out. As you see, there is no spillage whatsoever as everything goes into the endobag. It's important to keep oncologic safety and hygiene at all times. So this is now extracted safely with no spillage of material at laparoscopic. So this is now, we don't want to put the anvil, we don't open we don't do a service laparotomy to put the anvil into the bowel. This is the anvil extracted through the vagina. This is the distal part of the bowel extracted through the vagina. As you see, this is me with the headlight, and I cut the stapler line, and I'm putting now the anvil, which is this one here. You can see the anvil. I'm suturing. I'm doing a purse string suture around the anvil, which I put through the vagina. I'm going quickly because I don't want to eat on my time. So this is the anvil now completely placed into the vagina, completely placed into the bowel through the vagina. As you see, I'm making sure that the anvil is perfectly placed. There you go, last suture, suturing around the anvil, and this goes back into the abdomen through the vagina. So again, this is the sigmoid extracted to the vagina, put the anvil in, and it goes in again. And this is the laparoscopic vision. This is before the anastomosis. This is after the anastomosis. You see the ureters are well displayed on both sides. And this is the anastomosis at the end. So this is the video of the anastomosis. I'll go very quickly. You can see laparoscopic and vaginal part. This is beautifully mounted by my guys here in Padua, who are amazing. They do a fantastic job. And you see, I am doing the anastomosis from below, and my colleague, Professor Saccardi, is helping me through the anastomosis from above. You see the anastomosis, I'm going a little bit faster. The anastomosis is well sealed, and now I'm firing. See? I become weak. I need 2 hands to do this. I used to do it with 1. Age is creeping. So, and now this is, I'm extracting the anvil and the stapler, and the anastomosis is fully done. Okay, so this is another one, but it's the same, so I'm not going to go on this. This is the final procedure after the anastomosis. This is the anastomosis finally done. This is the diaphragmatic surgery we also do by laparoscopy. Very quickly in this, we use the snake to mobilize the liver. And so this is the type of disease we tackle, as you see. We do a full peritonectomy of the diaphragm, mobilizing the liver as much as possible. This is the gastrocolic and gastrosplenic omentectomy. This is the pancreas. This is the lesser sac, retrocavity of epiplon. This is the gastroepiploic, left and right gastroepiploic, which we seal. This is the splenic artery. This is the small omentum gastrohepatic, which we also take. And these are the results of the study. We so far have 50 patients that have undergone this type of surgery by laparoscopy out of 208. So it's still a small number of patients. They are highly selected. We are not able to do it in all patients, just to be very clear. So interval VPD, which is visceral peritoneal debulking, we have none of them had a complete response to treatment. 8% of them had a complete response to treatment, but most patients had stable disease, partial and good partial, which means they had significant chunk of disease present. We had a significant conversion to laparotomy, so not all of them managed. We didn't manage to do it in 158 patients, which is the very vast majority. Obviously, they had laparotomy at the same time, so in the same context. This is the type of surgery. As you see, the number of bowel resection wasn't different between open or laparoscopic surgery. We had the very same percentage. So it means that the surgery we did was quite significant surgery, even at laparoscopy. So the benefit, what is the benefit? The laparoscopic group started or restarted chemotherapy 15 days before the laparotomy group, which is quite understandable. And finally, there are only 2 studies which have done laparoscopic surgery in ovarian cancer: the CLOV and the Mission study. One is from Christophe Omen, and the other one is from the group of Giovanni Scambia. But they both only do surgery after chemotherapy. In the Mission trial, which is the Professor Scambia's group, they only do surgery in patients who had a complete response to chemotherapy. In the CLOV trial, we had very restrictive inclusion criteria. No evidence of peritoneal supramesocolic carcinomatosis, residual pelvic disease smaller than 10 centimeters, and absence of suspect supracentimeter retroperitoneal lymphadenopathy. So very restrictive studies. It's not really on multivisceral surgery. It's mostly on patients who had a complete response to chemotherapy. So overall, in these 2 studies, they had 3 bowel resections and 6 diaphragmatic peritonectomy in over 150 patients. So currently, the UltraLab trial is the only trial on feasibility of multivisceral debulking surgery in ovarian cancer. So what is the rule? Shorter hospitalization of laparoscopy, clearly. Decreased thromboembolic events, faster access to chemotherapy, decreased need for analgesia, decreased rate of infection, and these are well known. What is more important? Less immune depression, less inflammation, and we know that inflammation and immunity are very important in tumor progression and resistance. So do we have better oncological outcomes? We will know when we conclude the studies. So conclusions, very quickly, which are the patient feasibility? It's clearly, we have 28% in upfront, 28% in interval debulking and 18% in upfront. So again, Leila, it's not the majority, it's the minority of patients that can have laparoscopic surgery. Safety, it's really very, very much safe. And efficacy, we had 100% of complete resection with accurate selection of patients. So which are the most suitable candidates? We have patients who have disease confined to the pelvis. Even if that includes a bowel resection, that's no problem. Even if it's a peritonectomy, it's no problem. Gastrocolic omentum, that's no problem, but it doesn't have to invade the mesocolon, which is a problem. And any peritoneal disease can be done by laparoscopy, and diaphragm can be done if it doesn't require a dorsal liver mobilization, the so-called caval ligament. Acknowledgements to my co-workers and in Padua, these are my colleagues, and this is the ovarian cancer platform, which includes anatopathologist, researcher, oncologist, biologist. I'm very proud of them. They're doing a fantastic job, and this is my group. And thank you very much, Leila.
Дорогой
Dear Professor Tozzi, you are a fantastic surgeon. You will also deliver another lecture, and now Buktam Bekar is online. Can you give us an answer to only one question? The name of your presentation was Treating Patients with Ovarian Cancer from Laparoscopy Through Genomics. That is the second. I have several questions, but then I'll give you an answer after the second lecture. What is the role of genomics here? What is the role of genomics, please? Genomics.
The genomics is essential. As I said, we select patients now on their genomic profile. So the genomic instability score, which I said at the beginning, will tell us which patient will do what type of treatment. We have different channels of patient for different biology of tumor. So if a patient has a BRCA mutation, or it has an HRD, so a RAD51, PLB, PLAB1 or 2, or has an HRD score, which is significant, then this patient will have a much better prognosis. And they are definitely amenable for a number of treatments. So in these cases, if you can start the PARP inhibitors as soon as possible, that will make them in a better position. Same thing, the immunophenotype. So the immune infiltrate is crucial to understand the type of efficacy that immune therapy can have in ovarian cancer. So if you ask me what is most important in ovarian cancer these days, certainly surgery is very important. It remains a very important thing, definitely. But the most important thing is the information that you get from the lab.
Brilliant answer. We'll get back to you. Thank you so much. Please, thank you so much. Professor Buktam Bekar, is he online with us or not? Shailesh, hello. Hello, Shailesh.
Да, абсолютно. Да, дорогой Шайлиш, у нас...
Yes, Shailesh, we have a brilliant Congress. We have 60 superstars among presenters. All are there online here in Moscow. Those who, the audience and all across Russia. I don't wait to take much of your time, dear colleagues. Allow me to compliments. Yes, later. We'll postpone them until later. It is my great pleasure to present Professor Shailesh Buktam Bekar, Director and Consulting Oncosurgeon of Hospital in Pune, India. The name of the presentation is Anatomic Laparoscopy in Today's Changing World of Oncology. I have repeatedly seen Professor Buktam Bekar work in the operating room. Was it in India or in Russia? This is a fantastic surgeon. And he's got excellent, there is a word, pool. Would you say pool? What do you say? Well, dear Shailesh, the floor goes to you, please.
Okay, thank you, Leila. And at the outset, let me thank you for this opportunity. And I will now start my presentation. So this is the anatomy laparoscopy in today's changing world of oncology. I bring greetings from India. So we know the history of anatomy. It extends from the earliest examination that we had to do, and we had to do it on the cadavers. But now the most important thing is the laparoscopy, the minimal invasive surgery. And what is important is that we have understood anatomy in a much better way than what we understood when we were doing laparoscopic or open surgery. So this is the way we taught laparoscopy initially, anatomy initially. Today we teach them with laparoscope, so multiple people can watch, learn anatomy at the same time. And the most important thing is that at one point of time, because of the magnified vision, the anatomy is much better. So I personally feel when you have to do any kind of advanced laparoscopic work, what is important is to understand the anatomy of fascias, planes, so that you can do a bloodless surgeries. And that is a terminology which I use, what is called as predictive anatomy. What do you mean by predictive anatomy is that how you can understand what structure lies next, and therefore it's all about anatomy, and nothing else but anatomy. We are going to consider four important aspects: sacral promontory, fascias, spaces, vessels, and the nerves of the pelvis. So pelvic anatomy is constant, but what has changed is a thorough knowledge of anatomy, which we have understood it better with the use of laparoscopy. What lies where, what comes next, anticipation based on anatomical knowledge, and this is equivalent to what we call it as predictive anatomy. So you can see that when we put the laparoscope, we see two regions. This is the obliterated hypogastric artery, and then what you see is the summit of what I call it as the pelvis, which is the sacral promontory. At the level of sacral promontory, this is the highest level. The pelvis starts from here and goes downwards. The most important thing you have to understand is that there are three things that happen: division of the common iliac vessels into the internal and external. The ureter crosses from the lateral to the medial side, and the hypogastric plexus lies at this level. So these are the various important structures: the superior hypogastric plexus, bifurcation of the common iliac artery, and crossing of the ureter from the lateral to the medial side. The most important thing you have to understand that none of the uterine pathologies reach up to the sacral promontory. So whenever you are in any kind of trouble, start the dissection at the level of the sacral promontory. You can see right from the bifurcation of the common iliac, you can see the internal and the external iliac artery, and you can see that there are no branches on the external iliac artery or the internal iliac artery. Let us come to the fascias. There are four types of fascias: the cervicovesical fascia, the endopelvic fascia, the Walder's fascia, and of course the Denon-Villiers fascia. So endopelvic fascia is a fascia which covers the obturator internus muscle and also covers the internal or levator ani muscle. It is the key to support the pelvic diaphragm. The only organ which pierces this endopelvic fascia is the ureter. And all the vessels lie underneath the endopelvic fascia. This fascia is important when you want to do any kind of prolapse surgery, when you want to do pectopexy, or when you want to do birch repair. So it is very important to understand this fascia. This is the endopelvic fascia. You can see the fascia completely covering the levator ani muscle and the obturator internus muscle. Coming to the rest of the things, you can see what is the relationship between the fascias and the veins. All the veins in the body lie underneath the fascia. So what is the moral of the story? If you lie between the two layers of fascia, then the veins will never get damaged. So you can see the Denon-Villiers fascia, you can see the cervicovesical fascia, and you can see the internal iliac vein also covered by the fascia. This is the Denon-Villiers fascia. The Denon-Villiers fascia lies between the rectum and the vagina, between the rectovaginal pouch. You can start your dissection and it lies between the two uterosacral. When you want to dissect the Denon-Villiers fascia, one should go with an idea: fat belongs to the rectum, so you remain above the fat and go between the two layers of Denon-Villiers fascia. So you can see fat belongs to the rectum, go above the fat, and you can see the two layers of the Denon-Villiers fascia going there. This is very important to understand. You can see fat belongs to the rectum is the dictum. What about the cervicovesical fascia? The cervicovesical fascia is a fascia which covers the anterior border of the vagina. The veins lie underneath that, and the cervicovesical fascia splits into two laterally to accommodate the ureter, what is called as the anterior and the posterior cervicovesical ligament. So you can see this dissection should be done with the concept fat belongs to the bladder and remain below the fat. So you can see that you remain below the fat. This is the fat, you remain below the fat, and you can take it down completely. So this is how you can completely push the bladder, and once you push the bladder, then you can get a complete dissection over there. This is the most important thing one has to understand. The cervicovesical fascia, the bladder lies anterior to the fascia. The venous plexus lies beneath the fascia, and the uterine vessels also lie above the fascia. So it is very important that when you do this dissection, this is how you can understand these are the veins which lie underneath the fascia. So if you go underneath the fascia, and if there is any kind of bleeding, instead of taking the veins, this is a robotic surgery that we are doing. You can see that instead of taking the veins, when there is any kind of bleeding, bladder lies above the cervicovesical fascia, the veins lie below the cervicovesical fascia. You just take care of the veins, and then instead of taking the veins, just coagulate the fascia. You can see how you can coagulate the fascia, and automatically the veins can get coagulated. So these are the areas of applied anatomy which is important. Look at the vein there. Don't try to search for the vein. Just coagulate the fascia, and end of the story. This is very important. How do you do the bladder dissection? The bladder dissection is done remaining anterior to the cervicovesical fascia. When you want to remain anterior to the cervicovesical fascia, the dictum is fat belongs to the bladder, so remain below the fat. You can see this is the fat. Just remain below the fat. Push, and you push everything, remain below the fat, and that's how you can completely do this dissection, remaining anterior to the cervicovesical fascia, which is very, very critical in understanding. Again, you can see fat belongs to the bladder, just go below the fat. Now, what about the Walder's fascia? This is a fascia which lies behind the rectum. Then you can see this is the rectum. When you expose the posterior part, this is the left ureter which is going here, but this is the fascia which lies behind the rectum. There are two layers of fascias. This plane has to be opened for cervicopexy. You have to do this for endometriosis also when you want to do the bowel resection. So this fascia is the Walder's fascia. Two layers, one covers the presacral veins and one goes with the rectum. So all these fascias are very, very critical in understanding this. So you can see how we can see the champagne effect. You can see the veins which lie below the fascia. This is the basic rule of the body. And then the buttocks of the infant appearance, which is very clearly seen. What about the pelvic ligaments? So we have 4 types of ligaments, in fact 3. One is called as the uterosacral. You can see that, which is the posterior support, the McEnroth's ligament, which is the lateral support, and of course, anteriorly, you have the cervicovesical fascia, which gives the support to the entire uterus. So all these avascular spaces that you see are not seen when you put a laparoscope. They have to be opened. That means you have to take out the carpet. It is like taking out the carpet to see underneath what is happening. Why should we do interfacial ligation? Because fascias lack fibroblasts. And because the fascias lack fibroblasts, then you can understand that when you do interfacial dissection, then there is no way there will be any kind of fibrosis. Cancers, they spread because the cervicovesical fascia splits into two, the anterior cervicovesical fascia and the posterior cervicovesical fascia. And that is the reason the ureter gets involved initially with this kind of thing. This is our publication, Facial Anatomy and its Relevance in Safe Laparoscopic Hysterectomy. Significance of the fascias. The ureter is the only organ to pierce the endopelvic fascia. Dissection of the endopelvic fascia used to do the transobturator tape. 2 layers of denon-villus fascia. These are the toughest layer and prevents the direct spread of the cancer. The cervicovesical fascia splits into anterior and the posterior area to get the ureter inside the bladder. The anterior cervicovesical ligament is called as the ureteric tunnel. Now, what are the next thing that we want to know? The deep spaces. So we have the paravesical, pararectal, rectovaginal, and the prevesical spaces. The pararectal space is divided into 2 types. The lateral pararectal space called as the Latsgo and the medial pararectal space which is called as the Okabayashi. So you can see both the spaces. The ureter divides the space into 2. The lateral space which is called as the Latsgo, the medial space which is called as the Okabayashi space. The only structure that crosses the lateral space is the uterine artery, and the only structure that lies in the medial pararectal space is the hypogastric nerve. So you can see the approach to the pararectal space. You can use a medial approach. that is by cutting the peritoneum medial to the infundibulopelvic ligament. Once you cut that, you see the ureter, and once you cut the ureter, see the ureter, then cut the peritoneum medial to the ureter. Second thing is a lateral approach, where you can enter the retroperitoneum by remaining lateral to the infundibulopelvic. You can see this is the infundibulopelvic. Remain lateral to the infundibulopelvic ligament and open the space parallel to the infundibulopelvic ligament. So you can see very, very clearly that we are opening parallel to the infundibulopelvic ligament. The first structure that you see is the external iliac artery. Open the anterior leaf of the broad ligament further, and now you can see the external iliac, you can see the ureter. What we are not seeing, now you can enlarge the opening, and you are not seeing the internal iliac. So now what we do is remain parallel and lateral. Just remain parallel and lateral to the ureter. And this is very important how you do it is. So parallel and lateral to the ureter, you can see the external iliac. You are not still seeing the internal iliac. So again, push the entire area. This is now the internal iliac artery. Push parallel and lateral to the ureter, and you will see this is the only structure that crosses the pararectal space transversely is going to be the uterine artery, which you can very, very clearly see. That is the uterine artery, which is crossing the ureter anteriorly. And this is the lateral pararectal space, which is very, very critical. The pararectal space, again, you can see the opening of the space. You remain from the medial approach, cut the posterior leaf of the broad ligament. Once you cut the posterior leaf, you will see the ureter. Now remain parallel and lateral to the ureter. The only structure that will prevent you from going down is the uterine artery. Once you go to this, then remain parallel to the uterine artery. You will see the superior vesicle. Go between the uterine artery, and you will be able to see and push. This is the paravesical space. So you have the pararectal and the paravesical space. Now, this is the lateral pararectal space. If you want to open the medial pararectal space, open medial to the ureter and remain parallel to the ureter, and you will see the Okabayashi nerve coming up. So that's the Okabayashi space with the hypogastric nerve which comes in, and this is the lateral pararectal space. You have already taken care. The artery goes above the ureter. The vein goes below the ureter. So this is the change anatomy. And on the medial side, you can see the Okabayashi space with the hypogastric nerve. So these are the pararectal spaces. Then the dissection of the rectovaginal space, you can see very, very clearly. What you have to do is to go between those two areas. Fat belongs to the rectum, and this is how you should do the dissection. So you remain above the fat. You can see that you can go and remain above the fat. Fat is the correct plane. Look at the fat, go above the fat, and you will be able to see that you have reached the lower area. These are the two layers of Denon-Villiers fascia. And of course, the paravesical space, we have already seen the paravesical space. So this is the medial approach for the paravesical space. I'll just take you forward. This is the artery. You can see this is my arrow. This is the paravesical space, which is seen. And then if you want to go ahead and then dissect, this is the Yabuki space. Yabuki space is medial to the ureter. That's the hypogastric nerve with S234 fibers. And this is the medial pararectal space. Finally, the prevesical space, which is the space anterior to the bladder. You can see this space can be dissected by remaining between the two obliterated hypogastric artery. These are the two obliterated hypogastric arteries. Just remain in between the two areas. You can see this is the area. You try to remain in between the two. This is the area. Go above the fat, and you can see that we have gone just completely down, and then we can see and go into the prevesical area. This is the space that you open when you want to do the birch repair. So what about bladder dissection? So you can see this is the area, this is the uterine artery. The bladder remains anterior to the uterine artery, and just go below the fat. Use these tricks of anatomy. Just go below the fat. Just go below the fat and push Just go below the fat and push, and you can see how easily you can do the bladder dissection. Even if the patient is having a cesarean section, you can do this. So this was a 3 cesarean section patient. You can see that it is very, very badly stuck there. So instead of going from directly in the middle, we are now coming from the lateral side. This is the bladder, which is very, very badly stuck. So we will follow the principles of fat belongs to the bladder, go below the fat. So see how we are going below the fat, and slowly and steadily, we just go below the fat. Continuously, we go below the fat. And if you do this, so you can see again, this is the plane. We have lifted it up, just remaining below the fat. So this is the fat. We go, we push, we cut. So we have to use a combination of blunt dissection. This is the fat. You just go below the fat, and now the planes can open up very, very easily. And now you can go ahead and do a complete dissection. So these are the tricks of the trade that you have to use using the knowledge of anatomy. Again, you can see the fat. No worries, just go below the fat. Just go below the fat, and you are able to take care of this. So applied anatomy, you can do the uterine artery clamping, then you can do the cave of radius entry, adenolysis, and then finally the Yabuki space. This is the space which is medial to the ureter, and this is the space through which the hypogastric nerve enters. This is the space through which the hypogastric nerve goes and enters into the bladder. This is the fourth space of Yabuki, and it is very important to identify this space so that you come to know this is the space where you can lateralize the ureter, and you can see the nerve in the Yabuki space going towards the bladder, while the nerve fibers which are going towards the uterus have to be cut so that you can lateralize this. So with knowledge of anatomy, we have evolved into parametrium. You have the 3 types of parametrium. One is the anterior parametrium, which we described. You can see this is the parametrium that we open after we take the cervicovesical ligament. And once you take that and you do an infraureteral complete dissection, you can see the anterior parametrium, and you can see the Macken-Rods and the anterior parametrium, both of them together. So this is called as the anterior parametrium. Again, to show you, this is the ureteric tunnel. You can see the ureter there. You can use the Maryland forceps to dissect the anterior cervicovesical ligament. If you dissect the anterior cervicovesical ligament, always use clips, because these are the small 2 veins which drain from the bladder, and then you can see that you can push the ureter further and further down, and you will be able to see a complete anterior parametrium, which is very, very critical to understand the anatomy. So this is the dissection. We have got our Golden Telescopic Award for description of the anterior parametrium. Finally, the vascular anatomy. You can see the aorta and the IVC. They don't have branches, tributaries. Again, if you go down on the common iliac artery, you don't have branches. Again, on the external iliac artery, the only tributaries that you have are external circumflex iliac vein and, of course, the epigastric vein. And these are the only tributaries. As a result of which, when you want to do the node dissection, always remain parallel and parallel. So if you remain parallel to these structures, then it is, you can see the fascia covering the external iliac. You remain parallel to this, and you can see the entire dissection done very, very easily. Similarly, when you want to do major vessels, these are the nodes on the major vessels. Just remain parallel to these major vessels, and everything will be perfect. You can see the external iliac artery and the vein. Just remain parallel, because we know that there are no branches, no tributaries on the external iliac vein as well as the artery, which is very, very clearly seen. So knowledge is very important. The internal iliac artery, the first branch is the uterine artery, which is given about 6 centimeters away. You can see this is the first branch of the anterior division. So you have a long length available. The artery goes above the ureter and the vein goes below the ureter. So when you have a large fibroid, then instead of directly going over there, you can go ahead and take the uterine artery directly. So you can go ahead and take the uterine artery at the origin, And this is how you can do this. Again, few pictures to show you the anteriorly, the uterine artery and the vein that goes below. Now, I will not show you this. So these are the various areas. Finally, this is the corona mortis, which is nothing but a communication between the circumflex iliac vein, which is a tributary of the external iliac vein, with the obturator vein. Then the obturator artery, which goes below the obturator nerve, and then our friend. What about our friend? That is the ureter. Ureter carries its own mesentery. You can see it carries its own mesentery. It lies between the artery on the top and the vein below, and therefore it is very important. So where you have to trace the ureter always lies at the base of the uterosacral. It is about 2.5 centimeters away from the base of the uterosacral, and I've already shown you the ureteric tunnel dissection. So this is the separation of the medialized ureter in grade 4 endometriosis. You can see this is the ureter, and this is, if you understand the anatomy of the ureter, then you can immediately separate the ureter from this area. So this is how you can see we have gone underneath the infundibulopelvic ligament, and you have to know your place of ureter. Similarly, these are the various areas. I will not take you into the applied anatomy. The neural anatomy, we have 4 nerves in the pelvis. One is called as the genitofemoral nerve, the obturator nerve, you can see that. Then, of course, the hypogastric nerve with the S2, 3, 4 fibers. So you can see the genitofemoral nerve, which is lateral to the external iliac, the obturator nerve, which lies between the two bifurcations, then the hypogastric nerve. These are very, very important for you to understand that these are the various nerves. And then, of course, you have the sciatic nerve, which is just below the obturator nerve. This is the S234 fibers, which are the pelvic splanchnic nerves. So you have to understand the significance of neural anatomy is to preserve the superior and the inferior hypogastric plexus. The nerves which are preserved help you to get not only good bladder function, but also good vaginal lubrication. So most important thing, start by doing what is necessary. You understand the anatomy, start doing it, and then you will find that you will do completely different thing. So we have done radical hysterectomies, we have done various areas along this. I will, because of the want of time, I will not show you all these videos, but this is very important to understand. Applying the anatomy is the most important thing which is there. And of course, even the para-aortic nodal dissection can be easily done based on this anatomy, because you can see that just remain parallel to the vessels and you will see the entire aorta and the IVC completely cleared like this. So these are the various approaches. Again, this is the final roadmap of the pelvis. You can see the ureter is the most medial structure, and of course, the external iliac is the most lateral structure. If you understand this roadmap, then you can understand and do any kind of surgery. Surgical Pelvic Anatomy is our publication. Please go through it. It is in the International Journal of Obstetrics and Gynecology. We have published this in Journal of Minimal Invasive Surgery. And these are the various citations with which our citations have been given for various areas. This is the latest article published by a Bulgarian surgeon called Avascular Spaces, and you can see various references of ours into this entire area. So take home messages. Start your dissection at the sacral promontory when you are having difficulty. Always remain parallel to the tubular structures. Always identify the fascias. Remain medial to the ureter. And fat belongs to the bladder. Fat belongs to the rectum. The ureter lies in the fork between the artery and the vein. Ureter carries its own mesentery. Most important thing, there are very, very few variations in pelvic anatomy. So that is very important. And therefore, if you want to evolve and become a good surgeon, always anatomy, nothing else and nothing else but the anatomy, that is very, very, very important. So thank you very much, Leila. Thank you for all the help, and thank you for always inviting me for your conference. I hope all of you have understood what I have tried to tell you in the last half an hour. Thank you so much.
Да, дорогой Шариш.
Dear Sharish, it was a gift for us. Well, I know the level of your surgery is very high. So today, besides the knowledge of anatomy, besides the fact that, well, you are like a good driver who should know the road and you have the road map, but what is your interest now? What are you interested right now? Professor Sharish, for the first time, did the transplantation of uterus using the laparoscopic approach. Well, he can do his own procedures. What are you working on right now, Mr. Sharish Puntan Bikar? What surgeries do you do? What are you looking for in the future?
We are trying to do the recipient in uterine transplant also laparoscopically. So we did the donor laparoscopically. We are trying to see if I can do the recipient with vascular anastomosis also laparoscopically. So that will avoid a big surgery for the recipient in uterine transplant. And this is our mission. And hopefully we will get back to you within a week or within a month's time whether we can do this.
Thank you very much, dear Professor Puntan Bikar. And your presentation was a gift for us. Thank you and good luck. Let's move on. We continue our plenary session. Professor Roberto Tozzi is going to speak next. Radical surgery in patients with laparoscopic approach for cervical cancer, surgical and survival outcomes. Roberta, please, the floor is yours. Thank you again.
Thank you, Leila. So, just a second, please. Can you see it?
No, not yet, not yet. We can see you, but not the slides. We can see your face, but not the slides.
Can you see it now?
I see.
Да.
Yes, we can see the slides. Everything is okay.
Okay, good. So, thank you, Leila, again. Sorry for the delay. So, we're talking about now about radical surgery in patient locally advanced cervical cancer. So, we'll go through surgical and survival outcomes. And the message from this type of presentation is why should we still do surgery in patient with locally advanced cervical cancer? So again, this is a type of experience that I had in my journey through Oxford, Sicily, and now in Padua, where I am consistently. So what is LUC? It's patient with consider 1B3 to 2B cervical cancer. So it's 36% of the patient, and it's usually a disease confined to the cervix. So we like to think as local advanced as 1B3. So that patient with a large cancer which exceeds 4 centimeters, okay, but which is still confined to the cervix. So it's also called a bulky cervical cancer because it's a large disease, but again, it's confined to the cervix. It doesn't involve the parametrium and it doesn't involve the vagina. So it can involve the vagina and it can involve the uterus. And this is the new FIGO classification, which has clarified that 1B3 is now more than 4 centimeters. It used to be 1B2, and it's now moved to 1B3. This is the main change that has been in the recent FIGO classification amendment. So what is the traditional treatment of 1B3? It's radical hysterectomy plus adjuvant treatment, is chemoradiotherapy, or is neoadjuvant chemoradiotherapy or neoadjuvant chemotherapy followed by surgery. The guidelines of the European Society of Gynecologic Oncology, together with the ESMO and together with the SSP, which is a unique moment where the three societies have come together to do guidelines, have established that definitive platinum-based chemoradiotherapy is the standard of care. It's the preferred treatment. So chemoradiotherapy, which is external beam and brachytherapy, is the standard of care. However, there is an alternative, which is radical surgery is an alternative option, in particular in patients without negative risk factors, which is combination of tumor sites, lymphovascular space invasion, or deep stromal invasion. So in this case, very important as it reads here, is the quality of surgery, both parametrectomy and lymph node dissection is of key importance. So the message is surgery is acceptable, but has to be done to a high standard. So what is radical chemoradiotherapy? So the standard of care is radiochemotherapy. What it is external beam radiotherapy followed by brachytherapy. And chemotherapy with cisplatinum is concomitant. How much radiotherapy do we give? Usually is 50.4 grays in unit of 1.8 gray per time. And we will add to it another 25 to 30 grays of brachytherapy. So the overall dose to 0.8, which used to be it's no more popular, but it used to be the point to which we calculate the dose of radiotherapy conveyed to the patient, is about 85 to 90 grays total dose. So why can we not give more radiotherapy? Why can we not give double the dose? Because there is a dose limiting tissue. So dose limiting tissue is the tissue which is in the area of the radiotherapy, which is most sensitive at the highest possible dose. So in the pelvis, the dose limiting tissue is a small bowel. So if we exceed this amount of this grays, like 90 grays of radiotherapy, there will be, even in the most accurate and in the most specific and in the most modern radiotherapy technique, there will be small bowel involved into the radiotherapy field. And therefore, that will cause significant actinic morbidity. So usually is 60 points are given to point B, 60 grays are given to point B, and 85 to 90 grays are given to point A, where is the main cancer. So point B is basically 2 centimeters cranial and 2 centimeter lateral to the cervix, and point A is actually on the tumor. So this area is hit by a mixture of brachytherapy and external beam. This area is aimed mainly at the lymph nodes, and it's done by external beam radiotherapy. So this is the main treatment. So total 90 grays. However, very important, in the KEYS study, which is published in the New England Journal of Medicine, with this technique, 48% of the patients still had residual disease. So even with the most radical of radiotherapy, they had residual disease. And an update of this study, of the KEYS study, has showed that hysterectomy, simple hysterectomy done after radiotherapy, was of no benefit. So these are the studies that have changed, that have trialed radiotherapy compared to surgery. One was published in the Lancet, it's the Landoni group. They had 67% cut through and 30% had lymph nodes positivity. This is a very old study, but it's still very interesting to see there was no difference if you treat radiotherapy with this patient with radiotherapy or surgery. The main study is the Sedley study, 99, whereby they divided in intermediate risk factors and high risk factors. And in the Sedley study, we had patients involved with uterine risk factors, which meant deep stromal invasion, tumor sites, or lymphovascular space invasion, and they were randomized to have, after radical surgery, they were randomized to have observation versus radiotherapy. So the patient who had radiotherapy had a better disease-free survival, okay, but had a higher toxicity. This is quite an old study, okay? So we had the benefit. Key study, very important study. This is the main study. It's published in the New England Journal of Medicine. They did 1B2 at the time, which is now 1B3. They randomized radiotherapy versus chemoradiotherapy. There was surgery only in patients with persistent disease. So they say that radiotherapy is worse than chemoradiotherapy. So this study changed the practice and elected all patients with cervical cancer to have radiotherapy, radical radiotherapy, with the addition of chemotherapy. However, chemoradiotherapy had a grade 3 and 4 toxicity, GOG toxicity of 44.8. which is remarkable. This is something you need to remember. So overall survival was better in chemoradiotherapy versus radiotherapy, but they had almost 50% of the patient had grade 3 and 4 morbidity, which is very significant. It's not trivial at all. So this is another study, the Peter study for high-risk group. So patient with parametrial invasion with the R1 or with positive lymph nodes, they received chemoradiotherapy or radiotherapy after surgery, and chemoradiotherapy does better than radiotherapy. But that is not relevant to what we're talking today. So going quickly, the GOG92, which is the Sedley study, the one which was doing radiotherapy or observation after radical surgery, had an update study which showed that, and this is the first name is Marvin Rothman, that doing radiotherapy after the surgery, after radical hysterectomy, will reduce the disease-free survival, but will have no impact on overall survival. So the overall survival will not be affected. And the reason is quite simple. This is the study, because if you receive radiotherapy at time of surgery, you will not be able to receive radiotherapy at time of recurrence. So you will reduce the local recurrence. So you will increase the disease-free interval, but out of these who will recur despite radiotherapy, there's hardly anyone you can treat. So this radiotherapy after the surgery will impact disease-free survival, but will not impact overall survival. And therefore, we thought, okay, chemoradiotherapy has changed. We have other things now. We have intensity modulated radiotherapy, IMRT. We have image-guided brachytherapy, which have brought significant improvement. But nonetheless, very important, these are recent studies. This is a large survey run mostly by gynecologists and radiotherapists. And it still says, large review, patients who receive radiotherapy as part of the treatment have the highest risk of increased long-term dysfunction of bladder and bowel, as well as sexual dysfunction and psychosocial consequences. So let's go into this. The Embrace study. The Embrace study is radiotherapy group. They are a fantastic group. They do amazing studies altogether, and they are very honest in what they report. So this is the dose-effect relationship and risk factor for vaginal stenosis. So we still have significant G2 vaginal stenosis of 21%. So the data is not trivial. Again, these patients will have still significant morbidity despite new development in radiotherapy. They will still have significant morbidity. Rectal morbidity is still not trivial. So again, this is the Embrace group. They report their data very, very thoroughly. And yes, it depends on the dose volume effect. It depends on a number of things. And it has the advantage of MRI-guided adaptive brachytherapy, but the morbidity is still not trivial. If you look at the data here, grade 2 is still 6% rectal morbidity, which is something that is extremely impairing quality of life. Same thing for bowel morbidity overall. Same data, significant. So we have diarrhea, we have flatulence, we have incontinence. There are some patients who have the experience with this type of radiotherapy actinic morbidity. So a long time ago, almost, in fact, 20 years ago, we published a paper with the group, which was led by Professor Schneider, and I had the privilege to be one of the team with Christa Köhler, who will speak after me, Mark Possever, a fantastic group. And we published the first series on laparoscopic radical hysterectomy. We've now launched a study some time ago with the University of Oxford, the University of Padova, the University of Groningen, and the University of Brescia on radical surgery, radical treatment of patients with 1B3, local advanced cervical cancer. So it's now 5 years. We have very interesting data. The criteria for enter the study were stage figure 1B3, so that there should be no lymph nodes involvement, no tumor left behind, and no parametrial involvement. And we excluded small cell and neuroendocrine histology. The diagnostic pathway used outpatient examination plus MRI, and then EUA was done at time of the surgery. We did laparoscopic staging. On frozen section, the lymph nodes had to be free, and so had to be the space between the bladder and the rectum. So we have recruited 81 patients with 1B3 cervical cancer. We've done pelvic and in some cases, para-aortic lymphadenectomy. These are the type of lymphadenectomy we've done. We did intraoperative frozen section to triage patients appropriately. This is the type of surgery. You see external iliac vessels, obturator nerve, obturator artery, internal iliac umbilical, uterine artery. Again, as we said before with Philipp Koenig's, the cleanest field is associated to the best results. So this surgery has to be bloodless. Again, internal iliac at the bifurcation from the common iliac vein, obturator nerve. After this lymphadenectomy, you only want to leave the nerves and the vessels. Nothing else has to be left in the pelvis. Same on the other side. In this case, we are on the right side. So this is the vein here, the internal iliac vein. And this is the pelvic side full displaced. We are on the left side now. This is the artery and vein medialized. So this is the psoas muscle. We separate the psoas muscle from the internal external artery and vein. And this is the obturator nerve, and this is the sciatic nerve. So L5S1 joining. And this is quite a nice picture. This is the superior gluteal artery going between L5 and S1, which is then forming the sciatic nerve. So out of these 81 patients, they were typical for the data. Squamous was the most common type of histology. What happened? So this is the flow chart, which is now being published, but you can have a look at everything. So we divided in 3 groups. 9.4% had positive lymph nodes, and they built group 1. 90% had negative lymph nodes, and they are group 2. So positive lymph nodes did not have radical surgery. So surgical outcomes, group 1 and group 2. Group 1, 9% positive lymph nodes. We aborted the laparoscopic procedure. There was no postoperative complication, median duration 120 minutes, waiting for the frozen section, minimal extent blood loss, median hospitalization 1 day, and they had concurrent radical chemoradiotherapy at a very short time from the surgery. So there was no impact from doing the surgery to the chemoradiotherapy. So 90% of the patient had negative lymph nodes, and they were group 2. They had a full surgical resection, no intraoperative complication, estimated blood loss 115 cc, 1 intraoperative transfusion because she had a low baseline hemoglobin, bilateral nerve sparing achieved in 90%, monolateral nerve sparing in 10%, median duration 300 minutes. It's surgery which lasts significantly. You have to take your time and do it properly. So what were the complications? Relevant, we had almost 5% ureterovaginal fistula. That has now decreased massively. We haven't had a single fistula in the last 43 patients, which is very interesting, but it was very significant. Normally, in radical hysterectomy, you will have a much lower fistula rate, but these are big cancers, so it's a very different type of disease. Overall, 12% G3 complications, which is something we're getting better on. Overall, 29% based on all sorts of complication, irrespective of the grade. So these are the specimens. As you see, quite significant parametrium on both sides. This is the surgical specimen. And we try to do C1, C2, I would call radical hysterectomy. This is the nerve sparing. These are the splanchnic pelvic nerves. We are on the left side, and they're going through the middle, meeting the hypogastric nerve. And we can all find that this is the pelvic plexus, which we are lifting now, and that could be nicely spared, visualized and spared. So again, we also, like Shailesh Puntambakar was saying, we also believe in following the nerve not only at the origin, but all the way into the bladder. So this is on the right side. These are the nerves that are leading into the bladder. So also these are quite important. So these are the ureters at the end of the procedures, and they are very much denudated. They are dissected as much as possible, all the way into the bladder, trying to keep the meso of the ureter as clean as possible to preserve the blood supply. So group 1 is the lymph node positive. Group 2 is then divided in group 2H and group 2I. Histopathologic outcomes and histologic outcomes. This is how histopathology is worked out. So you see the specimen, you see the parametrium, and you see the beautiful reconstruction on the slice. So these are the specimens, large cancers, large parametrium. Again, what are the results? Histologic outcomes. Tumor size median was 58.4. So you see it was up to 8 centimeters tumors. Parametrial length, at least 4 centimeters per size. And we had surgical margin free in all patients. And in 4 was closed, so less than 10 millimeters. In all the others were more than 10 millimeters, no cut through whatsoever. And final histology was different, and therefore we had to classify patients based on the final histology, even if they all had radical hysterectomy, into upstaging through the final TNM classification. So what happened? So group 2, negative lymph nodes at frozen section. We had group 2H, high risk factors based on the Peter study. So they had either parametrial involvement, they had lymph nodes involvement. They will therefore be 11.3%, and 79% were group 2I, were intermediate risk factors. So they didn't have parametrial involvement, they did not have lymph nodes involvement. So group 2H, high risk, they had high risk prognostic factor based on the Peter study, so the Southwest Oncology Group 8797, and they had positive nodes, positive parametria. So in the 2 positive nodes, we had the false negative and frozen section. 1 with positive parametria, 1 with a free margin less than 5 millimeters, and 1 breach out of the uterine serosa. So they had adjuvant chemoradiotherapy. The group 2I, which is the most interesting one to us, is the one which had all the SEDLI study risk factors. So deep stromal invasion, capillary lymphatic space invasion, so lymphovascular space invasion, and large tumor size, all patients. This is the distribution of how the risk factors were represented in all patients. As you see, tumor size is always above 4 centimeters for all of them, and they all had at least 2 out of 3 risk factors. So these patients in group 2I did not undergo radiotherapy. They only underwent counseling. We discussed with them, and then we end on follow-up. We observed them, so there was no need for we didn't prescribe any radiotherapy for this patient. What are the survival outcomes, which is the most important thing? Group 1 is the one with positive lymph nodes. They had radical chemoradiation, no recurrence, 60%. So still, even with positive lymph nodes, there is good survival. There's decent survival for these patients. So this is the follow-up time, and on recurrence, they had exenteration or debulking of lymph nodes. So survival outcomes, high risk factors, group 2H, type 3, and radiotherapy, they had still a significant 83.3% survival at over 3 years follow-up. It's now almost 5 years, and the results are confirmed. Finally, the group 2I, which is the one which we are most interested in, the one which did not receive radiotherapy, like 3 radical hysterectomy, and 90% of them did not have a recurrence. So 90% of them are disease-free at 5 years. So that is extremely interesting. This is the disease-free survival for the 3 groups. So green is the group we're interested in, the one with large tumors and no radiotherapy. And the others are positive lymph nodes and risk factors at final histology. So recurrence analysis, how were they distributed? Risk factors for recurrence. This is a different analysis. We're not going to do this. Salvage treatment, surgery, hysterectomy, exenteration, 50% of them were saved. Exenteration, when it was just exenteration, hardly anyone survived. So chemoradiotherapy with surgery available, 50% of them were saved. So again, in group 1, with hysterectomy exenteration, positive lymph node, 50% of the patients were saved through exenteration. In group 2, which is the high risk, exenteration didn't manage to save this patient. In group 2-1, 50% of them were saved despite their recurrence. So overall survival, that is the most amazing data. So we have 92% we have 92% disease-free, and overall we have 92.1% overall survival in the patient which never had radiotherapy, which compares beautifully. If you remember the first study I presented, the key study, they had 83% survival at 5 years, but they had 48%, or they had 44% G3 and 4 toxicity. So advantage of chemoradiotherapy is no surgery and no intraoperative complication and similar survival. Contra, there is a complete pathologic response in only 50% of the patient. There is no lymph node staging, non-cost effective, and also there is a significant toxicity. So in the GOG 123, they had 44% of the patient had G3 and 4 toxicity, which is clearly something that we can avoid if we do surgery. Surgery advantage is that there's a complete pathologic response. Surgical staging can customize the treatment. It's cost effective based on the studies presented in the United States several times, and there's no risk of second malignancy. Contra is the postoperative complication. It needs significant surgical skills, and some of them will still have adjuvant treatment. I thank all my co-workers for this study, and Professor Schneider, who has been my mentor and is a good friend for many years. These are my girls, and thank you very much, Leila, for your attention.
Dear Professor Tozzi, I'm so grateful to you for this course in oncology that you now taught us, especially super radical oncology. Dear colleagues, thank you so much. All this morning, we were joined by Professor Roberto Tozzi, Department of Pediatric and Female Health in Padua University. This is the largest university and a great, great friend of ours. Thank you so much. Thank you, you and our family. Thank you. All the best. I hope we will have a face-to-face meeting. Thank you. Dear colleagues, it is my pleasure to present to this audience. I give the floor to somebody who adores us, and I refer to her patients, Professor Kircher. This is Professor Simona Marnitz. What is the role of chemotherapy and radiation therapy in gynecologic cancer? Algorithm of diagnosis, treatment, and rehabilitation. Clinical professor of private clinic of radio-oncology. Thank you so much, dear Simona, for all you've been doing for us. Thank you. Thank you so much. Good luck. Now the floor goes to you, please.
Okay, thank you so much. Dear Professor Adamian, thank you for the invitation. I'm really honored to be with you today, not really in Moscow, but I hope next year.
Откройте экран. Экран откройте.
Could you please share your slides? Share your slides, please. Put it a full. Yeah, thank you. Yes, we can. Thank you. We see full display. Thank you.
Thank you, Leila. Thank you so much for the invitation. Just in addition to Professor Tozzi, who already covered the topic of chemoradiation, just one remark. The brachytherapy with the point A is not longer considered as a standard of care, so we should do CT planning and MRI guided brachytherapy planning. And with the new techniques, there's a randomized study on IMT techniques. We can harden the treatment-related toxicities. So just a short remark to the speaker, Professor Tozzi. So my topic is, I'm a radiation oncologist. My topic is today not radiochemotherapy, but the fertility preservation and some topics around the fertility and radiotherapy. We have some problems with fertility after radiation. It can cause by central fertility problem during a brain radiation, for instance, in children or young people. we can cause ovarian failure, of course, after radiation. We can cause an endometrial atrophy or myometrial fibrosis after radiation. And I want to go with you through the topics. The central hypogonadism is a really big problem after radiation, especially in children. We normally treat brain tumors with a combination of chemotherapy and radiotherapy. And you see here an example of a child with a brain tumor before radiation. And you can imagine, because of the tumor localization, that there can be a problem after radiation, depending on the dose, depending on the age of the children, of course. And there's a strong need for a strong indication for radiation treatment, even for children, avoiding radiation, really young children, younger than 3 years. We have the need for high precision techniques with a sharp dose gradient to the normal structures and saving of the surrounding normal tissue, of course. There's a need for an interdisciplinary cooperation with radiologists, radiation therapists, chemotherapists, and of course, endocrinologists after treatment. And the children need a long-term follow-up and normally in substitution of the hormones. The topic ovarian failure after radiotherapy is a big topic even in young women with cervical cancer and maybe in young women with endometrial cancer. There's a high dose during radiotherapy, and a low dose is needed to have an ovarian failure. So the ovaries are really radiosensitive organs. We have a so-called 80-50 for the follicles of 4 gray. That means half of the follicles don't work after radiation, after 2 single doses. That means a probability of 50% for ovarian failure after 5 years after a dose of 4 gray. And there are some related factors. One factor is the age of the patient. The younger patient have less radiosensitive organs. As older patients and as very young patients, we can cause maybe genetic disorders in the ovaries with doses even below 1 gray. There is an influence of the fractionation during treatment of this maybe simultaneous chemotherapy or of chemotherapy given before radiation. The individual genetics, of course, is a factor, and the duration of follow-up. So if you have a long-term follow-up, you will see more ovarian failures after a longer period of time after chemoradiation, of course. Therefore, we normally use an ovarian transposition before chemoradiotherapy. You see here on the schematic view from a paper we published, and you see here the video done by Professor Köhler with an ovarian transposition, and very important, as high as possible, and to clip it with some titanium clips to see it on the planning CT, and you have the dose calculation and the dose optimization to the ovaries. We try to give to the ovaries below 2 gray, and with this perfect transposition, it's no problem with the modern radiation techniques to keep the ovaries below 2 gray. There's some unresolved problem of the uterine fibrosis after chemoradiation or after radiation. We don't know any established dose constraints. There has been an endometrial atrophy and uterine fibrosis, a reduced elasticity of the myometrium, causing that no pregnancy after radiation is possible. Maybe we have a microvascular impairment after radiation and an impairment of the microenvironment. This causes the problems with the nidation and with the pregnancy after radiation. And here you see one example of a young patient with an anal carcinoma and the need for chemoradiation of the pelvis. And what we did, you see here, we transposed with resorbable material the uterus to the abdominal wall to keep the uterus out of the radiation high dose volume, to keep the endometrium and to keep the myometrium below on the lower dose. And then we did the chemoradiation. After chemoradiation, after 6 weeks, the resorbable material was over and the uterus moved to the normal position. And this caused to a saving of the endometrium. And you see here the result of the saving. The patient got pregnant 3 years after the chemoradiation and was a mom of the healthy baby and healthy boy. So that's really successful. The other option done by especially by the Brazilian colleagues, you see here the video of Ratin from Brazil, the full transposition of the full uterus before chemoradiation. And here our example from our clinic, the transposition of the full uterus with the cervix coming out of the umbilicus for menstruation. And this is the video from the patient with a rectal cancer needing chemoradiation before the surgery for rectal cancer. You see here the video done by Professor Köhler during the laparoscopy to be sure that everything is fine with the vessel supply, with the blood supply after the surgery. And then we did it, and the patient got the chemoradiation. After chemoradiation, the transposition was done in the upper position. So this is uterus preservation during radiation. You see here that there's a low dose coming to the uterus and the ovaries. You can save the ovaries, you can save the uterus, and after the chemoradiation, you can replace the uterus to this normal position. So this is an option for really selected patients and a really experienced team of surgeons. Complications of the procedure may be uterine necrosis, ovarian failure, bleedings, vaginal descents, and some others are reported in the literature. To conclude, oncologic treatments, especially radiation, may compromise fertility in young patients or after treatment of children, may cause early onset of menopause. This causes, of course, discomfort and impaired quality of life of the patient, has adverse effects on bone metabolism and, of course, the cardiovascular risk of the patient. Ovarian transposition may reduce dose to the ovaries if done properly by an experienced team. You can do a partial or complete uterine transposition to allow pregnancy after oncologic treatment. And most important is, of course, an interdisciplinary cooperation and an experienced team for that. So I want to thank you for your attention, and I hope to see you all together in Moscow maybe next year. Thank you so much.
Well, dear Simona, such a pleasure to listen to your presentation, first of all, because I surely know what are your outcomes, what are your results. We refer patients to you and you never refuse them therapy, both you and Professor Köhler. This is a great thank you on behalf of all physicians who are listening to us. Secondly, never again, not for a single minute. You're always on time, not even a second later. This is probably your personal quality. Thank you for this too. Tell me, please, if we look at a situation that has to do with these severe patients, Well, in which percent of cases can we count on a patient falling pregnant? Simona? If we do it properly, if we do it correctly, if later on the patient restores her reproduction, well, approximate percent, how many patients in percentage could count to become pregnant?
The percentage of doing this procedure before radiation. So we decided for very selected patients. So there's a need, of course, the patient has to ask for it. We have to counsel with the patient, with the whole team. And there are some, of course, preconditions in terms of the patient with no comorbidity, the a consultation with the surgeon, with the vessel surgeon, and with the whole team, and of course the ethical committee of the clinic. You have to agree to that procedure, which is really impacting the life of the patient, and of course may potentially causes severe side effects. So it's what I did, what I showed you this morning is a really specialized procedure for very, very selected patients, only a few patients.
Well, recently, in our center is very much tertiary care. We now have dedicated oncology department, general surgery department, and 18 months ago, I operated on a patient she was radically operated on the uterus. But before we did that, they did transposition of the ovaries, and they asked me to take the eggs from this patient, the ova. First, I realized that we can do it when there is a permission by the oncologist. Oncologist says, yes, you can restore the reproduction later on. And as our colleagues were preparing our department, Tatiana Alexeyevna and other colleagues, during the laparoscopy, it was challenging because pretty far away with this ovary, somewhere down, especially the right ovary under the liver, I finally took 3 ova. And while we were operating on this patient and her husband was ready there, we did the implantation happen. Sorry, not implantation, insemination. And the woman now has a baby. Tell me, please, what is your take on this problem? What is your perspective? How far can we go? In which cases it is permitted, and in which cases it is too risky to allow it? What are the time limitations? You're the only one I can ask you to speak about this topic, knowing how tender, how careful, how caring you are about especially. Oh, in many clinics, reproductologist tries to get good result. Oncologists try to, God knows do what, and we should try to do this. We should have an interdisciplinary alliance of a gynecologist, oncologist, and reproductologist to ensure woman stays alive. She should have a baby after that, and this baby should have a mother, a live mother. What is your philosophy on oncoprevention, oncoprophylaxis, and the presence of a reproductive outcome in these patients? Please.
Yeah. In terms of the ovarian transposition, of course, there's risk for ovarian metastasis and treatment failure after transposition. And the risk is depending on histology. So at first, and on the stage of the patient, at first we check the stage. We don't do it in very advanced, locally advanced stages. So we do it to FIGO stage 2B, and not more. And we really talk to the patient that in patients with adenocarcinoma, the risk for ovarian metastasis is much higher compared to squamous cell carcinoma. So we talk to the patients and tell them the risk of the transposition, and then they have to decide. Normally, we do ovarian transposition before chemoradiation. but this is it's a standard procedure in our team. The other option I showed you with the full transposition of the whole uterus, it's a crazy surgery, of course, limited to a few people in the world now. And I think the Brazilian group had now one baby born after this transposition and retransposition of the whole uterus, and everything was fine. But of course, this is a potentially harmful treatment for the patient.
Dear Simona, thank you so much. It's a wonderful opportunity to be with you, at least online. Thank you.
Leila. До свидания.
Thank you so much. Dear colleagues, allow me now to please give this floor to the head of our Center on Oncology. We have only one department of oncology, excellent, great working colleagues, and Dr. Havas is now online. Dr. Havas, you will hear him, and he has brilliant, his team works fine. He personally and Dr. Avadenko, and it is my great pleasure to give the floor to Grigory Nikolaevich Habas. His presentation is titled Organ-Sparing Surgery in Ovarian Cancer. Grigory Nikolaevich, the floor goes to you. Good day, dear colleagues. Dear Leila Vladimirovna, today's presentation discusses organ-sparing operations, organ-sparing surgery. It is relevant because up to 10% of patients with ovarian cancer are under 40 years old. In today's age, later first pregnancy at later age gives us high percentage of patients with ovarian cancer who haven't realized their reproductive function. That's why we need organ-sparing surgery. Up to 13% of patients with ovarian cancer are younger than 40. Let's get back to organ-sparing surgery. The preconditions for organ-sparing surgery are, first of all, the woman wants to preserve her fertility. She has to be in reproductive age. No infertility factors have to be in play. Her reproductive potential should remain intact. Also, initial stages, favorable histotype and high differentiation. In borderline tumors, it is thought that organ-sparing surgery is possible, whatever the stage. Well, what can we do? We can preserve the uterus and contralateral ovary. This is a standard procedure. Or we can preserve uterus alone, but this is a controversial issue and requires a separate discussion. How do we evaluate the patient, whether we can do organ-sparing surgery in ovarian cancer? We divide it into 3 stages. First, pre-op. When based upon imaging evaluation, we evaluate first how locally advanced, and reproductologists look at reproductive potential and what is the fertility in a woman. Is there anything to fight for? Secondly, intra-op, when we do comprehensive surgical staging, morphological verification, as well as we look at anatomic and functional competence, efficiency of the preserved organ. Thirdly, post-op. Well, elective histological study and the patient's final decision. Well, absolute priority is, of course, oncological outcome. We need to look at survival. We must treat these patients in line with all the guidelines and recommendations, both for radical surgery. When impossible, for whatever reason, to preserve the organ, we try to spare, if we can, genetic material. This is where we look the whole range of technologies that are available for reproductologists in cryoconservation of the embryos, of the eggs, IVF, and whatever. Why do we do it? Why do we do surgery? Because nowadays experience is there, information and data about survival in patients with true early cancer. And this survival was found satisfactory. In maybe 5 years, survival may be over 90%. So that's why we suggest in a number of cases this technology for young women only. While total recurrence does not exceed 15%. So, in most oncological guidelines, be they Russian or international, organ-sparing surgery in early cancer is possible in first A, 1C, high differentiation, and non-clear cell histotype. About clear cell histotype, there is not enough evidence data in this histotype. And this is supported by our experience too. So organ-sparing surgery is something that should be done using same simples as radical surgery, with only one difference. In this case, we preserve the uterus, and we try to preserve at least one ovary and adnexa on one side. We should do all it takes, all the stages of surgical staging, both peritoneal as well as reperitoneal staging, to identify true stage 1 of the disease. The most difficult case and the most challenging is, of course, retroperitoneal staging. This is where we should also remove lumbar and pelvic up to the kidney level. Why? Because paraortal lymph nodes could be affected. If we do see it, it's more often seen in paraortal zone. That is why we should do this comprehensive lymph dissection. Lymph nodes in the pelvis are affected in only 15% of cases. In clinically early ovarian cancer, mets in lymph nodes are seen in up to 22-25% of cases, and this immediately moves the patient into stage 3. No questions of organ-sparing surgery here, unfortunately. That's why we need to have comprehensive surgical staging. In low-grade cancers, when it requires lymphodissection. In serous low-grade cancer, it may be up to 11%. In endometrioid cancer, it is insignificant. And in mucinous early G1, this lymph node involvement is close to 0. That's why in this, you may skip it in this case. So how does systemic lymphodissection affect in the risk of survival? Regrettably, there's not evidence data to speak about the systemic lymph dissection on survival in these patients, let alone that there is data available. The stage goes up in almost 22% of cases. There certainly affects adjuvant therapy that we offer, and in our target therapy in this small group of patients, this brings marked benefit in survival. For example, when we prescribe target therapy in patients with mutations. However, in general, the influence of lymph dissection so far has not been proven. And the study that you see on your, it's a new perspective loaf of the Chinese authors. It will help us give an answer to the question, does lymphodissection, does lymphadenectomy, does it play a role in early survival? Why high differentiation? Some data in literature say in case of high grade, when we have G1, low grade, sorry, G1, recurrence pattern usually stays within our control. Ovaries, smaller pelvis. This table hovers over 50, almost 60% of recurrence. Look at this. As these authors say, is in the ovary usually. And if we look at this low grade, grade 3, high grade, G3, then this is the degree of canceromatosis. So there can be no talk of organ-sparing surgery, no mention. That's why the guidelines introduced this technology only for low-grade tumors. Surgical access, surgical approach in early ovarian cancer, preferably would have laparotomy. However, laparoscopy is also part of many guidelines. It's possible. In case where the tumor cannot be damaged, when excluded, and we do all it takes for surgical staging. When these preconditions are met, then laparoscopic approach doesn't really impact the oncological outcomes in early ovarian cancer. In some cases, this approach is well justified. Reproductive outcomes. This table in red highlights that out of 42% of women who preserved their desire to fall pregnant later, to conceive, over 67%. Our own experience, very briefly, we calculated, just in preparation for this Congress, we did 147 operations because of early ovarian cancer. Out of them, 70% are radical, and only 31% did receive organ-sparing surgery. Who were they? Young patients. Mean age, average age was 32. Stage mostly 1A, 1C, and histotype cirrhose was the prevalent histotype. Reproductive outcomes as of today. 29% do not plan to fall pregnant, do not want to, regrettably, do not want to conceive. 20% do plan, 25%, and 46% as of today have conceived, are pregnant. 60% have delivered. 24% we operated them in pregnancy. This is specific of our center. And in 16% of pregnant patients with early ovarian cancer, the pregnancy is still preserved. It means that their reproductive function is retained, pretty high. So conclusions, and after conclusions, with your permission, if time allows, a minute or minute and a half, a short video that shows main stages of the operation. Organ-sparing operations because of early ovarian cancer are safe only in heavily pre-selected patients. It should be discussed and counseled by reproductologists. This operation can be done in fully staged low-grade tumors and non-clear cell tumors only. What is important? We don't have enough evidence to show the efficacy and safety of this method. This is something that has to be discussed and considered with the patient. We may use mini-invasive access if it doesn't increase the risk.
And naturally, treatment of such patients must be done by a multidisciplinary team of specialists. Now, dear colleagues, the major stages of organ-sparing surgery for ovarian cancer. First of all, peritoneal swabs at next to peritoneum from the side where the lesion is. Biopsy is done contralaterally. Then peritoneal staging is performed, subtotal resection and subtotal omentectomy, or the resection of the great omentum. Here you can see the stage on this video. Then multifocal biopsies are done of the parietal abdomen, and then retroperitoneal staging is done. That's pelvic and lumbar lymphadenectomy with the removal of major groups of lymph nodes, both pelvic and lumbar, including renal vessels. This video shows the final stage of this procedure. Well, inferior vena cava, bifurcation of the aorta, main lymph nodes are removed. You can see the laparoscopic approach is being used, and here's the final stage, the uterus with the preserved contralateral ovary, the areas of lymphodissection. The patient has been fully staged, and then you can see it's stage 1 established. Even in the era of imaging, there might be situations like this when there is the retroperitoneal staging, and well, sometimes we can find, although this is a rare case, the metastatic lymph nodes. Here is stage 3, and of course, organ-sparing surgery is not performed in this case. In this case, we use the standard radical surgery. As you can see it here, this is the condition after the lymphodissection. Thank you very much for your attention, dear colleagues. That's all there is to it. Well, dear colleagues, you've heard Dr. Habos's presentation. Gregory is head of the department of our center, oncology department of the Kolokov Center. And once again, I'd like to reiterate a thanks to this department. And we've got wonderful surgeons, wonderful surgical technique. We've got more and more opportunities to preserve the reproductive function in oncological patients. We have also a wonderful genetics department. We have wonderful chemotherapy. So I must tell our colleagues from the regions of Russia, well, we do not reject your patients. Send them to us. Thank you, Gregory. And now I'd like to give the floor to Professor Avodenko. The theme of the presentation is cervical cancer. And please be specific about the timelines. Do not overexceed the timeline. Dmitry Avodenko, cervical cancer, possibilities of modern surgery. Do not overrun your time, please. Mr. Avodenko. We can see you, but we do not see your presentation. All right. Good afternoon, dear colleagues. Good afternoon, Leila. Thanks for the opportunity to participate in this Congress and to present our data, modern surgery, possibilities of modern surgery in case of cervical cancer. More than 600,000 new patients are being detected. Well, you can see usually these are later stages and they are not included in this presentation. In this case, we cannot use surgical methods. Usually, chemo or radiation therapy is administered to such patients. Well, this was mentioned in the previous presentations. Today, I'm going to talk about patients who can be sent to surgery. Of these patients that we detect with cervical cancer, there are patients younger who are 35 in 56% of cases. As for the mortality rate, 23% up to the age of 40. Cervical cancer is the main reason of mortality under 40 years of age. Also, there is a trend toward an increase in the number of patients with cervical cancer with unfinished reproductive stage. Well, you can see staging is done primarily using the clinical methods as far as cervical cancer is concerned, but MRI was not included in our recommendations. Right now, according to updated recommendations, MRI is a reliable method to detect the tumor process. This method is included in the standard of detection according to MCCN, NCCN, European recommendations, and Russian recommendations. As for MRI, it can help us detect cervical cancer when the size of the tumor is 1 centimeter and more. In case of microinvasive processes, MRI is less sensitive. A few words about surgery in case of cervical cancer. We're talking about the initial stages of cervical cancer. Well, extended extirpation of the uterus, radical tracheotomy, and organ-sparing procedure, colonization or amputation of the neck of the uterus. As for types of surgeries, and there are several classifications, I'm not going to go into detail. You can see them on the screen. And if it's locally advanced forms, well, like stage 1, B3, well, usually it's a neoadjuvant chemotherapy, which is being used only for research studies because the results have shown that neoadjuvant chemotherapy doesn't improve outcomes of such patients. So as of today, all leading clinical communities claim that when it's 1B2, it's radical surgery. In other cases, chemo radiation therapy using the radical program. Other ways of treating such patients are used only when they're included in different pilot studies or research in major centers. As for surgical treatment, for cervical cancer. Well, usually the laparoscopic approach was used for a long time. The results were not bad when the randomized trial was conducted in 2018, when laparotomy was used as the new standard for surgical treatment of such patients. As of today, if you look at new guidelines, laparotomy is being used as the preferable approach for such surgeries. Both European and American and Russian guidelines stipulate that fact. After this study, there were other studies conducted that showed that when some protective manipulations are done, the results of treatment can be improved, but the sampling was not quite large, and that is why the results were not included in official guidelines. Yes, all these trials had some limitations, and I will touch upon them later. As of today, laparoscopic procedures, well, are included in all guidelines in patients with a low risk of progression of disease. That's after the colonization of the neck of the uterus with small uterus and without other risk factors, such as lymphovascular invasion or rare histological types. And usually we do not use manipulators in this case. We do not use intraperitoneal manipulators, and usually the surgeon should have a lot of experience in such situations. Here is our experience. Well, you can see that we have conducted more than 300 procedures for cervical cancer, and we have a similar number of laparoscopic procedures and open surgeries. Well, our data have shown, like you can see it here on this graph, the number of laparoscopic procedures. Progression-free survival amounted to about 96%. A few words about the data obtained when we analyzed these procedures. As for the length of perimetrium and the number of lymph nodes are basically the same when we use different approaches, so that's quite explainable. And again, you can see the comparison between laparoscopy and laparotomy. Well, you can see other data. They're basically the same, no major differences in terms of the duration of the procedure, not in terms of the hospitalization duration or blood loss. Well, all these data are basically the same, and we usually not do C1 procedures because we believe that, well, the concept of the spread of tumor cells plurineurally is the same, and we try to use radical procedures to achieve more functional results. I would like to show you some tricks how to perform such procedures. They are rather simple. They do not demand any additional preparation. We do not use manipulators, uterine manipulators, to do the manipulations inside the uterus for extended hysterectomy. We use the Vicryl needle suture. We can do a very good fixation, and we can just perform all the manipulations related to dissection in all spaces, in all planes. I'd like also to say that, again, I'm going to reiterate this. I will just speed up the video. Well, these are standard stages of the surgery. We never do C1 surgeries because we believe that it's not worth doing it. We don't want to reduce the radicality of the procedure in favor of more functional results. In fact, we had few cases when, well, urination was not fully restored, even when we used the radical surgery. Almost in all patients, sooner or later, the function of the urinary bladder can be restored. Well, these are the standard stages. I'm not going to touch upon them. You can see standard stages of the procedure related to the dissection of the ureter, dissection of the parametrium, and I'd like to just draw your attention to the fact that in our study, unlike previous presentations, we had just few urethrovaginal fistulas. Basically, there were almost none of them. Can you launch the video? Well, as I said, there were no urethrovaginal fistulas detected. Well, as for this particular patient, we used the ovary for tissue cryoconservation to preserve her fertility function. Parametrium was mobilized, and again, before we do the dissection, we use the vicryl suture and we isolate the cervix fully together with the tumor so that there could be no any impact, any contact with the adjacent tissues of peritoneal gases and other abdominal tissues, abdominal cavity tissues. At this stage, we do the resection within the boundaries without any contact. As you can see here, below the ligated area, we do the dissection. And after this, we just remove the uterus from the cavity, abdominal cavity. One way or another, when we use any approach, any method at the end of the procedure, the following structures should be visualized. Well, levator muscle, the pararectal vessels and median surface of the internal iliac vein. Well, on the basis of the data obtained, and these are randomized clinical trials, we need to review the use of laparoscopy for cervical cancer. We need to improve the technique of the procedure. We should have a better selection of patients, and in this situation, I think evidence-based medicine principles sometimes are not applicable. The radicality of the surgery is based on the previous experience of a surgeon, despite the fact that any surgeon who operates for cervical cancer believes that his method is most radical. We witnessed the situations when radicality of the procedure can vary depending on the healthcare facility and from surgeon to surgeon. That is why there is a need to conduct new RCTs, new randomized controlled trials. Well, radicality should not be diminished when we use the laparoscopic approach as compared to open surgeries. Once again, we're talking about the types of the procedure. Type C1 surgery should be limited in use, and surgery for cervical cancer should be performed in healthcare facilities where there are all the necessary equipment and specialists. Thank you very much for your kind attention. Thank you, Dmitry, for making this wonderful presentation. Dear colleagues, once again, I'd like to say that the Kolokov Center for Obstetrics and Gynecology is the leading center in Russia, but as our director, Dr. Suhik, has said, that's a big aircraft carrier. where all the departments are present: general surgery, oncology, chemotherapy, mammology, and of course our standard departments, operative gynecology. Every year we perform several thousand procedures. The time has passed before us when we were afraid of hospitalizing severe patients. Now we can operate on all women, refer them to us. We'll be glad to accept them. We have all the necessary equipment. We do the staging. We can do genetic tests, reproductive oncology, oncofertility, and we have wonderful operating technique. And we have an alliance between the members of the multidisciplinary team. Right now, we're going to have a 2-minute break. There will be a video clip, and then we will start the new plenary session, Current Gynecological Issues on the Basis of New Technologies. Dr. Ikoka Ota, The New Era of Gynecological Endocrine Disorders, Polycystic Ovarian Symptom. Please put on a 2-minute video, and then we'll give the floor to Dr. Ota. Distinguished colleagues, let's move on to the next plenary session. As you can see, we're keeping abreast of time, and during this plenary session there will be the presentation of Dr. Otta. Well, she will get connected in 5 minutes, and I will present some basic information, and we'll wait for her. Dear colleagues, well, yesterday we had 3,800 people. Well, this morning we had 800 and 1,500 people, and now we have more participants. I cannot even monitor the situation as far as the number of participants are concerned. And Dr. Ikoka, The New Era of Gynecological Endocrine Disorders, Polycystic Ovarian Symptom, POS. Then there will be the presentation by Ben Raphael, Riff and Era, also Dr. Valsky, Dr. Viretsky, and many others, while Ikuka is trying to get connected, since this particular plenary session is called Current Gynecological Issues on the Basis of New Technologies. I would like to give the floor to Dr. Makarova. Please, Dr. Makarova, start your presentation. Then Silachov, Sisoeva, Kalinina. There are several authors. Therapeutic opportunities for extracellular vesicles and reproductive medicine. Please, Dr. Makarova. Well, good evening, dear colleagues. Therapeutic opportunities of extracellular vesicles in reproductive medicine. Extracellular vesicles are the subject of research at the Kolokov Center. Our department deals with this, the Leonov department, and the Cellular Technology Lab headed by Denis Silachov. I have no conflict of interest. Well, I should say that in this presentation, well, the process of selection of male stem cells is difficult. When the sperm moves to an oocyte, well, poor sperms are being rejected due to different characteristics, and only 10 in the 7th power sperm get into the vagina. Sperm are being attacked by the immune cell system. In the cervical canal, 10 times less sperm get there. Well, and viscosity of mucus plays an important role, and sperm are selected on the basis of motility. Sperm are unique cells which like to overcome various obstacles, various barriers, such as pH, which is not acceptable for them, and also moving against the tide movement, depending on the gradient of the temperature. When sperm move inside the uterine cavity, there is a process of selection. Sperm interact with the immune system cells. When male gametes get into fallopian tubes, and there are usually 10 in the 4th power sperm get into the tubes, that's the environment which is not quite aggressive for male gametes. And here, the situation is quite favorable for conception and for the development of embryos. And you can see this is the cellular odyssey, as Judith Kergert said in her book, The Dance of Life. Well, we haven't studied this process, and I should say that the interaction of the cells of the female reproductive tract and sperm usually takes place through the extracellular vesicles of the biological fluid. Right now, it is quite obvious that the cells of the female reproductive system and sperm are annihilated by these vesicles, and they carry different proteins, lipids, non-coding mRNA, and also these extracellular vesicles can be potential markers for male and female infertility. At our department, we have a large project underway, the regulatory role of extracellular vesicles of biological fluids in processes of gametogenesis, in conception and early genesis. Right now, we have passed through 3 stages. Stage 1, we do ultracentrifuging, and we isolated extracellular vesicles from the follicular female fluid. We added them to non-ripe oocytes at the first stage. Then we took female follicular fluid. We identified extracellular vesicles. We added them to embryos donated for scientific purposes. Stage 3, which is also at the stage of completion, we cultivated the endometrial cells in petri dishes, and we isolated the extracellular vesicles, and cultivated them with the sperm of the donor. At each stage, we were interested in what was happening when gametes were interacting with embryos with these extracellular vesicles. In January, we made a presentation on EV-IVM when oocytes got the extracellular vesicles identified from the liquid of the fertile donor. When such vesicles were added under zonal pellucida, this allows us to have ripe oocytes, and unfortunately, right now they're being just discarded in IVF procedures. But yes, there is an IVM procedure, but IVM requires cumulus cells and granulosa cells, and if oocytes are ready for ICSI, so they are free from cumulus cells, such oocytes can not become ripe, and we're trying to use EV-IVM procedure in this case. Later on, we analyzed the interaction of extracellular vesicles and male sex cells. It was important for us to understand what is happening in this area in case of ovulation in the fallopian tube when sperm got into them. And we found out that extracellular vesicles usually bind with the head of sperm, thus improving their progressive motility and improve their hyperactivation. So extracellular vesicles of the follicular fluid play a key role not in just improving the quality of oocytes and embryo development, but also they induce capacitation. They prepare sperm for conception, for fertility. They activate hyperactivation of sperm, acrosomal reaction, and all this improves the process of fertilization, quality fertilization. As for reproductive tracts, when the vesicles get in, this leads to better fertilization.
We also established for the first time using electron microscopy that these extracellular vesicles build into the membrane of the sperm cell. This improves RNA content in sperm and helps influence further development of the embryo. But is still a hypothesis that requires proof. Using an immunofluorescent assay, we showed that cell-free vesicles in follicular fluid of younger women influences in a very different way on the sperm cell compared to women who are over 40. Indeed, we see a slowing decline in women over 40, and these vesicles are not that active in connecting to spermatozoa, unlike in young patients. So in 60 minutes after incubation, you see the linking of the vesicles, they are in red, of a young patient. But in this slide, in red, you see fewer. They are extracellular vesicles in women of late reproductive age. So immunofluorescent assay shows that follicular fluid takes part in the maturation of the oocyte within the follicle, but it also impacts the spermatozoa. It is needed to ensure normal fertilization. So it's important to optimize IVF, especially in patients where there is tubal or peritoneal infertility. The fallopian tubes are fully non-patent. So we thought we would improve the culture conditions using uneuploid embryo of young patients into cell-free vesicles of the donor, because we found out it is exactly young patients who have much more active extracellular vesicles. This cultivated embryo that were donated for education and research, it showed that in this young patients, the activation of the genes were responsible for cell division and proliferation. extracellular vesicles seem to be activating the development of the embryo, but it is in women of middle-aged, meaning 36 and older. These embryos from such patients, in case of co-culture with extracellular vesicles of the younger donor in embryo, are suppressing apoptosis in embryo, which is follicular fluid. It's needed to ensure fertilization in humans, no matter where it happens. But it's highly likely, and many books write about it. Regrettably, it's impossible to look within. Fertilization is happening at the very start of the follicular tube, where follicular fluid seems to be flowing into. On the next stage in this video film shows it, we took on endometrium of a donor and cultivated it in a petri dish. We built primary culture of the endometrial cells. What mattered to us most, to find out how spermatozoa behave when they get into uterine cavity. The thing is that to reach the oocyte, the spermatozoa have to travel a huge way, including all the cavity of the uterus. We were interested to see what is going on, how this interaction takes place using electron microscopy and IFA. We showed we showed that extracellular vesicles are connecting to the spermatozoa. So these vesicles do promote progressive rising number of motile spermatozoa in the uterus and endometrial cells within the uterine cavity. They seem to be expressing the extracellular vesicles. They seem to be like pushing in spermatozoa to be more motile. And those spermatozoa who do not respond to them remain within the uterine cavity and are later to be exterminated by the immune system. To show you that extracellular vesicles are not really excreted by the spermatozoa. Instead, they are binding to endometrial cells. This is differential staining. In red, you see spermatozoa that got bound to the extracellular vesicles. And in blue, you see nuclei. So it is endometrium that initiates it. It all seems to be promoting to the selection of the top best male sex cells that take part. These charts show significant increase in motility of progressively motile and non-motile spermatozoa when they're co-cultivated. You see in the right rising number of spermatozoa who changed the nature of their movement, motility. They change their tracks when they go through the cavity of the uterus. In our case, this is the endometrium cells that were cultivated in a petri dish. As of today, these are the main outcomes that we will try to adopt universally in our clinical practice, in our VF practice, and we shall also continue doing it since this is very interesting and it helps get into the very fundamental basis of fertilization in humans. And in this way, it may help optimize the therapy using assisted reproductive technology. Thank you for your attention. Dear colleagues, you listened to a unique person, a young lady, tender, beautiful. It's very much like in a dance. The alliance should be there of the spermatozoa and of the egg cell, and our director seems to be speaking on this, and this is a fantastic feeling. Our center very much, like many years ago, has created this lady Dantsova. This is the most advanced center in this country and not alone. I do think that in the very near future, given such alliance with other departments, our reproduction of this country, of our center, It's one of the probably on the very cutting edge of science, and we look forward to getting very good results. You listened to a presentation by Makarova Natalia Petrovna with the team Sivachov, Sisoeva, and Kalinina. This is exactly a department that created the first baby. Thank you so much, Natasha. All the best in further care for your patients and a very good health. It is my pleasure to give the floor Ikuka Ota. The speaker hails from Japan, our fantastic colleague. The new era of gynecological endocrine disorders, polycystic ovarian symptom. Thus, I open the new session, and I don't want us to stop. We have a fantastic connection. Everyone works. Everyone is on time. So, dear Ikoka, thank you very much for being with us. The floor goes to you, please.
Okay. I'm very honored to be invited. So my sincere thanks to Rera. Your friendship is one of the most important things in my life. Thank you. And so I choose these topics for today presentation because I would like to give some suggestions about PCOS. Our lives are becoming more developed and the birth rate is declining. One of the most important female diseases in society with declining fertility is PCOS. This is because PCOS is associated with a long period of exposure to unopposed estrogens during infertility, which may lead to the development of estrogen-dependent diseases, such as uterine cancer and breast cancer. PCOS is the world's most common metabolic endocrine disease with a prevalence of approximately 20% worldwide in reproductive females. As you may know from experience, it is hereditary. However, despite several studies, the gene and form of inheritance have not yet been identified. This may be due to the fact that the diagnostic criteria for PCOS are vague and that the trait is expressed only in female, with males not being considered. It is also difficult to identify because of epigenetic changes. Well, mankind experienced an ice age, and all of us are descended from Neanderthals who survived in part of Africa at that time. During the ice age, we had to contend with starvation, lower temperatures, and the loss of deeply rooted daily rhythm. Starvation required women to ensure superior or fewer offspring and reduce glucose tolerance. The drop in temperature also required the storage of fat and the efficient use of energy. In addition, the loss of the deeply upset daily rhythm required a positive cycle that was not constrained by the deeply upset daily rhythm and the liver metabolism that could tolerate vitamin D deficiency. In order to adapt to the changing environment, a constitution was selected that was more prone to epigenetic changes. These changes are thought to have altered a variety of metabolic genes, resulting in the masculinization of women, and most relevant is the change in autophagy. Let me explain autophagy. The role of autophagy is generally understood to be to secure a source of nutrition through self-digestion in order to survive starvation. However, it also lacks the metabolism of cellular components alongside the proteasome system under normal circumstances. Alteration in this autophagy gene, AFG7, have been reported to be associated with the pathogenesis of PCOS. Autophagy is a cellular mechanism for degrading intercellular proteins. When cells are starved, fat vehicles called sequestered membranes appear in the cytoplasm. The membrane then elongates while taking up cytoplasm, and the tips fuse together to form autophagocytes. The autophagocytes also contain large organelles such as mitochondria, and when the autophagocytes fuse with the lysosome, the inclusions are degraded. Amino acid obtained from self-digestion are recycled as a nutrient source. In order for cells to carry out their biological activities, they need to express necessary genes and biosynthesize biopolymerase such as proteins. Proteins are micromolecules composed of amino acids, and cells need to take in essential amino acid from outside the cell as a source of nutrition in order to carry out their vital activities. The starvation of an individual, resulting in nutrient depletion and cut off amino acid supply, can be severe life or death damage to the cell. Therefore, when cell becomes starved of nutrients, they undergo autophagy, and the obtained peptide and amino acid are used as materials for synthesizing proteins, which are more important for life activities. For example, when mammals are born, when the supply of nutrients through the placenta is cut off due to childbirth, the fetus becomes temporarily nutrient starved until it received nutrient from breast milk. At this time, by producing amino acid through autophagy, it survives nutritional starvation. So, returning to the topics of PCOS, the PCOS is resistant to starvation, and it's thought to be a state in which this normal autophagy is suppressed. I will show you the merit of PCOS. Less energy can be used and stored efficiently. And hyperandrogenemia, high skeletal muscle mass, and high thermogenesis. And the synthesis of androstenedione in skin is high, and the sebum is high. No dominant follicle selection in follicular recruitment. So PCOS is resistant to starvation and cold temperatures. In addition, PCOS is overactivated by the serine-threonine kinase pathway. The PI3K ACT pathway is present in all cells that require insulin-mediated energy production, including ovaries. Overactivation of the PI3K ACT pathway is cancer, diabetics associated with many human diseases, such as cardiovascular and neurological diseases. In cancer, two types of mutations have been found that increase in endogenous PI3K activity. In addition, mutation and deletions of P10 are frequently identified in human tumor cells. PI3K ACT pathway is known to be activated by AMH and suppressed by P10. So PCOS is a pathological condition caused by hyperactivation of PI3K ACT pathway. Thus, as you can see, PCOS present metabolic disturbance not only in the ovaries but also in multiple organs. So PCOS is a constitution that becomes disadvantageous in era of safety and declining birth rate. PCOS is originally genetically resistant to starvation when exposed to unhealthy lifestyles. Epigenetic changes occur easily induced. In PCOS, autophagy is suppressed and the PI3K ACT pathway is overactivated, resulting in metabolic disorders that affect multiple organs, mainly obesity, infertility, fatty liver, hypertension, and type 2 diabetics. Furthermore, PCOS has been pointed out to be epigenetically related to ovarian cancer and endometriosis. It is well known that insulin resistance causes hyperinsulinemia, hyperandrogenemia, and long-term exposure to unopposed estrogens approximately triple the incidence of endometrial hyperplasia. However, hyperestrogemia and long-term exposure to unopposed estrogens also contribute to the development of endometriosis. Hyperinsulinemia leads to increased androgen levels that stimulate growth of epithelial cells in the ovary. The PI3K ACT pathway overactivated in endometrium with PCOS is also a leading factor of ovarian cancer. Through a comprehensive transcriptome data analysis have discovered that PCOS, endometriosis, and ovarian cancer shared similar biomarkers. Cancer pathways are biological processes were shown to be enriched in the three disorders, suggesting that they may all play a role in interconnecting these three diseases. There were 403 shared genes between the three disorders, according to comparative gene analysis. Also, their regulation patterns were not the same in each. From comparative analysis, it was found that all three illnesses shared 32 microRNAs. Some of the genes that are involved in endometriosis development include ARID1A, KRAS, and PI3K ACT pathways, which also have an important role in polycystic ovary syndrome and tumor development. ARID1 and P10 in the endometriosis lesions that causes the activation of the PI3K signaling pathway, which helps in the proliferation and growth of the cancer cells observed in clear cell ovarian cancers of endometriosis-associated ovarian cancers. The diagnosis of PCOS is based on the Rotterdam criteria and it is made when two of the following conditions are met: amenorrhea or oligomenorrhea, and the second, hyperandrogemia, and the third is polycystic ovarian morphology. However, symptoms are multi-systematic and diverse. It is metabolic disease that is first detected by gynecologists because the symptoms found in young patients are gynecological symptoms: anemia, dysmenorrhea, and irregular uterine bleeding in youth can also aid in the diagnosis. Metabolic diseases such as cardiovascular symptoms, fatty liver, and diabetics develop after middle age. As part of women's medicine, we in gynecology need to diagnose PCOS early and administer progestin as soon as possible for its anti-androgenic and anti-estrogenic effect. Metformin and other drugs should also be administered as needed to improve metabolism. So, PCOS is associated with endometriosis, ovarian cancer. Early diagnosis and intervention from a young age is required. In addition to the Rotterdam criteria, biomarkers such as AMH and microRNA are used to diagnose PCOS, and early and accurate diagnosis will be desirable in the future. Thank you for attention.
Great, nice girl. Great presentation. Моя дорогая, да, моя...
My dear Ikuka, fantastic presentation, fantastic slides, and you are so beautiful with us. You love Moscow, you love our center. Thank you very much. Thank you. Till we see you again. Thank you. Thank you. Спасибо большое. Спасибо. Спасибо. So, dear colleagues, it is my pleasure to give the floor to Professor Dan Valsky from Jerusalem, Israel. New ultrasound imaging techniques to determine treatment tactics in gynecology. I'd like to say that Dan is a fantastic, brilliant OB/GYN and ultrasound specialist. He knows so much, especially in questions that have to do with development of the fetus, uterine development defects, fetal defects. Dear Dan, please, Zion Ben Rafael also is online, but since we now announced your presentation and we promised you would go, please keep to the time. We would very much appreciate that. So, new ultrasound imaging techniques to determine how to further manage patient in gynecology. Dan Valsky, a great friend of our center. Please, the floor goes to you. You're on live. You're live. Please start.
Добрый день.
Good day. Good day, dear colleagues. First of all, I would like to thank the organizers of this Congress and Leila Vladimirovna for the opportunity to speak before this distinguished audience and give a presentation on this topic. My topic today has to do with the technologies of gynecological ultrasound and how they immediately are related, how they impact our gynecological practice and our clinical decisions that we make. There are a lot of, most recently, lot of novel technologies that are become available in ultrasound, especially it has to do with gynecology. I chose some of them that we will present to you today and their clinical application. We'll speak about 3D ultrasound. We'll look at the congenital uterine cavity defects. We'll speak about hysterosalpingo contrasonography, how to assess ovarian reserve using 3D sono AVC technique, and several examples about the use of Doppler in gynecology and the example of ovarian torsion. The first thing I'd like to tell you is using 3D ultrasound, congenital uterine anomalies. We know that congenital uterine anomalies, malformations, are seen in about 0.5% in the general population and almost 10 times in women who have infertility, and up to 40%, as some authors claim, in women with multiple recurrent pregnancy failure. Well, so pregnancy loss. For most, we see uterine septum pathology, almost a third of all genital malformations, and everyone knows that in a large number of cases, these malformations go hand in hand with the renal pathology. Today, they are related not only with recurrent abortions in first and second trimesters, but also with a high placental pathology, C-section that goes up, the risk of eclampsia, intrauterine development, growth retardation. This scheme seems to be putting into a system the connection between different groups of congenital pathology and complications. We do say that all have to do with malpresentations, they all have to do with preliminary early development, and septate and bicornuate uterus have to do with abortions, spontaneous abortions in first and second trimester. 3D ultrasound. Well, in gynecology, its role is most marked and its contribution is most marked exactly in diagnosing the pathologies of uterine cavity. And it has to do with this 3D ultrasound, helps us get clear coronal projection that we needed to do laparoscopically to evaluate the external contour of the hysterosalpingography to evaluate the internal. Today, this is only one thing. You can use 3D ultrasound or using MRI. Well, there's examples where coronal section or coronal plane helps us evaluate the external and internal contour of the uterine cavity too. Today, there are a lot of publications where the authors have clearly shown that 3D ultrasound is not inferior and maybe superior.
Can be as accurate as other methods, including hysterosalpingography, including traditional ultrasound, and including even MRI. Well, maybe we can see here how the pathology of the uterus with the septum, this is the 3D US ultrasound imaging, but just using at this picture, looking at this picture, it's difficult to say about the length and the thickness of the septum. Well, 3D usually doesn't give us this imaging, but 3D ultrasound allows us to see everything. You can see the septum goes through the entire cavity, through the internal os, and separates the cervical canal. This example shows the cavity, the way it looks like normal on 2D ultrasound, but on 3D ultrasound, we can see that here we have a case of unicornuate uterus. There are other technologies which are more specific, such as OmniView, which is also a 3D ultrasound. OmniView allows us to get a 3D layer. It may not be straight. Modern technologies allows us to look at the direction of the uterus. Here we're talking about a two-cornuate uterus with the septum going through the entire cavity as well as the cervical canal, as you can see on this example. All this was the foundation of a new classification, which was published in 2021, and this classification is more accurate. It has replaced the American Fertility Society classification of 1988, and now we can classify different pathologies, including cervical pathology, vaginal pathology. Now we have standardized terminology, so I recommend you use this tool. You can download it on the internet. It is an interactive tool. It allows us, after making a diagnosis, to identify a group of patients, see what can be, the best treatment, and also to get information related to clinical issues. Another method is sonohysterography. As you can see it here, it is widely used in gynecology. Sonohysterography, or infusion sonography, or contrast hysterosonography, has replaced traditional salpingography, hysterosalpingography. Before that, the hysterosalpingography was associated with radiation, with introduction of contrast media. This procedure was not quite convenient, but right now, sonohysterography can be carried out in any office where there is an ultrasound machine. We can get the same range of answers as hysterosalpingography. In this case, we use the so-called sonocontrast media. It can be just normal cells with air bubbles or agitated cell. There are special sonocontrast substances such as Ercovist, which is injected into the cervix, and we can see the uterine cavity very well, and then we can see the patency of fallopian tubes. Here is another example as hysterosonography can show us phase 1, then the contrast media is injected, and we can see the contours of the uterus. We can see small masses which usually escape us when we use the usual ultrasound without the contrast. Usually they look like small polyps, and we can see the agitated saline with the air bubbles goes through the fallopian tubes, and we can see what is happening to this substance along the fallopian tube. We can establish the patency of the fallopian tube, which is important for fertility restoration. Another important thing is that this method can be used to detect synechures and adhesions in the uterine cavity. Without a contrast media, it's difficult to do. We can see here that the fluid shows that there are some formations here. You can see it on 3D ultrasound. There are lots of adhesions in the uterine cavity. Another technique which has existed for more than 10 years is shown here. It is used to assess the ovarian reserve. The ovarian reserve has a clear correlation with the volume of the ovary and with the antral follicle count, up to 10 millimeters, and we can count the number of antral follicles by using traditional methods or using the new 3D technologies such as sono AVC, automatic volume calculation. That's what AVC stands for. These technologies allow us to calculate all the hollow structures. And if we're talking about the ovary, we can have a clear picture about the antral follicle count. And this software can also be used for the automatic count of follicles, not just antral follicles, but also in women who undergo stimulation. In this case, we can have a full picture and the description of the number of follicles and their size. Doppler can also be used in gynecology. Today, I'm not going to talk about the part which is linked to the description of ovarian mass with the differential diagnosis with benign or malignant masses of ovaries. Let me just give you several examples where Doppler is playing an important role, even in case of simple diagnosis such as acute salpingitis. Usually the fallopian tube or the uterine tube, when it is normal, we do not see it on ultrasound. It is becoming visible when there is the contrast around this tube. There is a liquid around this tube, or there is a liquid in this tube, as we see it here, and hyperemia of the enlarged wall of the fallopian tube. Well, in fact, proves that there is acute salpingitis. Well, we can also see it on another example. Here you can see expanded uterine tube with the manifested blood flow, which is usually not quite visible. It is inside the fallopian tube. We can see the tubal ovarian complex, a conglomerate of inflammation, and you can see the contours of ovaries, the contours of the tube. This is the tubal ovarian abscess, and we cannot see boundaries quite well. Boundaries merge. Here is another example where Doppler can be used in clinical practice. That's to detect different acute gynecological pathologies. As an example, I've chosen adnexal torsion or torsion of ovaries. Well, torsion leads to severe pain, and often it can lead to the situation when a woman is hospitalized in the emergency room. It can cover the entire adnexa, or just the tube, or just the ovary. If it is in the area of the ovarian ligament, it can also be in the area of the IP ligament, and this condition usually occurs, as experience has shown, is not quite rare. We do encounter such conditions several times a week in our clinic, and you can see adnexal torsion clinical conditions can be different. They can be acute pain in pelvis, or it can be chronic pelvic pain, or bilateral pain can be also bilateral adnexal torsion. Well, clinical manifestations can be different. This diagnosis can be very tricky in terms of making it, so you should have enough confidence to make the right diagnosis. Let me just give you one or two examples which demonstrate why it is important to make up the right diagnosis. A 35-year-old woman who came to our clinic on week 25. Well, first she was pregnant with 5 fetuses. Now it was reduced to 3. She had severe pain in lower abdominal pain. We conducted tests for several hours, and we realized that there might be dehiscence or even the rupture of the scar she was operated on, but it turned out that the scar was quite okay, and the problem was the adnexal torsion, which was not diagnosed. Another example, a 13-year-old girl who was totally asymptomatic at the time of examination. But during the last several months, she went to see several doctors because of the recurrent pain. Well, the pain came and went away, came and went away. She had normal ovaries, the normal uterus on ultrasound. But as a result, we can see that here she has normal ovaries, but there is the adnexal torsion, which covered only the fallopian tube. You can see the way it looks when laparoscopy was done. So this diagnosis can have different manifestations. Different differential diagnosis is needed here, and Doppler will help us make the right diagnosis and to see different additional diagnostic aspects, but may not be very specific, such as enlarged asymmetric ovary, adjacent free fluid, stromal heterogeneity, when we have additional follicles or peripherally displaced follicles, when we can have ovarian mass or lesions, all these aspects tell us that we must send a patient for making the special diagnosis, such as ovarian torsion. If we just use all these indirect signs, well, the adnexal torsion diagnosis can be confirmed in 20 to 70% of cases, depending on how you do your job. In some cases, it's important to make the right diagnosis, the correct diagnosis, when we're talking about pregnancy, when we're talking about the possible surgery, when the surgery was complex and the risk is very high, and when there is a discrepancy between the clinical and ultrasonographic picture. Here is an example how the Doppler test can help us, and you can see also the whirlpool sign, which can help us suggest that this diagnosis is adnexal torsion. We can see also the ligament itself, and in such cases, when the diagnosis needs to be confirmed, that we should do it. We can see what the whirlpool sign looks like. Well, it's the situation when Doppler was not used. At the top and at the bottom, we can see the circular vessels involved, and also you can see the way whirlpool sign looks like with Doppler and without Doppler. Here is another example, a 26-year-old woman, 11th week of pregnancy. She is totally asymptomatic. She has complaints such as manifested pain on the right side. Her right ovary is a little bit enlarged. So, well, it looks like there is an explanation to her pain, to cysts in the ovaries, but the real explanation is the torsion. And you can see that in the area of the ovarian ligament, well, whirlpool sign helps us make the right diagnosis. And how the use of Doppler allows us to see this torsion and the circular vessels. And the last thing I'd like to mention is that this technique allows us not just to make the right diagnosis of adnexal torsion, but also to exclude the torsion when it is important to see whether there is torsion or not. When we exclude torsion of the ovarian ligament, if we see that it is straight, when we look at the vessels going from the uterus to the ovaries without any barriers, and right now the sensitive Doppler allows us to make the right diagnosis, to confirm the diagnosis, or to exclude the diagnosis of torsion when the operative risk is significant. Well, that's all there is as far as this presentation is concerned. I've shown you several examples, and thank you so much for the opportunity to speak here. Thank you, Dr. Dan Valsky. You're a wonderful ultrasound specialist. That was a wonderful presentation, and I would like to apologize before Professor Zion Bell Raphael. I tried to call him, but he did not pick up the receiver. Now he is with us, Zion Ben Raphael, and the presentation has the following title: The Meaning of Reef and Error Tests. He is the co-founder of the Congress on Problems of Obstetric, Gynecology, and Infertility. Tel Aviv, Israel. He is a friend of us. Zion Bell Raphael, please, the floor is yours.
Again, thank you, the organizer, for the kind invitation. And I will discuss repeated implantation failure and endometrial receptivity analysis. I will show you in the next few slides that failure in IVF is a common situation, more common than we would like to admit. In the last 30 years, there was a iatrogenic term, repeated implantation failure. It was coined for cases that failed 1 to 3 cycles or 4 to 10 embryos in patients under 40 years, purposely so 40 years, because after 40, the results is even less good. But the etiology of IVF failure is very rarely known. We don't know what is the reason for the failure. So we should name the situation repeated IVF failure. This is a very common situation, but not implantation, because if it's implantation, it implies that we need to do something about the implantation. Because most failures are due to the embryo. It's aneuploidy of the embryo. So it is the definition of RIF, or repeated implantation failure, is vague, it's meaningless, and not related at all to the etiology. So the treatment that we give this patient, or the change in the treatment, is not related to the failure. This is a paper I published a few years ago about repeated implantation failure being a iatrogenic, meaningless definition that generates unnecessary and costly use of add-on procedure. We know that the chances of IVF do not decline in the first 3 to 5 cycles. Likewise, recruitment of patients to new add-on treatment based on 1 to 3 failure is potentially wrong. For example, just let's take the results of ESHRE of all European countries, but this repeats itself year after year, and we have to tune the expectation accordingly. The live birth rate for all European countries is 22.2%, and live birth rate in ICSI is a bit less, it's 20%. So this is the background according which we have to operate. Potential repeated implantation failure according to the age shows you the reality. If we discuss the age of 38 to 39, it's 22. But if we go down the age to 40, and then 42, 43, and 44, the results is much, much less. So live birth rate that we discuss is for women below 40, and after 40, it's down to very low. And look at this, cases of abortion increase sharply with the age. So whoever have results that is better than 20%, please raise your hand and tell me we have better results. But think again if this is overall results or per embryo transfer or per egg collection and so on and so forth. If we just assume that we have implantation rate of 30%, which is not bad, after 2 to 6 cycles, the false positivity diagnosis of repeated implantation failure, according to some of the definitions that were tried in the literature, is 86 to 51%, 51 to 86% of false positivity. And I think this paper, which was published 2 years ago, gives you the reality of the situation. Imagine having perfect results. 95% pregnancy or implantation rate, 92% delivery, live birth rate after 3 cycles. First cycle, 64, 54, 54. So it's about 60% per cycle per 1 embryo transfer. These are women below 35, fantastic age. Repeated implantation is rare because after 3 single embryo transfer, frozen euploid blastocyst had 60% pregnancy and low miscarriage rate. So the conclusion, it's all in the embryo because it is a tested embryo. It's a perfect embryo. It's a blastocyst. So if you have 92% live birth rate, you have to do nothing. It's not the endometrium. It's not the zona pellucida or having etching. It's not a freeze-all technology that will correct it. It's not endometrial scratching and not adjuvant therapy and changes in the therapy. Everything, you cannot actually mend the embryo and have a better non-euploid embryo if it is not euploid. So by scratching the endometrium, you're changing nothing. So all in all, we have to accept that our results is highly age dependent. So below 35, we have euploidy of the embryos is 55% of the blastocyst. And it goes down and down and down. So above 40, we have 18% only euploid embryos. So the chances of implantation is about 1 in 5. So if we have to ask ourselves how many transfer we have to do in a non-tested embryo to be able to say that we had a good trial. So a good trial in a non-tested embryo is 6 blastocysts at a good age, and then 9 blastocysts at 38, 40, and above 40, you need 15 and more eggs. And if this is a cleaving embryo, then you need 20 to 30 embryo to say that these are a fair chance. We give the patient fair chances. So all in all, repeated implantation failure is not a reality. It has to be dependent on the age of the patient, and it's highly dependent on the euploidy of the embryo. So then we have to recalculate for each case according to the age. Now, what is an add-on? Add-on is everything that is not simple IVF. So once we start failing 1 or 2 or whatever number of failure, it is many times by chance. The results will improve if we keep on doing IVF, but what we do, we add another treatment. So we do scratching and we do zona hatching and we do many things that all in all are not expected to change the fate, but by chance you can get a pregnancy. And if you have a pregnancy, then you say, okay, we have the solution for this situation, and then you apply it to all patients. Unrelated, if it's a euploid, non-euploid, whatever, we start doing it. One of the reasons that we're doing all these cases is because we think that it will keep the patient coming back to us and coming to treatment in the same clinic. And second is the money that is involved. We charge them a lot more money. Why did we at all added this situation, the add-ons? Remember, most add-ons, except the ERA, were done in the 90s when the results were frustratingly low. It was like 6% live birth rate. But today, the results is about 20% live birth rate. So we do not need all this add-on. And if you take it in the UK and in Australia, in the 1980 and 1921, 70 to 80% of the patients were offered some add-on, which really does not change the fate of the embryo. If the embryo is not euploid, the chances of the add-on to do something else is very low, very slim. As we said, the real reason why we do that is first to keep the patient in the clinic, and second is that we charge them money for that. But then it lessens their ability to finance in this privatized sector where many of them pay by themselves. And also, it might be disadvantage. Gleicher suggests that add-on are the base of worldwide drop in the success rate. So it's not, and none of the add-ons was really shown to be proven, was not proven medically. So there is a media critique. There is a couple that is already suing the doctors for worthless unproven extra that they had to spend £7,000 for add-on to boost their chances while the chances were low. And the literature, and this is the red lights of ESHRE, the literature doesn't show you that any of the listed add-ons change the fate of the treatment or have the real proof that they work. What about endometrial receptivity analysis? This is a new, unproven technology. ERA test is a good example of the lack of methodology for the introduction of medical technology in IVF. ERA test, what do we need to prove in this test? First, the ability of the test to diagnose the situation. But we do not have any direct proof that ERA test can diagnose non-receptive endometrium. There is no gold standard for receptive endometrium. We also do not have, we have to show that personal embryo transfer can improve the results. We need to show that live birth rate is reduced if, after diagnosis of non-receptive, we transfer at a standard time. And then if the results will drop, then we say, okay, it's not receptive. But first of all, they don't do that. And when they do that, it doesn't work. And then the question is, what the maximal effect that we can expect from ERA test? It can be more than the size of the problem. So we said that after 3 euploid embryo transfer, we got 92% in live birth rate. Then it means that we can, if we want to offer ERA test, then we offer it to about 5 to 7 or 8%. In fact, let's take a closer look on ERA test. What is it? For me, it's an unproven, since endometrium is rarely the problem in IVF. It's a failure to synchronize, the theory is that this is failure to synchronize the blastocyst with the patient personal window of implantation. This is the basis for the test. Its timing is everything according to this. But I don't think it's a fact. The test is a PPL. We do a PPL of endometrial biopsy and we look for 238 genes that are tested. Results are presented as receptive, non-receptive, and subdivided in pre and post implantation. And then we correct the transfer with the progesterone that we give for plus minus 24 or 12, even 12 hours. The tests require very sophisticated mathematical statistics to sort out the clinical results. So tell me, how many tests do you use on a daily life that you don't understand what it is done? They just tell you, do this or do that. They don't give you the results and how they get the results. And then you have to decide, and then they decide for you what to do, when to transfer. ERA test is offered to patients failing 0 to 3 embryo transfer, which is not a problem. It's not an entity because we know that the first 3 cycles can get you 95% or 92% live birth rate if the embryo is euploid. Just to say that the early study that brought about this commercial kit to use was on 17 patients failing 1 or 2 cycles, a mean of 2 cycles. So this is not a basis to spread out this solution. It raises many questions, specific reservation on why correct the endometrium if most implantations are failure of the embryo. True real implantation failure is very rare. What is the advantage or the claim that the window of implantation is 12 to 24 hours to human procreation? Why would it be such a narrow window? We know there is superfetation, superfecundation that can be done away from the date of the window of implantation. Embryo can linger in the uterus for 2, 3, and even 4 days. We transfer on day 1, on day 2, on day 3, and the embryo waits for its turn to implant. We had promises before. We had the proteome, the metabolome, and this is the transcriptome. And here we found we have gold. And also this test was started in a certain way of evaluation, and now only NGS is expected. So do you repeat all the studies before? No, no need to, because no study have shown that real results exist. The different gene numbers were claimed by different groups: 10, 40, 63, 303, 606, some going up, some going down. And here we zeroed on 238 genes. Different numbers were also claimed in different clinical situations. I would not get to it now. All this number casts doubt on the true number of these regulated genes. And most importantly, what does it mean if the embryo is not there? Because when we take the endometrium biopsy, there is no embryo endometrial crosstalk, so there are many genes that do not come into action. So there are also other commercial kits of 11, 40, 67, 100 genes, and so on and so forth. All of them needs to be proven before putting them into action. Also, the methodology, the gene profile of error without the embryonic effect, biopsy time cannot be identified consistently. The optimal day of embryo transfer relationship to LH is not consistent. LH plus 6 is different than LH plus 7. And also the studies that were done with the group that suggested this procedure showed that the chances of using this, because this study, for example, by Majan, the success rate was 61% in the first cycle, 40 and 42% in the second and third cycle. So only 6.5% remained non-pregnant. And 1/4 of them had non-receptive endometrium. So you're talking about, in the best case scenario for the commercial kit, about 1.8% of all IVF patients can potentially enjoy RIF. So this is not a real message in these cases. Further, the undeclared elephant in all these cases is the progesterone level. We know very well today that high progesterone level pre-ovulatory can drop the results, and this was never shown together with the ERA test, and it can lower the pregnancy rate, but this was not checked. Yet ERA test was introduced independent of progesterone level. And also there is this nice study from Belgium that showed that if you take day 4 embryo and you put them back on day 3 or day 5, the results are almost identical. And sure enough, the randomized controlled trial of the group that suggested the results by the group of Carlos Simon have shown that if you take patient, you do IVF, 37%, only 37% of the group were naive patients who never had IVF. So why do you offer ERA test if you don't try IVF? But all in all, by intention to treat, the results were similar. So, and another thing in that study, only personal embryo transfer were tested, but they did not test the reverse situation where you take an embryo that should have been put in certain date and was not postponed, even if it was non-receptive. So the ability of the test to diagnose, I would say no, we didn't show that. That personal embryo transfer can improve the results, there are no such results. And maximal positive effect of the test is below 1.8 to 5%. There are many studies, I would not go into all the studies, but there are meta-analyses today, several meta-analyses, and I think there are another 3, 4 meta-analyses coming. I reviewed at least one of them, but I saw more of them that showed that ERA test is not changing the results of the results. And most importantly, the group of IVI recently have published this study that showed that maybe it is associated with lower cumulative pregnancy rate. This is a study by Cosolino and Tony Pellicer. So I think this is a huge support to the debate that I had in that paper with Carlos Simon that says that this cannot, on theoretical basis, cannot work. So all in all, we have zero proof that it works. We have meta-analysis that show that it doesn't work. Some of the meta-analysis find some changes and would say in the future, okay, in certain population, we should continue to try. But ERA, in my view, cannot work. And this is only symptomatic to all add-ons and to the fact that repeated implantation failure is not a diagnosis. So when you search then for freezole, for zona pellucida hatching, or for scratching, or for changes in your protocol, you're doing something that is unproven, unneeded, and is not and does not have proofs in the literature. So with that, I thank you very much. I invite you all in November to COGI, where we very effectively discuss controversies in all fields of obstetric gynecology and infertility and in surgery and so on and so forth. It's in 23 November in Vienna. Thank you very much.
Дорогой профессор,
Dear Professor Zion Ben Rafael, my apologies that we did not put you in immediately because I was waiting for you to take my call, as you were talking at the same time to my assistant, Katya. Of course, not with Leila, but you answered a telephone call by Katya. I'm sorry for this confusion. Brilliant presentation. I fully support you. No error would work. No error would work. I have a question for you. I know that you are brilliantly aware of all these factors. We're now all very keen on patients who have this failure, ovarian failure, ovarian insufficiency syndrome. We got a lot of material. We went to Kawamura after your recommendation. We visited Pelusir and others, and out of 127 patients, only 27 got pregnant. In those where anti-Mullerian hormone, AMH, was even lower than 0.0305. As you can see, knowing your background, you were one of the pioneers at all of reproductologists. What do we do next in cases where endometrium doesn't work, ovaries do not work, and the patients are young? As to endometrium, we start PRP into the vagina, then we do stem cell therapy into the vagina, then we do all sorts of gels that we apply into the uterus. We do scratching and stretching, you name it. But as to this is my question number one. Question number one, how does endometrium, how can we refresh it? How can we create this refreshment of endometrium? Second question, do you believe into this technique, this surgical, of fragmentation of the ovary and reimplantation? Two questions from me personally to you. Thank you.
просто ваш клинический...
Your clinical experience, please.
Thank you, Leila, for the question. First of all, the lecture that I gave was in cases where there is no problem. You have checked everything, the endometrium looks good, everything looks good, and the patient failed. And then, should we do any add-ons, different treatment? My answer is no, because if the embryo was good, euploid, chances very high of success. So, because many times after one failure or two failure, we want to do many other things and change them because we are afraid that the patient would leave, would not continue, and try some other places. So I think we should continue the same treatment if everything looks good. However, if you cases that you say that it is ovarian failure, or you see that the endometrium is no good. Endometrium can be thin, like 4 or 5 millimeters, maybe 6 millimeters, and it had before some endometritis or anything which is, then you should treat. I'm not saying you cannot treat, you have to treat. And when you treat, usually you don't have enough literature to tell you whether you should treat with hysteroscopy and antibiotics, or only antibiotics, or what you treat bad endometrium. Some people try GCSF, some people try. These are all trials that are legitimate, but this is cases where there is a problem. And when there is a problem, the book would not always lead you to what you should do. And this is the art of medicine. You should choose whatever you think can help. Either it will help or not. This is another question. As for cases of low ovarian reserve or no ovarian reserve, I think you have a talk in this meeting. I think you also visited at the time Japan, and you visited IVI group and learned that even in an ovary that looks completely empty, it has few follicles. It's the same like a woman postmenopausal can have a follicle here and there. And then if you can have it and use it, but remember the table that I showed in the beginning of my talk, that after the age of 42, the chances of getting a euploid embryo, when you have a blastocyst already, the chances of it being euploid is less than 10%. So the chances are very low. If you get 25 cases pregnant out of 125, this is fantastic. This is the 20%. So you're having beautiful results.
Dear Zion, you know why? Do you know why to get these good results? It's difficult to tell the patient, well, that's it, stop. Nothing more will work. We won't do anything. And then you start doing some refreshment. We do scratching. We try to administer cells. We do, for example, gels, PRP. But still, it helps. I don't know. I've been thinking, how long ago? You've been working so long. I've been working over 50 years. We have known each other for some 40 years now. What is the future here? We can't transplant uteruses. I would like to thank you for your being loyal to your profession, to what your patients, to creating this COGI initiative. For at least 5 times a year, we used to meet at different meetings. I got your invitation for November. Thank you very much. I'll hand it out to the people I know. Thank you so very much for being with us. Good luck, success, and all the best, dear Zion. Thank you so much. Dear colleagues, it is my pleasure to introduce immediately Attila Vireski. Vireski is a unique specialist, a unique person. We also known one another for quite a while. And he knows about female health, about myomas, and about endometriosis, and about all sorts of endocrine disruptions, be they agonists or gestogens, you name it. Nowadays, he wants to speak, Professor, Medical Director of Versus Clinic of the Institute of Human Reproduction in Budapest, Hungary. The impact of fibroids on female general health. Please, the floor goes to you, dear Professor.
Oh, dear Leila, dear colleagues, dear friends, first of all, I would like to thank the opportunity to talk and to be with you today. It's fantastic, Leila, your achievement, and congratulations in those situations, what life brings to us. You make this wonderful conference with wonderful faculties and speakers. So all my best to you and big hugs. And thank you for inviting me again. It's fantastic to be with you today. So the talk for me today would be to talk about the impact of fibroids in terms of general health. We know that as a background, fibroids is a benign tumor which represents about 80% of Black women and 70% of white women. It may cause multiple symptoms. The risk for malignancy is quite low. The leiomyosarcoma is extremely rare. And the problem with fibroids is that it consists of smooth muscle cell which carry the MED12 mutation, and this brings the patient to develop fibroids. It's really big public health problem. It costs a lot to our societies, and the estimated cost is more healthcare expenditures than breast, colon, or ovarian cancer together. The tumorigenesis of fibroids are a very complex situation, and I don't want to go in details in this. But I would like to only share one point is that this here, the genetic hit, because on the normal myometrium, we know that the stem cell population is responsible for the proliferation of normal myometrial smooth muscle cells. But if there is some genetic or epigenetic problem within the system, the fibroid stem cell will be mutated, and this will produce, in an uncontrolled fashion, an exceptionally high development of fibroid cells. We know that there are several classifications of fibroids, and we all know that the location plays a very important role. The effect on fertility, for example, depends very deeply on the location of the fibroids and, of course, of the size of the fibroids. We know that there are several subtypes of the smooth muscle tumors. Histologically, there is a cutaneous leiomyomas, which appears as a small or multifocal nodular skin lesions, the vascular leiomyomas, and the deep soft tissue leiomyomas, which is normally include the common leiomyoma in gynecological origin, as we mostly see. There is a quite wide ranges were reported in uterine fibroid incidence and the prevalence. It is depending on the study, which this publication is listing here. The black race was the only factor that was recurrently reported to increase the fibroid risk by 2 or 3-fold compared with the white race. This publication actually identifies about 12 risk factors that play an important role in the fibroid epidemiology, like strongest evidence is the black race, high quality prospective observational data are needed, for example, to improve the epidemiological data. So we know that uterine fibroids are impairing the uterine function as well, but there are many other factors which plays the same importance in destroying the function of the uterus, like Müllerian anomalies, polyps, adenomyosis, very big problem, as it was talked several lectures before. Even Leila, you made a beautiful lecture on this. Endometriosis in the pelvic cavity, the hydrosalpinges, and sexually transmitted disease, the microbiome, the genetic disorders, environmental issues, and the previous uterine surgeries and the quality of the previous surgeries can play an important role on the uterine function. Furthermore, women who diagnosed uterine fibroids, they reported significantly more the following pain symptoms, for example, pressure of the bladder, chronic pelvic pain, painful sexual intercourse, and pain occurring mid-cycle, after and during menstrual bleeding. And you see here that this is about 32% on the bladder and other part of the abdomen. So the pain plays a very important role in the diagnosis procedure. And we know that the impact of fibroids on pregnancy is very important. There is a high risk for placenta previa, preterm delivery, cesarean delivery, and postpartum hemorrhage is an effect of the outcomes. And fibroid double the miscarriage rate from 7% to 14%. The perinatal outcome and the long-term pediatric morbidity of pregnancies is listed here. So we see that there is 20% higher chance for placental abruption. There is a 50% higher chance for developing a low birth weight, very low birth weight, fetal growth restriction, small for gestational age. So there's a lot of consequences of fibroids during pregnancy. And if we compare the long-term morbidity of children born with mothers with and without fibroids, it's very interestingly, we have found significant differences on the endocrine disorders with the fibroid group. So there has been a higher chance to develop some kind of endocrinological disorder in the child of women who are having fibroids. This is the graph where the maternal uterine fibroids appear to be independently associated with adverse short-term perinatal outcome. mainly related to abnormal placentation. And this is the graph which shows that there has been no significant differences which was evaluated in this cohort, except endocrine morbidity, which is very important. We know that the uterus is very sensitive in terms of fertility issues, especially in the case of fibroids. And we know that the fibroids are present up to 27% in case of infertile couples. It affects fertility through cavity distortion and many other alterations, for example, the endometrial receptivity. We need a very detailed evidence-based approach if we want to suggest a procedure to a patient. So myomectomy seems to be the most evidence-based approach, and the surgery, after surgery, the pregnancy rate should be going up to 60-70%. It's very interesting how the uterine fibroids can cause infertility. There are many issues, not only the uterine cavity distortion, but fallopian tubes obstructions, gamete transport, abnormal endometrial receptivity, abnormal hormonal milieu. So there are different treatment possibilities what we have, but the choice depends on the age, the desire for pregnancy, wish to avoid surgery, question symptoms, severity, and also the skill of the treating team. Arno Vati, as yesterday, has told very importantly about the importance of the surgical team and the skills. And again, I like to highlight that it needs a multidisciplinary approach. And again, I like to show here that there is a big group for medical management, interventional radiology, and surgical management. Actually, the overall trends of uterine fibroid treatments are changing into the methods in terms of saving the uterus. And you see that less hysterectomy is done, more myomectomy is done, and the interventional therapy is getting more space here. But we know that there are extrauterine growth for benign uterine leiomyosis is also known. It's clinically minor potential. Metastasis has been reported with different types of the extrauterine growth. For example, a single large fibroid will and may occupy the entire uterine cavity, the fundus here, but fibroids can be removed in the same uterus with many small pieces and small nodules, which are seen here. And also we know that there are cases, for example, in this publication, where 34 years of multiparous woman was operated on multiple recurrent fibroids in the parametrium. And at what time 32 fibroids was removed. 13 months later, the next laparotomy had to be performed. And at that time, 132 small, large, and medium-sized fibroid nodules and fibroids was removed. So again, fibroids can play a very tricky and important role in terms of fibroid surgery. We know that the vascular biology is connected to uterine fibroids. Here you see that uterine fibroids can have interaction with the hypertension syndrome through the renin-angiotensin-aldosterone system by playing a role in the TGF-beta, the transforming growth factor, the endometrial matrix, and the smooth muscle injury, and develops fibroid, and vice versa. It's a circus vicious. And also through the extracellular matrix, it plays an important role on the development of preeclampsia. And the last one here is atherosclerosis. So through the smooth muscle cell proliferation, there are several other diseases linked to fibroids like diabetes mellitus, hypertension, obesity, metabolic disorders, and hyperlipidemia. So we know that this is a cross-sectional study showed that uterine fibroids were associated with an increased rate of elevated blood pressure, 35% higher. And the meta-analysis revealed a significant association between fibroids and the prevalence of hypertension. Actually, the lung is the most common extrauterine location for for leiomyomas, but the heart is playing a role as well. This is the report and the incidence of a cardiac mass in a 36-year-old woman who presented in a hospital in an emergency unit. And you see after the surgery, they have found 4 centimeter mass, which was later has shown histologically that this is fibroid. The cardiac tumor, which is shown here on the picture, was resected and shown benign histological features. It was a uterine leiomyoma. But we have other cases. For example, this is the case where intravascular leiomyoma was shown in a 55-year-old female with a very big mass in the vena cava inferior. After surgery, it was confirmed that it's a spinal cell leiomyoma. In these cases, in the follow-up, the CT scan has shown, and the magnetic resonance has shown a recurrent leiomyoma, multiple uterine leiomyoma proceed surgery, and it was again shown a large fibroid in the vena cava. It was intravenous leiomyoma. If you go ahead, this is a 55-year-old patient who had been on oral anticoagulants for deep venous thrombosis on the left lower limb, and the pathological examination found smooth muscle fibroid on the femoral vein. This is the report of a very rare case of primary pulmonary leiomyoma in the 55-year-old patient who presented with symptoms of cough for more than 6 months. And you see it's very nicely shown that through it's a benign tumor, endobrachial lesion showed the cystic ovarian leiomyoma is also a very rare case. It's a huge, it's about 4 centimeter large mass, which was produced by one of the ovaries. It's included about 10 liters of fluid inside, and the histological pathological examination has confirmed the leiomyoma with cystic degeneration. Of course, the genitourinary tract is also a rare but difficult location for fibroids. The preoperative examination is shown here. This is the postoperative surgery, and nephrorectomy specimen has shown a solid tumor, which again, immunohistologically has been shown fibroid. There is a very interesting connection between the hereditary leiomyomatosis and renal cell cancer. And it is a tumor predisposition syndrome, which is characterized by cutaneous and uterine leiomyomas and increased susceptibility to develop renal cell carcinoma. There is only 200 to 300 families in the world who has a hereditary leiomyomatosis and renal cell carcinoma, which was reported, but still a very unique and very interesting case. This is the uterine leiomyoma case with a massive lymphoid infiltration in the patient with a history of IVF. And this is a massive lymphatic infiltration, which was shown by ultrasound. And it was very, very important to differentiate it from the non-Hodgkin lymphomas. And of course, it's associated with the muscle and nodular lymphoid infiltration, which was again histologically proven to be a leiomyomatosis. It needs a systematic therapeutic approach very importantly. The leiomyoma in the breast are very rare and atypical location again, but this publication shows that this could happen. Then you see in the bilateral leiomyoma of the breast is shown here histologically confirmed. This is so-called STUMP, the uterine smooth muscle tumor of uncertain malignant potential. The incidence of breast cancer was 35% in the uterine leiomyoma group, but interestingly, the overall mortality rate was not higher in the leiomyoma group. But again, it's very important to build up the connection between these two diseases. This analysis has shown that uterine fibroids, which develops a significantly increased risk of thyroid cancer, were more likely to be middle-aged and with the higher income levels, with the median follow-up period patients. And so there is a significant increased risk for thyroid cancer, even with or without fibroid enucleation. This is a 20-year-old female patient who presented with abdominal symptoms, and later on after surgery, the primary hepatic leiomyoma was confirmed with associated with the Epstein-Barr virus presentation as well in many cases. The rectal leiomyomas has been reported back to 1800, and one in every 2,000 rectal tumors consist rectal leiomyoma. So we have cases we have to be careful on this, but also radial neuropathy can be caused by intraneural leiomyoma. Very rare case. It shows here that the intra or perineural leiomyoma can cause focal neuropathy. So with MRI, the right tumors has shown location and histologically it was proven. If we go ahead to the census, in the eye, in the intraocular leiomyoma could happen, and this is a very strange and unique cases which was published here. This is smooth muscle actin was most reliable diagnostic method, for example, for diagnosing the pigmented uveal leiomyoma from the melanoma, and this was fibroid again. And this is a 7-year-old boy which presented with a right distal forearm and wrist pain with restricted supination for 4 years already. And after surgery, the histological immunohistochemical features was showing leiomyoma on the 7-year-old boy forearm. We know that it can be presented on the skin. So this is the case of the cutaneous leiomyoma, and it has been shown that ALM type with several small fibroids on the cases like this. There could be a munified leiomyoma in the midline of the anterior neck, which is shown here, and after surgery it was reported to be a leiomyoma. But also the face, the cheek, can be location for strange location or fibroids. This is less than 4% of the benign soft tissue tumors are leiomyoma in these cases. This is a giant abdominal leiomyoma of the male. So male can develop fibroids as well. And this is the huge, large 4 or 5 centimeter. This is a deep soft tissue smooth muscle tumor. And of course, it had been shown up very severe symptoms. Also, the testicle part, the tunica albuginea, can be the location for developing the fibroids. Again, a very strange and very rare case, pediatric leiomyoma has been shown on this very young boy. And you see on the glance, there has been a marked whitish area after surgical removal. Histological examination has shown fibroid. So, sorry. So the beyond the physical problems and the risk what the patient can develop in fibroids, the quality life issue is playing an important role. There's a high prevalence and severe physical impact of fibroids, but there's a significant physiological, psychological impact of women, and it improves the psychological health and quality of life issue as well. And if you ask the patients, they could tell that it's a lot of pain, non-stop menses, it's a terrible situation and it's not fair. So concluding my talk, Leila, if may I have 1 more minute. We know that many factors are associated with the development of fibroids, including black race, increasing age during the reproductive time frame, elevated BMI, positive family history, personal history of myoma, early menarche, and nulliparity and obesity. Fibroids may be asymptomatic, or they may be cause of multiple and severe symptoms. Presence of uterine fibroids can greatly affect the fertility pregnancy outcomes in women, including those undergoing RT. Surgical interventions has proven to be most effective treatment of fibroid-related infertility compared with non-invasive and medical treatment. Uterine fibroids intra and extrauterine location carries a very high risk of medical situations which may need further interventions, and uterine fibroids has a negative impact on general health and on quality of life. Leila, thank you very much for your kind invitation again and for your attention.
Дорогой профессор
Dear Professor Viretsky, thank you very much for being with us. Every year, twice a year, you make different presentations on different subjects. You're a wonderful person and our great friend. Thank you very much. There are no questions. We are behind the schedule, but we covered the most important problems in gynecology. Every third patient of reproductive age has myomas, and we need to do something about it. Thank you very much. Dear colleagues, I'd like to remind you once again that we have the plenary session, current gynecological issues on the basis of new technologies. And new technologies does not just mean surgery, but that means new technologies in diagnostics, new genetic methods, new methods related to preserving immunity, and this particular breakout session is rich for unique presenters, including from the Kulakov Center. Once again, I'd like to say that it's a great honor for me to work at the Kulakov Center. I've been working there for more than half a century, and Gennady Sukhik always asks me, is it 50 years or 51 years or 52 years? Well, 52 years, almost, I should say, when I was a resident at the Kulakov Center. We have a wonderful group of specialists at our center. Our director, Professor Sukhik, by the way, is actively involved in the development of new methods. Professor Krechetova showed what was done 30 years ago at the Man Sukhik immunology of myomas, immunology of endometriosis, issues related to congenital immunity. 4 dissertations were written by us, and that's why I became more involved in this process, besides surgery, of course, but also I became involved very deeply in fundamental science. And I would like to introduce a unique person, Maria Kuznetsova. The title of the presentation is The Role of Molecular Genetic Methods in Detecting Risk Factors for Uterine Myoma, Development, and Recurrence in Women of Reproductive Age. There are several co-authors here: Vladimir Kuznetsov, Dr. Trofimov, and yours truly, Leila Adamian. But Gennady Sukhik is our mentor. He is very modest. Well, I like to be on the title of different articles. Maria, please, the floor is yours. You're welcome. Good afternoon, dear colleagues, esteemed Leila Adamian. I would like to start my presentation by saying what is meant and what is happening on the molecular level in myomatic cells. You can see the changes here. These are so-called somatic changes. They happen spontaneously in a single cell and then can be translated to clonal cells, adjacent cells. We know that any myomatic node is a clone of the cell where some mutation took place. And besides that, for many tumors, and not just for myomas, but also for different cancer, there might be epigenetic changes when there is a mechanism regulating the gene expression, which is not having an impact on the DNA sequence, but has an ability to change the proliferation of cells, leads to the vascularization of the tumor, and many other aspects for the development of the disease. This slide shows genetic changes in various chromosomes, such as pinpoint mutations, well, genetic aberrations and rearrangements, well, chromosomal rearrangements, and there might be also deletions when the chromosome is losing the long arm of chromosome 7, especially this is typical of myomas and chromatopsis. That's chaotic rearrangements of all chromosomes in the cell, but this is a very rare case. As a rule, this leads to oncomyomas and sarcomas. Epigenetic changes lead to changes in methylation, which regulate the gene work, and also non-coding mRNA. These are short RNA when we cannot read the protein, but they work as gene regulators in the cell. Well, modern views of molecular mechanisms of pathogenesis. In general, we have two types of myomas. That's myomas with somatic mutations in gene MED12 and HMGA2 mutations. The first type of myomas consists of smooth cells and fibroblasts, often associated with specific tumors, not just myomas. Usually these are TAF fibroblasts. And 90% of cells in the myomas of type 2, these are smooth muscle cells, purely smooth muscle cells. As for transcriptomic studies of all genes expressed in tumors confirm the fact that cluster of myomas with somatic mutations MED12 and HMGA2 are two different clusters, two different molecular mechanisms for development of meiotic nodes. This slide shows the genotypes and phenotypes in myomas for MED12+. Well, you can see there are fibroblasts in the tumors, which is not typical for HMGA plus, and lack of MED12 mutations, well, plus, and there is also a growth of the tumor is stimulated by progesterones and progesterone, and also there might be giant myomas, low frequency rate, and the growth of tumor is stimulated by progesterone. That's an important issue. What is the role of heredity in this case? Well, there are family forms of myomatosis, and what nodes occur in what patients? That's another question, which are more typical for family forms. So this is the issue of great interest for us. What are the genetic predictors for the development of uterine myoma? When the organism develops, and we have the comprehensive impact of different risk factors, this leads to the changes in protective factors which protect us from tumor, and the risk factors which cause the formation of tumors. And as a result of that, as it has already been mentioned, there are driver mutations. Well, this may be the somatic mutation MED12 or HMGA2 superexpression, and then as the tumor develops. And this is the article shown on the slide, which tells everyone about the hypothesis of passengers. The mutation is the drive mutation, and the passengers are epigenetic changes which occur as a result of the tumor growth. They just go hand in hand, and this leads to the formation of a particular tumor. What are the factors which determine the risk of relapse? First of all, genetic factors, ethnic factors. Afro-Americans usually have a higher frequency of myomas, also congenital genetic variants, which are responsible for predisposition for the disease. So these are genetic variants which cause the so-called family cases of uterine myoma, when from generation to generation we can see the development of myomas. In the same family line also, multiple myomas, and usually they have a high frequency rate of recurrence and somatic mutations in cells. That's also a genetic factor. Non-genetic factors, first and foremost, are external factors such as stress, well, poor hormonal balance, and such things as immune mechanisms. They should also be taken into account. Pregnancy and other problems. As far as changes in the reproductive health is concerned.
Мы в поисках этих самых генетических...
Well, in search of genetic factors that can code the predisposition for the disease or vice versa protect us from a disease, we use a very simple system. That's when we have alleles. Well, and obviously there are differences in the genome. Usually there are alleles that occur all too often, and there are rare alleles. And if, for example, we take into consideration that fact that the organism of any person has two variants of the same polymorphism, there might be two frequent variants, such as homozygous alleles and heterozygous alleles, which are quite rare. And the rarest option is when a person has two rarest options. Well, that's homozygote to the minor allele. And well, the rare homozygote can have the protective nature. This variant of the genotype is showing that leiomyomas do not develop. We've chosen 12 different variants of genetic polymorphism, and if in the first group the rare allele is protective, and you can see there were differences which were quite reliable between the control group and the leiomyoma group when we tried to check polymorphism for the rare allele, which was protective. Well, in this case, the differences were not significant. That means when we have this pathology in the population, which is quite spread, the search for such variants where the frequent allele bears the protective function is totally futile. You can see the control group. These were women who have never had myomas and no family history of myomas. In the comparison, in the control group, there were women with the family history of myomas and the general sampling. As you can see it here, the differences in different types of polymorphisms can be reliable to a certain degree in this or that group. We should also take this into account. So as of today, we continue to search for targets for therapies of leiomyomas using metatranscriptomic and metallomics. There are different studies conducted with different options for treatment. Different articles are shown here, as well as the prevention of myomas and prevention of occurrences. Unfortunately, as you can see in the third column of this table, the samplings of patients were very small, unlike our studies where we included more than 500 patients in the sampling. And of course, it's much easier to make conclusions because the results are more reliable. As for new technologies which are in the pipeline to treat the uterine myoma, first of all, targeted nanoparticles and the CRISPR-Cas technologies, well, sequencing of ovarian cells, but unfortunately, they do not have the practical application as far as I can see. What are the prospects for developing new methods of immunoprophylaxis of uterine myoma? Here are 3 articles describing DNA immunization that could suppress the development of myomas. And you can see metal protease 11 on the basis of mice models. This drug suppresses the tumors of the colon, and maybe this could be good for myomas, but this is a matter of the future. Also, there is another article, DNA immunization, and by the embryo protein at the first stage of clinical trials, and it is used against breast cancer and against the colon cancer, and maybe this will be useful also to prevent myomas. And the third work I'd like to note that in particular was done at our center as compared to the previous 2 ones. Well, nulliparous women have, multiparous women has a risk of disease 4 times less than in those who did not have children. We must test this hypothesis. Going back to our sample of those patients who were in our sampling, well, women with the severe cases and non-severe cases, the recurrence rate in those groups is different. Patients with severe disease, the frequency rate is 15% higher, and this trend is being kept even if we change the sampling, if we even include the number of patients in each sampling. The same is true of uterine myoma. It's a risk for recurrence, and it's not just due to the simple fact that there are multiple myomas which may not be fully removed by surgery. Not all nodes can be removed during surgery, but we can also see that the frequency rate of detection of somatic mutations in MET12 gene is 13 times higher than in single nodes. So this frequency rate, elevated frequency rate, has a molecular basis. Let me just draw the conclusions. Our modern views on molecular mechanisms of myoma development can identify two types of nodes, MET12+ and HMGA+, and to detect somatic mutations and hyperexpression of genes by using immunohistochemistry and reverse transcription PCR, and to assess the risk of relapses. The analysis of data on polymorphism allowed us to identify 6 protective alleles in genes, and thus we can develop the algorithm to assess the risk of uterine myoma development and to counsel women of reproductive age regarding the possibility of developing the disease and its relapse. Thank you very much. Thank you, Maria. That was a wonderful presentation, and I also contributed to this together with our group of people, including Dr. Suhik, etc. Could you tell me, please, you have been dealing with this for many years. I mean, genetic diseases, or to be more precise, gynecological diseases. We're trying to talk about different genetic aspects, and we have more than 3,000 participants watching us online. What is your view of this problem? Yes, in the myoma there is MET12 gene. Well, we can diagnose this mutation, and now we do the testing whether there will be a relapse or not. And what else has been done by you in terms of value to the genetic aspects of gynecological diseases? Well, now we got the RNF grant to develop the myoma vaccine. We're trying to detect those proteins on which basis we could develop a vaccine that could protect patients from myomas. Not all patients, but those who have a family history of the disease where myomas can develop at an early age. We even have one project with the Department of Pediatric Gynecology where they have cases of myomas in the early age. So, but we also hope there will be other projects with other institutions. Yes, we will continue this work. Who else, if not us? Thank you very much again, dear colleagues. Now we are going to have a 2-minute video, and then we'll give the floor to our colleague from the United States, Tamir Shekin, New York. After a 2-minute video, please. now, dear colleagues, folks, we start our next breakout session. I just called our geneticist from New York. That's Professor Diego Marin, sorry. He has 2 presentations in 15 to 20 minutes. He will be ready to get connected. Right now, it's a great pleasure for me to announce our next speaker, a professor from New York, the US, Tamer Shikin, fertility and endometriosis, surgery, egg donation, and thoracoendometriosis. He's a professor of OBGYN, Zucker Horsti Northville School of Medicine, the founder of the Organization for Endometriosis of the U.S., a clinical instructor at Lenox Hill Hospital, New York. Sorry if I got your name wrong. Dear Tamer, you're with us. Please.
Do you hear me? Do you hear me?
Yes, we can hear you. 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 Yes, we can hear you.
All right, so if there's any problem, let me know, because I'm connecting from the hospital network, so I didn't know how things were going to go. For me, good morning, good afternoon, everyone.
Звук побольше.
Am I being heard?
Yes, we can hear you. Keep closer to the mic.
Do you hear me? Yes. Okay.
Yes, we can hear you.
Okay, good. So again, I am Dr. Sechkin, connecting you from New York City. It's a true pleasure. It's a humbling moment. Nowadays, we do these things on Zoom. It's very convenient, but we do connect for a cause that we all love to share, and we become friends and have a language common. Today's subject is pelvic components thoracic endometriosis. So I will start with this slide. I want you to know that this is a trivia question. You may have seen this again, but the Indians bring down the big buffalo, American buffalo, with one arrow. Where do they shoot? So that's one issue, because in humans, it's a different issue. And there's also another slide here that shows an elephant. It can swim. This couple tons of massive meat can swim with no hassle. Why do they swim? So I'm not going to prolong your weariness long, because buffaloes has one chest cavity. The arrow goes to the chest and it is down. Luckily, we human have two chest cavity, two compartments in the chest, in thorax. So many times these thoracic endometriosis cases come with minimal pneumothorax. People can bear with it, can live with it. It's not deadly, yet it is very morbid. So I will go. And buffaloes have actually they go through natural periodontitis, which thoracic surgeons often do by mistake to endometriosis thoracic patients. And then these patients come back very frequently back to surgery. So I thought this could be a nice entry to my presentation. I have no relevant financial relationship to disclose. I'm going to go over the current understanding of endometriosis and look why these things happen in pelvis, and give you some thoracic endometriosis background. I will define you peritoneal pores, which I detect all the time with my technique of removing peritoneal endometriosis, which I think is the cause of the diaphragmatic holes. And I'm going to present some experience in Lenox Hill. Going back after Rokitansky, it took almost 60 years for Samson to call it endometriosis. And then these are some characters I have associated over the years, Gomel, Martin, anyways. But thoracic endometriosis, even though Hart defined that, Hart found described endometriosis and documented pulmonary lesions. It took 50 years for Maurer to tell you that the spontaneous pneumothorax happen in women concurring with onset of menstruation. To fast forward, it took almost 70 years, 80 years for Joseph to call it thoracic endometriosis syndrome. First, Livingston described it in 1972 and associated this as catamenial pneumothorax first time. So it takes so many years for us to progress in this field. So only Sampson's theory really explains features of thoracic endometriosis, and Lillington very smartly talked about valve mechanism. In fact, there is always a subtle and very, very discrete, very, very hard to detect holes like a bleb that doesn't really define as a hole, but these blebs open up and close in diaphragm. And this is one of an example that from one of my cases that we will be going in short while I'll be showing it. Shortly, I have looked at our experience as Zelenoxel a couple of years ago. We have more than 50, close to 55 patients, Rob, but these patients all went thoracolaparoscopic approaches. I call that dual compartment approach. And 37 patients we have experienced by then. This really constituted 2% of our surgical referral practice. And these patients were typically around 36 years of age. And most of them had 90% of them came to us with prior pneumothorax. Only 10%, as you can see on the figure down there, had nothing prior. And 18 of these cases have multiple pneumothorax. You can tell that these patients come back recurrently. And one patient had 17 chest tubes placed, and they traveled with the chest tubes, and they live with it. Unbelievable. This is happening in America. God knows what happens everywhere else. And 10 of them had no prior pneumothorax. All of these patients, ladies and gentlemen, had endometriosis in the pelvis. Literature says something close to it, but I think if you look very carefully, there is an association there. So we removed total 500 specimens from these patients. The way I remove specimens, I will be telling you later, but I go after every lesion and I'm subject to pathology in pelvis. And 10% of them were from thorax, abdominal diaphragm, 16%. The rest of them was all from pelvis. And these specimens, most of them showed fibrose, positive with fibrose for endometriosis, 60%. The rest of them were inflammation and fibrosis that we're going to touch really the new concept of endometriosis, the way we talk. It's really about fibrosis. These could be healed areas. These could be areas that also pathologists might have missed. So we removed like 13 specimens per case, and 8 specimens per case were positive. So when we look at these specimens, about 35% of them were peritoneal. In other words, with thorax, pneumothorax, there's 35% we found only peritoneal endometriosis. These were prominently gravid patients. And more lesions were found, as usual, in endo cases on the left pelvic sidewall. And 24 of these 31 had advanced stage endometriosis. So the cause and the basic understanding is the endometriosis is usually very severe in pelvis in these cases. 14 of these patients, these were mostly non-gravid stage 4 advanced endometriosis with retroperitoneal fibrosis. They had bowel disease, umbilical and inguinal lesions. And deep fibrotic endometriosis was found 10 of these cases. There were endometriomas. So endometrioma becomes a major culprit on this, but not necessarily. Interestingly, even though endometriosis shows very dramatic appearance in pelvis in these patients, not necessarily they are the cause of the the holes in the pelvis. There must be something else enzymatic that has to do with the necrotic menstrual debris. And most of these patients, 7 of them had radical hysterectomy, many bowel resection and bladder resection. So, 11 of these patients went for 3 segmental resection, 1 bladder, and radical hysterectomy. So this is what happens in New York. This is one of my patients. It was a medical mystery. She hit the big screen, and New York Times reported it, how a mother lung collapse led to a surprising diagnosis. This patient came to hospital with recurrent pneumothorax, and usually thoracic surgeons miss it. But let's go to symptoms of what this patient suffered, and I'm going to tell you something
Pressure
else.
pushing down on the actual lung, like the balloon that's being pushed down.
We treated her for that, and she initially did very well.
So Zara had second pneumothorax a year and a half later, and her
What made her case a little bit unusual was that she came back with another one. That only happens less than 5% of the time.
So
Trying to understand what it is in my life that's different that could cause this. I went through many rounds of IVF. I pumped myself up with hormones. Is there some kind of connection with that? And that's when he brought up catamenial pneumothorax.
So what I want to say is Zara could not walk. She felt a shift and pressuring down on her lung. This is the second time after. Many times, thoracic surgeons don't have any clue about endometriosis. So this is why I'm mentioning this, because this patient, like many others you're going to see in this presentation that have repeated pneumothoraxes, and nobody knew what was happening, and many times they were missing the diaphragm. This is a patient that drove this figure to me about the symptoms. I want to say, look on the right side, the left side is happy. There's a heart happy, lung is fully inflated. On the right side, lung is deflated, not full pneumothorax. She's feeling pain. The pain is reflecting to her shoulder. They feel like rice crackers, sudden short of breath. And when the period is over, somehow it may resolve itself, and the patient comes back the next month. So this is typical with catamenial pneumothorax patient. Many times you may be missing it. This may be the cause of the symptoms of hysteria, for example. Imagine a patient monthly coming short of breath, the pupils are dilated, anxiety. These patients were put to hospitals maybe in the past. This could have something to do with something we know about endometriosis, the hysteria business. So this is a gymnast who described her pneumothorax. And whenever she had it, she would do tackles like this, head down, and she would let the air go with heads down for half an hour, and she would feel relieved. This tells a lot of things. Why was this happening? So the patient really described this. These are drawings one of my patients. It's like a snake wrapping her, and it's all coming from pelvis. This is one of the pneumothorax patients that drove this. I told her, the head of the snake is in the pelvis. So this is a patient. I can't show her her own writing there. I can't show her own writing there, but it says life only can be understood backwards, must believe forwards. Thoracic endometriomas can only be understood downwards, must be treated forward. So these are the incisions we make, and chest incision. This is semipolar position, and this is the dual compartment technique. And we make incisions. First, we go by laparoscopy, examine the abdomen, do our work, and the thoracic surgeons completed the procedures followingly. So pelvic endometriosis is really not an enigmatic disease as is often portrayed in many publications. In fact, its pathophysiology is more straightforward than many other chronic inflammatory conditions. And endometriosis originates from the endometrium cavity. And what separates endometriosis from other inflammatory disease, its dependence on estrogen for its key biologic properties. Persistence of endometriosis and is associated with fibrosis and remodeling of neighboring tissues negatively and distorting their functions. This is a recent publication just made that shows that convincing evidence, that DNA evidence that all sorts of endometriosis, superficial, deep, and even endometrioma removed from the same patient share the same genetic makeup, suggestive highly that these various lesions originate from similar oligoclones of the intrauterine endometrial tissue. So Samson hypothesis years ago is not anymore hypothesis. It is a scientific fact. And there was a great review by Dr. Bulun and Fertility and Sterility based on this recent publication. And I think I advise everybody to read that. Basically, estrogen dependence is the key biologic driver of this. And underlying pathologic mechanism is the defectively programmed endometrial mesenchymal progenitor stem cells, most likely. It's all coming from inside. So the disease is estrogen-driven, sensitive, stem cell-driven fibrogenesis, fibrosis, gland and stroma resembling endometrium is not enough to describe this powerfully debilitating disease of women. So it's fibrosis and fibrogenesis that really leads to the end result. So we're gonna look in this presentation more to the peritoneal, ovarian, and deep endometriosis. You have to think of uterus as a powerful pump that pushes the baby out. But in many stages of non-gravid stages, we know nothing about the way the uterine muscles really act. Similar to heart, these muscles can go to tachycardia, like tachymyometrial contractions, maybe fibrillations, maybe all sorts of muscle-related peristaltic problems you may endure before the cervix open, and other anatomical structures of this muscle also may lead to this. There's no study on this. We are all focusing on genetic molecular version of it, but very little electrophysiologic studies are done on the men's uterus that's leading to endometriosis. These are the layers of the endometriosis. You know, there's upstream and downstream contractions. You may really look into this. There's beautiful sonographic and MRI cinematography of how these muscles really contract. And we often see on these, you know, this is an animation I want to show before cervix open. You know, there's probably, depending on how much menorrhagia there's different volume of tissue is pushed down there. So this is based on Leyen-Decker's graphics. You know, there's a high probability of subtle uterine septum or arcuate uterus presence in these cases. We found up to 20 to 25% presence of these subtle changes. There's another publication on this regard. So evaluating endometriosis is utmost important in these cases. These are like a cat sign. You can really, there's variations of this. I see this often in my presentation. And going back, again, the peritoneum is a beautiful organ with translucency and smooth, shiny purpose. But what happens with endometrial debris coming, you know, when you cut this peritoneum, underlying connective tissue is also beautiful. There's no fibrosis, you see, retroperitoneal fibrosis. But when the uterus is dealing with, peritoneum is dealing with the necrotic debris, it goes through significant changes. So this is a case that I removed and sent to pathology. I requested, and there you go. You have your gland in this debris, and you can tell. And these lesions are actually protruding into the peritoneal cavity, and they bleed. And if you really look at this with this technique that I use, you look what happens here. You almost normal pelvic sidewall, and you see the holes. This pelvic Peritoneum is really, went through the process of tendering with the necrotic debris, and the changes happening in the peritoneum is significant. This could be the reason the patient may have more pain than people who don't have endometriosis. These holes may have necrotic debris more communicating with the underlying and existing nerves that are on the peritoneum. When you look at this lesion, for example, you see that there's a problem here, but the same patient, when you put the methylene blue back behind, and you see how the holes are here, and the lesion is here, but the rest are, many times these lesions are stroma positive without gland, 50% of the time almost. And when you look at underwater at the same time, you see what happens here, all these like grape vesicles. These lesions are really swimming because of the pressure. You don't appreciate this, but when you look at them underwater, it is like a grape leaf with a seed on, and they bleed. And I like to take these photographs. Later, when you look at, when you cut, you see underlying fibrosis, how thickened the peritoneum is, and underlying, you see the holes when you look from the retroperitoneum. And these holes are real. These holes are real. When you push the fluid, and I didn't make that hole. These holes are real. It's patent holes. So we think it's very likely that these inflammatory process causes the also diaphragmatic holes in the chest cavity due to the circulation of the menstrual debris. I think time is moving here. I don't know how much time I have, but we're moving. So you wonder why this is happening. Though intrauterine pressure is during menses up to 56, there is negative, but there is a suction pump here. If there is a hole, obviously, the air would go up and everything will be equilibrating. Maybe the air comes most likely from menstrual debris, or necrotizing menstrual debris may be producing some degree of pressure changes in the abdomen. So the bottom line is these, regardless of the size, these lesions do bleed, endometrioma ruptures, and basically the way the circulation in the cavity, it accumulates in the chest. So this is an animation of how cul-de-sac closes with a ruptured endometrioma. This patient came with 17 procedures. When we looked at her chest procedure, she came with a chest tube to our clinic. This was her inside, filled with menstrual debris. And many times these are endometrioma ruptures and causes advanced endometriosis, going retroperitoneum and closing the adjacent organ with the progressive fibrosis. So chest endometriosis is a progressive disease. It's a further testament. Because it's on the average, it is at the age of 16. So when we look at these, you may not see initially any holes, but when you depress the liver, more holes pop out. And as you lyse these, more lesions from the chest appearance and above appearance, you see these. When you look at these pelvises, you see the similar massive peritoneal texture abnormalities. So we basically remove these peritoneal by cold excision, and we subject every lesion to pathology separately. Every year I have 1 or 2 borderline atypical peritoneum that may be significant to the patients this way. So this is like, these are not nonchalant stripping. These are focal targeted excisions, and you really leave the healthy peritoneum behind. This is a patient we did. Best thing is really, I could show you, but my excisions in the past. Right now, robotically, these are more stably done and properly done. This patient is, when it is repaired, we look at the pelvis. The pelvis also has endo. We clean the endo from the pelvis too. So I'm not sure how the time is progressing. I'm almost there. So the same patient, we remove the endometriosis in the same manner, peritoneal wise. And this patient came with, again, pneumothorax. This is the endometrioma, multiple with fibroid appendix involved, and we treated her endometrioma. But we look at it from the chest, you see a protruding, herniating liver to the chest cavity. So we're almost there. So in general, care needs to be done with endometriomas. As you know, for fertility patients, you really have to be very careful how you delicately really remove these lesions. And as you see underwater, we examine these and then very meticulously counter-track without ripping them. You need a lot of, for me, the most difficult procedures are endometrioma procedures, believe it or not. So, and then we suture it continuously or interruptedly with trio monocryl. This is another thing. I borrowed this from Arnaud Wattier. There's also, without cystectomy, there are sclerotherapy these patients may go with, and it's a promising way of preserving ovarian reserve. So this is a patient. I'm almost there. We saw this is a multiple with chest. We did massive bladder mass removal. So first we went to the anterior cul-de-sac, and there's an ICG green in the pelvis. So when we delineated the bladder, this is the right obturator internus muscle, obturator canal, and corona mortis vessels here, and completely mobilized the bladder. And then we did the ureterolysis. During this time, we had to tie the hypogastric artery in the same manner to decrease bleeding, because we know we're going to do multiple organ disease removal. Bladder is removed, basically pure cut and repaired. Bladder is repaired. Ovaries reconstructed. Then vaginal cuff is closed. I'm almost there. And the multiple nodules removed, but this wasn't enough. We had to do bowel resection on this patient. Many times you may find yourself in trouble, and you should be ready to do bowel resection for the best outcome. Here we go. This is an interesting patient. Not everything is crystal clear. In this patient, again, this patient came from, believe it or not, very prominent hospital. We hit the inferior vena cava here, and it's a massive bleeding.
Professor Sekim.
Last slide, almost done. So massive bleeding. We didn't do laparotomy. Luckily, the pilot was the surgeon was a Russian pilot working. He was very cool. We suctioned this off. We, believe it or not, we did a patch, Everest patch, fibrin patch. This is the first time ever a vena cava is repaired without any suture. Thank you for your attention. Final word is, dual compartment approach is feasible, and it should be done for a better outcome with the right team. And I hope this was helpful to you. I'm going to finish here. Thank you. Thank you very much. I'm open to questions.
Dear Professor, I'd like to say that my apologies for trying to... what a pity that I had to wake you up. Such a pity that we have such huge time zone difference. Thank you for many years. Thanks to Harry Ritchie, who introduced us. Of course, it's very useful, but we have agenda to follow your program. Your lecture was amazing. Thank you so much. If you wish, please stay with us. We have fantastic agenda later on. Thank you very much, Professor Tamir Sekin.
The OR, I apologize. I will follow up later. Thank you so much. Thank you, Leila. I'm grateful. Thank you.
Thank you. Dear colleagues, well, it so happened that we are now also woke up somebody because of time difference, because we've got to ensure that everyone should listen to the lecture. The floor goes to Professor Diego Marin. Diego Marin, opportunities of gene editing in human embryo. And the second presentation, he would deliver novelties in pre-implantation genetic testing. Both presentations will be delivered one after another. Dear Professor, you have 40 minutes. Diego, please, as we agreed, Please, we give you some 10 minutes for the first presentation and 30 minutes for the second presentation. The whole country and the world at large are looking forward to your data. We hold you in very high esteem. We love you. We appreciate you. My apologies because we woke you up so early. Apologies. Thank you, Professor. Floor goes to you.
Very much, Dr. Lila. For us, it's a pleasure to participate in this Congress, and no worries about waking up. That's we started really early here. If you can hear me well, I will continue.
Yes, we do. Thank you.
Да, очень хорошо.
We can hear you perfectly well. Thank you.
Perfect. So we're going to start with a presentation about opportunities of gene editing in the human embryo. And I open it with a very beautiful picture of a blastocyst, human blastocyst, that was published in Science magazine, just to start breaking the ice. First, I would like to disclose that I'm a full-time employee at Genomic Prediction, which is a PGT company in the US. So before we start talking about gene editing and how this could be an opportunity and how we can exploit it, it's very important to clarify two concepts. One thing is gene editing. The only thing is genetic embryo selection, because sometimes people use them interchangeably and they are very different. On the one hand, gene editing, we're talking about manipulation of the DNA. So there is we're doing something on the sequence of the genome. And an example of this is these technologies that have been doing so much sound in the field, such as CRISPR-Cas9. I'll explain later, we're going to focus on gene editing, but I did want to clarify that has nothing to do with what we do in PGT. PGT, which would be the second presentation, talks about screening the DNA, whatever is there, and then once we have a cohort of embryos, then we select. And as an example of this is the PGT. Just wanted to start with that different of concept. Now, going into the topic, gene editing in human embryos. So there are several techniques, but I would say that the most widely used, and in fact it got a Nobel Prize, is the CRISPR-Cas9 system. So a CRISPR-Cas9 system, we're talking about ribonucleoproteins. So it's a system in which we have a protein, that's the Cas9 protein, and then we also have sequences of RNA attached to this protein. In this case, for example, the what we call the guide RNA. So the way this works is that this guide RNA sequence that you see here is something that we can edit the way we want in the lab. So we can say, for example, I want this Cas9 to go to chromosome 3, specifically to the small arm of the chromosome. And we can do that by just doing this in the lab. So the way this works is we inject in cells that we want to edit both the protein and that guide RNA that we made artificially. It would go into the cell, and then we will have the double-stranded break, because what CRISPR does is that it cuts the DNA, and when it cuts it, it puts new nucleotides. So that's how the editing works. It cuts it, and then we fix it. Now, a very important concept is, how does this editing happen? Or when does it happen when we're talking about a human embryo? So there are different stages in which we can actually edit the embryo. The most, I would say, useful is at the time of ICSI. So we have an M2 oocyte, and we're going to do ICSI. So at the same time where we inject the sperm, we also inject the cocktail of proteins. That's useful because we assure that the entire blastocyst after 5 days will have at least that editing that we did. The other stage in which we could do it is once we have the zygote. So we already have fertilization, and we inject the CRISPR-Cas9 at this stage. The only disadvantage here is that we might have mosaicism, because once we have a zygote, it's possible that we have syngamy of the DNA, so it's not going to be affecting the entire cells in the blastocyst. Another time in which we could do the CRISPR-Cas9 on injection is when we have an embryo of 2 cell stages, which has a disadvantage that it results in mosaicism, because some cells it would work and some cells it won't work. Now that we established the concepts, I wanted to open with this article. This article was published in 2017 and was a very important piece of paper, because for the first time, the authors published that mutation was cured in the human embryo. So what they did, they injected the embryo, with the sperm and then with a CRISPR-Cas9. So they did it at the time of ICSI. They grew the embryo until day 3, and they analyzed the blastomeres. And they saw when they analyzed the blastomeres that the mutation was gone. So there was a publication in Nature, everyone was happy. We were thinking CRISPR was very promising for this kind of use. However, well, in science it's very important that we always have to replicate every single experiment. So our group decided to replicate it again. But it's very important to show that when we analyze the data, it's important to know what platform we're using or what technique, because in 2017, the techniques that were available in the embryo to analyze the data were not that sensitive. Now in 2022 or 2020, we developed a platform that has a very high resolution, and we're talking about 800,000 probes in the genome. So this allowed us to have a better view of what was going on in that embryo that we attempted to edit. And the cool thing about this platform is that from one biopsy of an embryo, from a couple of cells, not only can we see all chromosomes, 24 chromosomes, but also each chromosome individually. And this is what opened the door to our discovery. So just to go back, we wanted to replicate the same experiment. What we did was we found a sperm from a donor who was blinded. So it was homozygote for the same mutation. What we did, we took a donated egg, we injected it with ICSI, and at the same time of ICSI, we injected that CRISPR-Cas9 that was directed to the mutation we wanted to cure, which was coming from the sperm. We made blastocysts, we let those blastocysts grow, we took a biopsy, a trophectoderm biopsy, just as we do for PGT, and we analyzed it in our new platform. We did the same thing with the inner cell mass, creating a embryonic stem cell line, just to have much more material to keep analyzing it and see if we actually cure the mutation. And the surprise that we found was that the mutation itself was not being cured. What was happening is that the entire chromosome or part of the chromosome was being lost. So what I'm showing here is a figure of the Cell paper we published at that time. So here we have chromosome 6. This would be the small arm of chromosome 6, centromere, long arm of chromosome 6. So if you can observe here to the right in the long arm, there is no data in the middle. What this indicates is that there is no heterozygosity, meaning we only have one copy of that chromosome. So when we look at this data, we were like, how is it possible? We thought we were targeting the mutation, which was located here in this arrow, but in fact, we were getting rid of the entire chromosome. And we did this again with other embryos, and we observed the same. In this T biopsy sample, after editing, we saw that the entire chromosome was being left. And the conclusion was that that initial paper that I showed at the beginning, when they claimed that there was a curation of a mutation, was not really true. That was not accurate. What was happening is that the entire chromosome was getting lost. And of course, once we proved this and we published this, it was a very mediatic reaction because, we're talking about an undesired effect of CRISPR. We were trying to cure a mutation. In the end, we got rid of the chromosome. So our research got a lot of attention in the media, and people were being very cautious. However, I would like to end this intervention with a message, which is when science goes wrong, there is always an opportunity. Therefore, the title. And it's true that with CRISPR, we might be getting rid of entire chromosome, but you know that in our field, advanced maternal age has a problem. They have more chromosomes than we want. They have aneuploidy. So we were thinking, can we use this CRISPR system to actually get rid of those extra trisomies that are a headache for us in the infertility field? And this is what we did with Columbia University in a collaboration. Gynecologic by that time in 2021, we won the ASRM prize paper because for the first time, we proved that it was possible to get rid of a trisomy in the human embryo. This was a proof of concept. We only managed to do this in a few embryos, but basically we did exactly the same experiment. We took, in this case, it was a zygote. We injected the CRISPR-Cas9 directed to chromosome 13, because chromosome 13 was trisomic in this zygote. So we wanted to get rid of it, just to cure it. So we did that. We grew the embryo to day 3, and each of the blastomeres, we analyzed them in the platform. And some of the blastomeres did have, sorry, it was chromosome 16, not 13. Some of the blastomeres had the trisomy 16. We couldn't cure it, but there were some blastomeres in which the copy number of 16 went down to 2. So for the first time, we managed to prove that we can eliminate a trisomy from that 2PN embryo, meaning that if it arrived to a blastocyst, it could potentially be a usable blastocyst, right? So this is something that's still under research. What we call this project is correction of aneuploidy. So we're doing right now a lot of interventions. We're doing a lot of embryo donation just to prove this and have a big N, because eventually this could become a very useful tool, especially for advanced maternal age. And one other advantage that we have had, which is very prolific, is that we have mentored a lot of fellows, students from Columbia University. Each year we get new discovery with this technology, and we expect that for Evan Rashev, which is our new fellow, in 2023, ASRM could present an advancement of this technique. So the first intervention, I will end it here. Here you have my contact, and I would like to end with the topic of this book. I recommend it. It's pretty good, and it really talks about how we're going to see the human species in the future. I don't know, Dr. Leila, should I continue to the next one?
Yes. Well, I suggest you move on to the next presentation. Make a double, as they say. All right? So if there are questions, we'll ask you at the end. So Professor Marin, please continue with the second presentation. Diego, please go on.
Perfect. Thank you very much. So now we're going to change gears a little bit. We talked about genome editing. Now we're going to talk about embryo selection, which is pre-implantation genetic testing, basically on what we do, if we do genetic selection. So here, I'm going to take a little bit more time because I do want to show you the novelties in 2023 of PGT, specifically how we're optimizing platforms to make this way better. Also, to just make the point, and I think that'll be the take-home message, pre-implantation genetic testing of PGT goes beyond what we always do, which is aneuploidies, monogenic diseases, and I want to show you the new applications and how this is going to be very widespread in the field in a few years. I want to touch a little bit about PGT and artificial intelligence. I know there is a lecture about this. Artificial intelligence is something that's right now, it's extremely coveted as a concept. And finally, the elephant in the room in PGT right now, which is segmental aneuploidies, something that not everyone talks about. So with respect to optimization of PGT platforms, PGT has been in the field for almost more than 10 years. Remember, we started using FISH, and then we moved to molecular techniques because FISH, even though they did have some benefit, it was not as tangible as it is right now, and it was damaging some of the embryos. So we moved 10 years ago, or a little bit more, to molecular techniques in which you could do comprehensive screening of all 24 chromosomes. And here we have some sort of a timeline, if that's a good concept, of the evolution of these platforms. We started with qPCR, only 4 locations in each chromosome. Then we moved to arrays and next generation sequencing, which is looking at thousands of locations in the genome, probably 20 or more thousand. And then we also have other techniques such as the SNP array, because it genotypes single nucleotide polymorphisms, in which the resolution is extremely high. We're talking about 800,000 locations in the genome from just a biopsy of 6 cells. So the important thing here is that optimization of PGT platforms have to go in the direction of increasing resolution. How can we take as much information from the trophectoderm biopsy that we are already performing? And one of the new advantages or huge novelties is the use of single nucleotide polymorphisms, or SNPs. SNPs have a lot of advantages. Not only do they probe more locations in the genome, but it also allows us to look at other things. For example, relatedness between samples, or for example, false positive mosaics, right? You know, mosaicism is also a topic in our field. So just take home message here, PGT platforms get optimized by increasing accuracy with resolution. Now, here, the only thing I wanted to mention was that right now in our field, PGT is being developed, is extremely well accepted, but we have a problem, we have an issue, and that is we have a huge heterogeneity and variability of PGT platforms and vendors. And the problem here is that each laboratory would do whatever they want because there is no huge regulator or FDA that would look or oversee PGT. So the problem of this is that each platform, each vendor would do whatever they want. So they would do their own standards and validations, and this could result in this next slide, which is clinical outcomes differ among PGT labs. What does this mean? There's going to be in 2023, if you have the opportunity to attend virtually or in presence the ASRM and ASHRAE, a lot of work of this type, which is one IVF laboratory comparing different PGT labs, meaning it's one IVF lab, they have patients, they send one chunk of patients to PGTA lab 1, PGTA lab 2, PGTA lab 3. And this is very useful study design because you can see by controlling the IVF lab if there are differences in each genetic testing lab, which is something that before was not really done, right? And there has been some publications such as this one in which clearly you can see that the PGT chemistry, the PGT laboratory results in either higher or lower live birth rates. So this is very important because we're trying to optimize it, but we need to optimize these PGT platforms in a cohesive way altogether. Otherwise, we have these differences. This is another example. It was a study published in 2021 in which 3 PGT technologies were compared from the same IVF lab. The aneuploidy rates were different. The clinical pregnancy rate was higher with one platform versus the other one. And this is again, because some platforms have more resolution than others. So it's very important to not do what the umbrella does, which is putting all these things on the same concept because they are different. Okay. Now that we spoke about at least the novelties in increasing resolution of PGT, the next thing I would like to talk is how can we go beyond the conventional indications of PGT? You know that right now preimplantation genetic testing is mostly used for aneuploidy screening, for monogenic disorders, for structural rearrangements when we have translocation in parents, and lately the polygenic disease. It's something that is novel, however, it was introduced a couple of years ago. So let's say that these are the current 4 indications of PGT. But how can we go beyond that? What's happening this year? So because we are increasing resolution of these PGT platforms, the more data we have, the more doors are open. And one thing that we could do is between samples that we process in PGT, we can compare them and see how closely related they are. For example, are they siblings? Is this the correct mom? Is this the correct dad? And this is very important because we're talking about a potential application of a genetic witness. You know, we are used to the matcher system, the electronic witnessing system in the IVF lab in which you put the barcodes on the dishes and then where the gamete comes, you control that. But we do not have a genetic testing until now. So this genetic witness is a safety and quality control tool of the IVF lab. And what I'm showing here is something my student Diana from University of Costa Rica plotted, in which we are comparing this y-axis is the similarity, genetic similarity, and we can tell that the self-section, meaning different biopsies from the same embryo, so it's the same DNA origin, has a very high similarity. It's very easy to distinguish. When we have siblings, and look at, for example, the difference between siblings and unrelated samples, there is a separation. So that's how we can distinguish if you have all these biopsies from one patient, the other one from the other patient. And also the parent and child relationship, it's easily distinguishable from the non-related. So using this technique, and if we have biopsies and also DNA from the parents, this technology is possible to tell you, you use the correct gamete, everything is fine. And just an example of how we do this on the day-to-day basis, we process, every time we do PGT, 96 samples at a time. So what I'm showing here is a heat map. And the heat map shows the comparison of those 96 samples compared to themselves. Therefore, this diagonal black line means each sample is compared to the same sample. And that means, they are the same genetic origin. But if you notice, there are some squares. And these squares, what they indicate is that all these samples are trophectoden biopsies from the same patient. Therefore, they are all siblings. It's the same cohort. And as you could see, this is pretty easily distinguishable. Each square is a patient. And this is what we use to guarantee that the sample that we received, there is no mix-up. Everything is fine in the IVF lab. Also, this is also useful to control PGT lab, that there was no mix-up of samples, because it could happen both in the IVF lab, but also the PGT lab. And finally, if we have parental DNAs, we can also confirm if the right sperm and the right egg were used for those embryos. So this is a new concept. A genetic witness is being implemented in some centers. So I believe that this is going to be revolutionizing the field, because we are talking about something that's a very important tool. PGT is not only aneuploidies, it's also control of the IVF lab. Now, moving forward, how can we go beyond PGT? Is there another way? Well, I don't know if any of you had the opportunity to attend the PGDIS Congress. PGDIS Congress is something that a Congress done every year in various cities, mostly in Europe, of PGT experts. And this year it was in Paris. And Dr. Santiago Monet, who I know that you may know, he presented for the first time a product from this company in which they can do whole genome sequencing on the human embryo. Now, whole genome sequencing is different from conventional PGT, because we are actually looking at specific mutations across the whole genome, and this could help us detect de novo mutations. So PGT, if this was a proof of concept, so if this was to be applied, it means that PGT would do aneuploidies, genetic witness, and on top of that, screen if there are any mutations in the embryo that we did not know that parents had, or the parents did not have. So this is something, it's proof of concept, but it's certainly a novelty, and we have to keep on the radar. Now, another topic, how can we go beyond PGT, is doing research on other biomarkers in the trophectoden biopsy. Because, right now we take the embryo, we take a trophectoden biopsy, we do the aneuploidy screening. But in that biopsy, if we could potentially look at other molecules like messenger RNAs, gene expression, or proteins, or epigenetic markers, this becomes very useful, because we know that euploid embryos, normal embryos, they have a roof of 60%, 70% implantation rate. There is still 30% that's not explained. How does a normal embryo does not implant? Why that 30% fails? Well, it could be metabolomics of the embryo or something else going on in the culture lab. So that's why these extra markers are important. We tried to do this in 2017. We published a proof of concept from the same biopsy. We could get aneuploidy screening and gene expression. A group in Canada also replicated it. Right now, there are proof of concept because it's very difficult to couple the chemistries, the reactions, to get both DNA and other markers, but we're working on that so that we can get more data, and not only DNA or aneuploidies, but other molecules that might be informative. And just to end this part, PGT and artificial intelligence, I just have one slide, but what I wanted to make sure is that artificial intelligence is something that's going to be a tool for us and is revolutionizing our lives. And it's important that not only in PGT, but in the IVF field, we have to integrate all parts of the practice, from the patient's DNA, from embryo development, from results of PGT, from clinical outcomes, because once we have all these elements and maybe morphogenetic data together, then we can do artificial intelligence so that we could do better predictions of the outcomes from the very beginning when the patient comes to the clinic. And I want to emphasize that because sometimes we believe that artificial intelligence is just doing an algorithm to predict a karyotype in the blastocyst. That's not really artificial intelligence. Artificial intelligence is a lot of data from all parts of the system of our practice in order to integrate it and try to do better predictor of the clinical outcome. I wanted to show you guys this. You can visit this website. It's a company that is the first one to my knowledge that is doing exactly that. That is going to different centers, different PGT labs, trying to get all that data so that we could create a network and make our treatments more efficient for the patients. So you're welcome to visit it. So now to start ending the presentation, I wanted to talk about the elephant in the room, the awkward topic right now in PGT, which is segmental aneuploidies. Segmental aneuploidies, or we call them also partial imbalances. So just to introduce it, remember that PGTA for aneuploidy usually looks at trisomies, monosomies, so changes of the whole copy number of the embryo. But when we're talking about segmental, we're talking about a section of the chromosome that is either gained or lost. In this case, I can show you an example. This is the result of a trophectoderm biopsy. The karyotype was 46XY, duplication of a small segment of chromosome 10, a short arm. And here I'm just showing you chromosome 10. So you can see here the short arm, the long arm. And when you these two plots, they are showing two things. Well, first, that this part of copy number, or this part of the chromosome, sorry, has an increased signal, increased copy number. So we can see there are 3 copies of this part. So there was a duplication of that small part. And this other plot just confirms it. This is what we call the B allele frequency. And as you could see, there is a change of pattern of the data points. And this is what confirms that this is a true duplication. So this is what a segmental aneuploidy is. And we know that there are syndromes with segmental aneuploidies with deletions, duplications. So we report it in the PGT, and we do not recommend transfer. I also want to show the audience that there has been a lot of work with segmental aneuploidies. This is pretty old, from 2017. This is 2022, 2021. But the major groups in the field, they have done a lot of research trying to describe it. However, the prevalence of segmental aneuploidies in the human blastocyst is around 10%. So because it's not as high as, for example, aneuploidies in maternal age, like 80%, 4%, it's very difficult to get enough N or enough data points or enough samples to do this research. But there is some literature. Now, why do I want to show you guys this, and why do I think it's the elephant in the room? Well, because we have done a study that's right now under review, in which we did multiple biopsies from the same embryos. We have around 20 embryos. Here, this is the result of chromosome 11 of biopsy number 1. We have the long arm, the short arm, and as you can see in the short arm, we see a decreased signal of DNA, therefore we have a deletion, right? And you can see this white patch means there is no data points because we have a deletion, only 1 copy of that arm, therefore no heterozygote SNPs. We perform a second biopsy on the same embryo, discarded for research. Same thing. However, I don't know if you noticed, but there seems to be more noise or more data points in the middle. We did a third biopsy. Chromosome 11 still look with that deletion, but we started looking more data points in the middle. So what's going on? Is it the quality? Is it that the deletion is getting lost? Fourth biopsy, it seems that it's disappearing, right? And the fifth biopsy, we saw that this chromosome practically looked normal. So what does this mean? That this was a true mosaic of that deletion. And why is this an issue? Because if the biopsy would have been done in this section, we would have been transferring this embryo because it was 46XY. So the point that I want to make is, or the discoveries we found, segmental aneuploidies, most of them, the vast majority, are mosaics or of mitotic origin. And they are also of paternal origin. So we also had DNA from mom and dad. And we know that for a whole chromosome, when the whole chromosome is an aneuploidy, the maternal, the egg, is more responsible. But we're seeing that when we're talking about deletion duplications is the sperm, the one that has a bigger role. So, of course, this opened door to a lot of questions. That's what I said. I think this is the big novelty right now. ESHRE and ASRM this year, we're going to talk a lot about segmentals. Main question, should we transfer these embryos? Well, this is an unanswered question. What we recommend is genetic counseling, because that small part of the genome could have very important genes, that the leader duplicated one, which could result in, let's say, a syndrome. So it's very important. Maybe some sections won't, some sections are likely to transfer, but we don't know. So that's why I mentioned it's an awkward topic, but we need to do more research to try to define what to do with these embryos. And just to end this section, there was a question that we have been receiving from physicians lately that we didn't think it was important, which is, are these segmental aneuploidies real? As geneticists, of course they are real because we can see them. But then there are some hypotheses saying that, you know, that the DNA, when it replicates, it goes to the chromatin, and there are specific points in which the DNA strand opens and the polymerases start replicating. So there are some literature saying that there are specific locations, they are called origins of replication, and they have been correlated them with the beginning of a segmental aneuploidy. So what could this mean? This could mean that some segmental aneuploidies we're seeing are not real, but are an artifact, because that's where the DNA is starting to open, to replicate. So it's a biological normal process. So I guess the message I want to show is that right now we have a lot of research to do with segmental aneuploidies, because we need to define whether, first of all, are these transferable or not? And second, are these artifacts? Which segmentals are artifacts and which are not, which are true biological phenomena? And I hope I cover most of the topics. The point today was to show you how PGT is being right now seen in US, Europe, Australia, Latin America as well. And here you have my contact. If you have any questions, please don't hesitate. And this is my team here.
Dear Diego, thank you so much. Our Congress is called the New Technologies in Diagnosis and Treatment of Gynecological Diseases. And it was a brilliant presentation. Well, I didn't understand even everything. I didn't manage everything, maybe just 1%, but I do not deal with the issues. I deal with clinical issues. A question from a clinician. In general, do we need this? If we do not know, well, we got a lot of information, a lot of knowledge. Should we do the transfer or not? Well, segmental or not? Well, 2 minutes. What would you say in answer to my question? In practice, what is the practical meaning of this colossal massive of knowledge? Yours, Professor Treff, PGT, other issues. Well, in a couple of minutes, could you say, do we need this or not? And why do we need this, dear Diego? How far should we go? And what is real today for us? Just in a couple of minutes, as for a simple gynecologist.
Of course. So when we're talking about PGT for whole chromosome aneuploidies, it is pretty clear. We know we have very good studies, randomized control trials, that huge monosomies, trisomies, this does not implant, have low predictive value, and if it implants, it's a syndrome. Now, going back to what we presented today, the novelties, the new current debates, we are at the stage of looking at this segmental aneuploidies in a, I wouldn't say research-based, but we still do not have clinical data, because the next step that Dr. Leila was mentioning is the clinical trial. So what we're working right now is trying to do a non-selection study, meaning that we will have patients, we will biopsy the embryo. The biopsy, we're going to freeze it. We will analyze it. We transfer the blastocyst, biopsy it, and then we see the outcome. And then we go back and look at the biopsy. Because if we see segmentals there that actually resulted in a pregnancy and everything is fine, then we will have the data for physicians and tell them we're fine transferring these. Unfortunately, as of now, that's not possible, but it's going to be a huge topic in the future congresses.
Dear Diego, well, I've been watching and I've been looking, browsing the literature, trying to get into it. I didn't cover immunology or genetics in my medical school, but in very many modern studies it says that first it seems like this embryo is not really good, but if you transfer it, it begins to fare well after the transfer has taken place. It kicks off sort of good. And many researchers say, especially in ladies over a certain age, you don't have such clear pre-implantational PGT, you don't need this so much, because to some extent, this is a trauma to the small embryo. What's your take on this? Or do you think we should transfer? Oh, maybe we should block. Where is the responsibility? Who does it lie with? Because there are some studies, at least 10, even I could give you this, references that somebody regarded it, somebody disregarded it, and as a result, some embryos who seemed not so good, but they sort of caught up with those who turned out looked excellent. What's your take on this?
Perfect. So my take on this is one of the first slides of the second presentation when I presented the umbrella of all these different vendors and companies doing PGT. I think this is part of the problem, because when you have all these different vendors, commercial interests, everyone would try to optimize the results, and the platforms are not that accurate. So what happens is that between different labs, you see embryos that, oh, they are chaotic, they are aneuploid, don't transfer them. You biopsy the same embryo in another lab and it's normal. So I think that's part of the problem. And just to mention something that you just mentioned about the trauma of the embryo, it is true that the trophectomy biopsy could create trauma. However, not really if the embryologist is very well trained, and if the embryo has cells and is biopsiable, because there are some embryos that you cannot even dare to biopsy, also because they will not survive thawing.
In the last question, if you will, you mentioned artificial intelligence, AI. I've got time-lapse camera. I used to have excellent embryologist, and we trusted in him. Nowadays, there is time-lapse camera, which tells us, oh, look, this one is developing well. Just how far should we go in using artificial intelligence? How far should we follow it? Or should we just bear it in mind, its recommendations? And where intuitively, when this AI, will it really be intuitive, very much like humans are? And this will be my last question. I promised I would let you go. Thank you. How far can we go?
Yeah. So the artificial intelligence, as of today, we don't believe it is accurate. We don't have enough data to apply it on the day-to-day lab today in 2023. But for sure, in a couple of years, this is something that we don't even have to think about it. It's gonna come, and we need to adapt. Now, how far should we go? It depends on how much data and how much accurate that is. Because again, as I mentioned, some people say, oh, we can do artificial intelligence. That's not really it. Artificial intelligence is thousands of data points from a lot of centers. And to be honest, if this is as accurate as they are predicted, it is possible that in the embryology lab, we're going to see a lot of changes. I'm not saying embryologists would lose their job. It's just that there's going to be a change in the IVF lab procedure. But certainly this is going to come and we will have to adapt no matter what.
Thank you very much for this question, but most importantly, that the results of this AI depend on what a lab technician suddenly, if he made a mistake or not, you know what I do? Dear Diego, dear Dr. Morin, thank you so much. Please give my love to my friend Trev and all your company. My daughter is now based in US. She's also watching you. Thank you so much. All the best. Thank you. Thank you. Thank you so much. I have to give the floor to the next speaker.
Убирайся. Дорогие
So, dear colleagues, once again, it is my pleasure to give the floor to Professor Tomer Singer. He's been waiting online for a lot. I think I'll stop the previous speaker. Fertility and endometriosis, surgery, egg oocyte donation, surrogate maternity, and what follows next. Took a service to infertility in New York City. Shady Grove Fertility, New York. Brilliant doctor, knows so much about fertility. From Singer, 20 minutes, I'm afraid no more, no less. The next speaker would be delivered, Professor Naftalin, with a fantastic new data he would present. Fred, my apologies for keeping you waiting. Donor Singer, please, the floor goes to you.
Thank you, and good morning for the team in New York. Good afternoon for the team in Russia, and thank you, Leila, for inviting me again for this wonderful conference. So I'm going to try and bridge between the great talk that we just heard by Dr. Marin and the surgery presentation on endometriosis that was given by Dr. Sechkin. So we'll start by talking about what fertility treatment we have for patients who present with the endometriosis. So, of course, surgery is the mainstay of treatment when a patient presents with either a pelvic pain, recurrent implantation failure, recurrent pregnancy loss, endometriomas on their ovaries, adenomyosis, and sometimes as a complication, potentially Asherman syndrome or hydrosalpinx. And the options for surgeries are ranging anywhere from a DNC, thoracoscopy, to a open surgery to laparoscopic surgery, and now more and more robotic surgery. And the second treatment for patients who are desire fertility is either in vitro fertilization, especially due to a tubal factor and diminished ovarian reserve, or egg donation when the diminished ovarian reserve is significant, or when the patient lost their ovaries or have stage 4 endometriosis with very low AMH and very high FSH, or of an advanced maternal age. And in those cases, the patient will have the option of selecting the egg donors. We'll talk about pros and cons of choosing a fresh versus frozen donor eggs, what the medical screening that the donors are going through, the psychological screening, the legal contracts that are enforced, the FDA screening, and the process of embryo creation. And lastly, when a patient has a uterine factor as a result of the endometriosis, they'll have the option of using a gestational carrier. And we'll talk about the GC medical screening, the psychological screening, and then the embryo transfer, and whether or not we should transfer 1 versus 2 embryos. So the indication for egg donation, which is something that they have evolved in the past 40 years, is mainly decreased ovarian function, premature ovarian failure or insufficiency, genetic abnormalities. We know there's a lot of patients with a fragile X or a mosaic Turner's, failure of other treatment, whether it's IUIs, IVF, or any medicated ovulation induction. The LGBT community that we're helping with co-IVF or dual insemination in the same-sex men couple who are in use of both egg donation and a gestational carrier, and of course endometriosis patient, which is a very prominent condition that we see in the infertility world. So this slide just shows the factors that can affect infertility and cause infertility. And we take a very careful history, family history, personal history, do an extensive genetic panel, and of course look at the patient's signs and symptoms. And when the patient have diminished ovarian reserve or had previous ovarian surgery or have been exposed to any chemical or radiation exposure, of course, that will have an impact on the fertility. In the US, the process of using a third-party services, which is a big name for sperm donation, egg donation, and gestational carrier, is monitored by the FDA. So there's very strictly defined FDA testing for both the donor egg and sperm donors, and we basically do the testing prior to initiating the creation of the embryos. And the FDA testing usually includes blood tests and a urine test, infectious disease questionnaire that the donor will complete, and then a physical exam by a physician or nurse practitioner or PA. And then we test all those things, get the confirmation that the patient is negative, and then we'll be able to proceed with the creation of embryos, whether it's with a donor egg or whether it's for a transfer into a gestational carrier. The FDA screening timing is usually 7 days within the sperm production, and with eggs, it is within 30 days. What we see here in the slide is a patient with stage 4 endometriosis. This is actually a patient for a couple months ago that I took care of who went for IVF, and you can see that the patient in the meantime has an IUD in place with progesterone secretion, has bilateral endometriomas, has significant diminished ovarian reserve with a lot of adhesion and scar tissue, and the hope is to try and obtain a few eggs. You can see that she was born in 1988 there, so this patient will go through several probably rounds of IVF before she obtains enough euploid embryos to be transferred either into her uterus into a gestational carrier. So there's always the debate whether or not this patient can benefit from surgery prior to retrieval, or should we proceed with the egg retrieval with all the risks that go hand in hand with that, and only then proceed with surgery prior to a transfer, or even omit the surgery component. So that's something that I think it's where the debate is still ongoing, and a multidisciplinary approach with the surgeon and the OBGYN and the fertility doctor is of paramount importance. What we see here from the CDC is the chances of conceiving using a donor egg, and we can see that from age 40 to 47, there is a significant decline in the implantation rate due to aneuploidy, as Dr. Diego Martin had mentioned in his previous presentation. And what we do see, and which is very reassuring to our patient, that even a patient who's 46, 47, the implantation rate remains the same when we use a donated gamete of patients who are usually 21 to 32 years of age. So when a donor egg recipient comes in to be seen and desires future fertility, they usually are faced with 4 options. One is to use their own IVF center egg pool, a designated egg donor, such as a sister or a cousin or a family member or a friend. More and more patients are using egg banks, and it is my prediction that probably in the next decade it will all be a use of frozen eggs rather than a fresh donation. But in the meantime, when looking at the SART database, which is the organization that assess all the IVF clinic in the United States, we see that at this point it's favoring egg bank and about 60% frozen eggs and 40% fresh eggs. And if we look at the data just 5-6 years ago, it was a prominently or mainly use of fresh donation. So the shift has already happened a few years ago around the time of COVID, and now we see more and more the use of commercial egg banks. And lastly, if a patient has a very unique ethnicity or background, they may choose to use an agency that focuses on that ethnicity and background. The donor egg screening includes patients that are 21 to 32 years of age, and this is true to anonymous donation or de-identified donation, not for a directed donation, meaning if a patient wants to use their 33-year-old sister, of course, we'll be exploring that and see if that sister is a good donor. Height and weight usually is taken into account, and we would like to have a BMI that's less than 30, non-smoker, healthy medical and family history. We will, of course, run an AMH, FSH, and do an antral follicle count and a pelvic ultrasound prior to the donation. Consultation with either a nurse practitioner, PA, or physician. We'll do a negative drug screen as required by the FDA. Again, if it's a directed donation, there's the option of course, signing a waiver there and using a sister who may be using weed or marijuana and not exclude her. Infectious disease screening in accordance with the FDA, as I mentioned, and genetic carrier screening to make sure that the donor egg is in a match with either a partner or a sperm donor that the recipient will be using. And the donors themselves are going through psychological evaluation using both testing and a personal interview. Then the medical clearance, once it's completed and the genetic testing is back and psychological clearance is back, we go into the legal contract, which can be between the directed donor and the recipient, or between the IVF center, or if it is a commercial egg bank, between the egg bank and the donor itself. You can see on the right-hand side an antral follicle count of a typical egg donor, which you can see usually will have greater than 6 or 8 follicles in each ovary, and then we'll be able to proceed. As I mentioned, with looking at the SART database just from 2019 to 2021, we can see a significant shift from fresh donation to frozen egg banks. And initially in 2012, when the American Society of Reproductive Medicine has released the notion that egg freezing is no longer experimental, we have seen that there's a big shift towards commercial egg banks. There's a couple of egg banks that are available in the US, and more IVF centers have their own egg banks that are now recruiting donors for the sake of their own patients who are in need for an egg donation following IUIs or IVFs that are not successful. And it's an estimate of about 5,000 babies that were born using egg banking since 2012. But there's a challenge in maintaining an accurate number here. Because SART is reporting about a year and a half back, and there's been a big shift towards frozen eggs just in the last 2 years. We assess that about 45 to 50% of patients who are using egg donation with the fresh eggs and frozen eggs and fresh transfer will have about 45 to 50% implantation, and that's fairly conservative. What are the advantages of using a frozen donor egg? So the big advantage is the timeline. So a patient comes to see me, they underwent 2 or 3 IVFs, and unfortunately they have a diminished ovarian reserve, or all their embryos are aneuploid if they chose to do genetic screening of the embryos, and then the donor can essentially be matched within a couple of months with a donor egg. They usually will receive anywhere between 6 and 8 mature eggs, with the option of securing more eggs if they would like to have a larger family. There's no need to synchronize the recipient, who is the patient that we're taking care of, with the donor, given that the donor already went through the cycle, usually 6 to 12 months prior to that. It widens the donor selection, so the donor egg recipient can choose from different egg banks, any commercial egg banks or any IVF center egg bank. And there's really no need to wait for other recipient in the case that there's a split egg cycle, and there are some centers that offer, including ourselves, a split of donor egg among 2 recipients to reduce the extranumerary embryos if the couple would like to have only 1 child, or if it's a single patient who's using a donor egg and donor sperm and would like to have just 1 child. There's no reason why there's be many residual embryos or extranumerary embryos that no one is going to be claiming. More control over the cycle timing. Patients who are going through fertility treatment, trying to struggle with the scheduling conflict with work and school and so forth. So that will give the recipient the autonomy to decide exactly when to do the transfer, when to thaw the eggs, when to complete her fertility journey, and when to conceive and when to deliver, essentially. The disadvantage are that you have a limited number of eggs and the lower chances of embryo cryopreservation. That means that if a couple were trying to have a family of 2 or even more kids, and they're starting their journey in their early 40s, that means that if they only chose 6 or 8 mature eggs and we fertilize those eggs with the husband's sperm, usually that will result with 1 or at most 2 kids. And if there's only 1 child and there's only 1 embryo or no embryos remaining, that donor may not be available a year or 2 or 3 down the line when they're ready for baby number 2. So that's something we are discussing with our patient, and they'll have to decide how many eggs they would like to match with or secure. This is, in a nutshell, the process of in vitro fertilization. The only difference in an egg donation is the patient who's doing the injection or undergoing the egg retrieval is the donor egg, the same 21 to 32 years of age, or the sister or the cousin in the case of directed donation. The process, as we know, takes about 12 to 14 days of self-administered injection, usually once a day. And then the patient will be coming for monitoring 5 or 6 times during that 2 weeks period. And there's a lot of trends towards limiting the visits to make it more palatable for donors, and then eventually an egg retrieval. Usually the protocol will include low-dose stimulation, very close monitoring, usually a GnRH agonist trigger, given the risk of ovarian hyperstimulation in this young, very healthy patient population. Then on the day of the retrieval, we either freeze those eggs if we're creating eggs for future use with a commercial egg bank or IVF center egg bank, or we fertilize the eggs. And usually the option to fertilize will be either using insemination or ICSI, and I'll talk about it in a second. And then we create embryos, and the options are either to transfer an embryo, either on day 3, day 5, or to freeze the embryos for future transfer, or to do pre-implantation genetic testing, as we heard from Diego in the previous presentation. Usually the transfers will be done under ultrasound guidance, with over 95% of the cases being, at least in our center, a single day 5 embryo transfer. This is the timeline of IVF and egg donation. You can provide that information with your recipient so they know that when the donor starts, we're talking about 2 weeks roughly of stimulation and an egg retrieval. We'll update the donor egg recipient during that time of how the donor egg is doing, how many follicles are growing, and we may use birth control pills, Lupron, an estrogen patch, or GnRH antagonist in this most stimulatory cycles, given that we would like to use a GnRH agonist to induce maturity of follicles. 2 weeks later, the donor is completing her cycle with her next period and basically completed her donation. The ovarian stimulation itself will require also FDA testing, injection of gonadotropins, ultrasound monitoring, and blood tests on average 4 to 6 times, and then the egg retrieval. So when donors are enrolling to become an egg donor, this is a process that is outlined to them, and a donor in the US usually can donate up to 6 times in their lifetime. The egg retrieval itself takes about 15 to 20 minutes. Patient, the donor will have IV sedation, usually with propofol. Sometimes we'll add fentanyl to the mixture. The procedure takes about 20 minutes, and the patient will go home about an hour later. And usually anywhere between 10 and 25 eggs are being retrieved. And of course, there's many cases when the donor will have very high AMH and will have more eggs. We'll have to monitor very carefully following the donation. The embryogenesis, the part that is actually done in the lab. So if we take 10 eggs from a donor egg and we inject the sperm either of the partner or the sperm donor, usually we quote about 70 to 80% fertilization, with about 6 to 8 of those make it to day 3, which more and more centers are now shying away from day 3 transfers and even an assessment of day 3. As Leila was mentioning, a lot of embryoscopes have taken place in IVF labs, and we essentially assess them under closed system and then assess on day 5 for the best embryo to be transferred. Many who go through to do egg donation have gone through IVF themselves and are very familiar with pre-implantation genetic testing. And even though pre-implantation genetic testing is not recommended given the young age of those donors being in their 20s, a lot of patients elect to do pre-implantation genetic testing. And there's pros and cons that we just heard with false positive, false negative, and maybe the PGT in that donor egg population is overutilized, at least in the US. But many patients will choose to do pre-implantation genetic testing, especially if they're using a gestational carrier and planning on doing a single embryo transfer in order to minimize the risk of chromosomal abnormalities and miscarriage due to that. The insemination type, as I've mentioned, could be either conventional insemination when the sperm is completely normal, or we're using a sperm donor, or intracytoplasmic sperm injection, which is the only way we'll use when we're using a frozen egg banks. This slide shows, as we all remember from medical school, the development from the zygote to the hatching blastocyst, which is usually the stage when we will do the biopsy if we were to do PGTA. But we can, of course, transfer even the moruli, blastocysts, which are one stage earlier. So in the vast majority of cases, we'll use the embryo evaluation using the Gardner's criteria. We'll look for stage of development, the symmetry of the inner cell mass, which you can see there at 1 o'clock, and the amount of fragmentation that are seen. And we'll assess the trophectoderm in the periphery of that embryo, which is where we'll do the biopsy if the patient selected to proceed with the sampling of the blastocyst. Usually, we will take somewhere between 4 and 6 cells from one location. With looking at the ESHRE and the ASRM guidelines, there's about up to 2% risk of damage to the embryo, which will mean that the embryo may not survive the biopsy, the freezing, the thawing later on when we do a transfer. And we test for chromosomal abnormalities, and as we've just heard, also potentially for segmental aneuploidy, which is a big topic that we'll have to address. Mosaicism is another big topic. We now transfer low-level mosaics in most centers, but there's centers that shy away from that, and most centers at this point in time do not transfer high-level mosaic. And as we've heard, there's several commercial PGT labs, and each one of them has a different cutoff or different threshold for reporting low-level mosaics and high-level mosaics. Some IVF centers choose to be blinded to the report and just choose to have a euploid or aneuploid. And by making that decision, by default, we potentially are discarding embryos that could potentially be viable and vice versa. And this is just a quick short video that shows how the trophectoderm biopsy is done on a hatching blastocyst. You can see the holding pipette holding the blastocyst there on the left-hand side, where the biopsy pipette and the laser is performing that biopsy there. What we know from different PGT reference lab is that the egg donor population on the left-hand side there in green has still about 55 to 68% chance of euploidy, which means that about 35% still will be aneuploid. So that's where a patient may choose to do genetic testing, especially if they're using a gestational carrier or have had several miscarriages themselves. This is a slide that summarizes the pros and cons of using fresh cycle versus frozen embryos. On the left, in fresh, you usually get more eggs and therefore have more embryos and more attempts of doing transfers, slightly higher success rate when we look at the STAR database. Supernumerary embryo freezing for baby number 2. The frozen could be sometimes less expensive because you get less eggs and convenient in terms of the timeline, but limit the number of each donor egg. The indication of gestational carrier, which I'm switching gear now to the last group of patients that have a uterine factor, are stage 4 endometriosis, adenomyosis, severe Asherman syndrome, which we all faced and took care of. Those are challenging patients. Congenital absence of the uterus, Mayer-Rokitansky, Kuster-Hauser syndrome, irreparable anomaly of the uterus, whether it's fibroid, whether it's previous repetitive C-section, bad PID, and so forth. Surgical absence of the uterus prior hysterectomy. Some patients have a hysterectomy following C-section. Medical condition during that process that precludes them from having pregnancy, Mullerian anomalies, leiomyomas, and prior pelvic radiation if they were diagnosed with cancer. The indication here is summarized here. Of course, we use a third party very freely with the LGBT community, and the same-sex men will use both egg donation and GC. The characteristic of an optimal gestational carrier is outlined here. You can see that history of uncomplicated pregnancies, less than 5 vaginal deliveries or 3 C-sections, age less than 40 is ideal, but we will be making some exception when it's a family member who's carrying. Maternal age is associated with multiple obstetric complications, as we know, both preeclampsia, diabetes, prematurity, abnormal placentation. So that is something that we review very carefully with both the gestational carrier, the intended parents, and the patient himself if they're using just a donor egg and using their own uterus and they're over 40 years of age. We'll choose a gestational carrier who's a non-smoker in excellent health with BMI less than 30 with a negative drug screen, given the impact of drugs on obviously the pregnancy and the risk that involved with that. Stable lifestyle and intact support system, making sure that they're taking the medication on time, the prenatal vitamins, estrogen, progesterone if we have to supplement them, and no significant history of mental illness. And we'll essentially assess them with a psychology testing online usually and in-person visit, and then do a GC day when we assess the uterine cavity with a saline sonogram, a hysterosalpingogram at time, and potentially a mock embryo transfer. The difference between an experienced or first-time gestational carrier, most patients will be first-time gestational carrier or only time first gestational carrier, given that they may not want to do it 2 or 3 times. So the first time widens the selection. Usually those are going to be younger gestational carrier, and usually they'll have lower compensation. The experienced ones usually will have a track record. They'll have vaginal deliveries of their own. They understand the process, and they usually get higher compensation, but they're usually also typically older and less likely to do a sibling journey. The medical testing and the review of those gestational carrier includes a complete physical examination to assess the health of the GC, comprehensive record review of the prior pregnancies, if they had vaginal or C-section and gestational age and any complication during those pregnancies, vaginal ultrasound that will assess the uterine wall and the lining, rule out leiomyomas, rule out polyps, rule out other issues that could impede implantation, and then do the regular infectious disease screening, which will reduce the risk of transmissible infection to the embryo that we're transferring. And again, as I mentioned, psychological assessment, and then they'll have a legal representation. The medication will include usually estrogen and progesterone to prepare for the endometrial lining to get to that trilaminar phase that you can see in the top picture there, and we'll use different medication, including estrogen pills, estrogen patches, estrogen that can be given vaginally or via a sub-Q IM injection. And then once we reach the nice endometrial lining that's usually will be greater than 6 to 8 millimeter, we'll start the progesterone, and usually 5 days prior to the transfer if we're transferring a single day 5 embryo transfer. During the transfer that you can see here in the video, there's going to be a transabdominal ultrasound. Some centers do transvaginal ultrasound nowadays, but you can see the soft catheter that is being introduced into the external os, into the internal os, and then into the mid portion of the uterus, and then usually about 1.5 to 2 centimeters from the fundus is when the embryo is going to be dislodged and then 10 to 12 days later, we'll do a pregnancy test. The embryo transfer itself can be either day 3, day 5, day 6, day 7, depending on the embryo phase, especially if it was biopsied for PGTA, it could be day 5, 6, or 7. We'll transfer one embryo in most cases, especially if PGT was implemented. At times, we'll transfer 2, especially if there's a uterine factor or prior failed implantations, or if it's a day 3 embryo, but not more. And we will definitely encourage most patients to use single embryo. And in gestational carrier, the vast majority will be with a single embryo transfer. There are a couple of cases here. This is a patient who had cervical cancer and had a hysterectomy and froze eggs, and later on used a gestational carrier to carry a pregnancy 2 years thereafter. And this is a same-sex man in the top picture there who used the donor egg and the gestational carrier there in the middle, and did dual insemination and transferred a single embryo. At the bottom, a patient, a sister who's going to be carrying for her, given the first baby got complicated with C hysterectomy, given that she had multiple fibroids and delivered prematurely. And the last case here is a patient that both the husband has severe male factor, was a quadriplegic, and the wife herself has stage 4 endometriosis and severe adenomyosis and had multiple surgeries, and eventually used a gestational carrier who was now 22 weeks pregnant. Thank you so much.
Dear Professor, I would like to say that I expected this presentation, but I thought it would be a little bit different. I know that you, as a specialist in reproductive medicine, has a lot of experience. Dear colleagues, Professor Singer from New York made this presentation. Fertility and endometriosis, surgery, egg donation, and gestational carrier. Here's the medical director of the largest school in New York. May I ask you a quick question and a quick answer from you? Maybe it was not in your presentation. Well, could you tell me, please? Well, if we're talking about endometriosis, why originally, well, the problem with oocytes is very bad. Well, I know I've been at the center, the Kolokov Center of Obstetrics and Gynecology for a long time. It's the main center in Russia. I'm the chief gynecologist, and our director, academician Suhik, is the star in medicine in this field, in the field of genetics, immunology, etc. What is your view about a person who deals with issues of infertility in a big school? Well, just do not tell us about all the problems of endometriosis. I've been dealing with this for 50 years. But what is the problem? What is the main problem with these women with endometriosis? Well, eggs, degenerative forms. I'm not talking about major problems with reproductive health when there are retrocervical anatomical changes, but why in general some women with endometriosis get pregnant normally without any problems, even if there is a severe stage of endometriosis, but others, there might be a minor foci of endometriosis and a woman can never get pregnant. What's the reason? What is your view as an American scientist on this problem? Just a short answer.
Obviously, this is a very, very important topic that we all are dealing with. When we talk about endometriosis, we know that there's a significant delay in the diagnosis of endometriosis, and most women will go through several OBGYNs before they're being diagnosed. So usually by the time they met the reproductive endocrinologist and had a diagnosis, they usually already have either a significant tubal factor, diminished ovarian reserve, or even adenomyosis and a uterine factor, and they're of advanced maternal age. So a lot of them will need treatment. A lot of the endometriosis patients, as we know, get pregnant on their own and find out with a second baby or third baby that all along they had endometriosis. Endometriosis, as we know, is an inflammation of the pelvis, and it can affect all the pelvic organs. So by having a patient with bilateral endometriomas with distorted anatomy, we can clearly understand why they have challenges in getting pregnant. But again, the delay in diagnosing them and not being diagnosed in the early 20s puts them already in the brackets of advanced maternal age, diminished ovarian reserve. They usually seek treatment when they're in the mid-30s, which in case for most patients, it's already too late. And that's why they seek more third-party reproduction, because they're getting into their late 30s and early 40s with a very low ovarian reserve and significant tubal factor. And that's where third-party comes in to help them.
Товер, я
Right. Yeah, yes. If there are equal conditions, right? Let's say genetic factors, immunology may be not just the late presentation. If a woman doesn't have severe damage, that's a different case. But in general, endometriosis is a disease of what? Immunity, genetics, embryology. You've been dealing with this for a long time. So what is your impression?
I think it's a combination of all of the above. It's a multifactorial for sure. There's definitely an immunological aspect that have been looked at, both at the level of the endometrium in terms of implantation, but also in terms of, as you said, anatomical distortion and having the embryo get stuck in the fallopian. We know they're much more prone to having ectopic pregnancy, having miscarriages, and so forth. It's a very big question to answer in a short
Я
answer,
знаю.
but we still
Я
have good.
знаю, потому и спрашиваю.
I know that. That's why I'm asking you. My second question, premature ovarian failure. Premature ovarian insufficiency. Why some women, if we exclude genetics, if we exclude thyroiditis, if we exclude immunological diseases, why this happens in young women, premature ovarian insufficiency. The ovary becomes almost sclerotic. Why does this happen in young women? We start a surgery, and the surgery basically damages the hyper way. Do you have any opinion? We know Calambura, Pelicera, yes, Hugh, but what is your view on this problem of premature ovarian insufficiency? Why does it occur? And what do you do in this case? Scratching, endometrial scratching, PRP, stem cells, surgery? What kind of surgery? Please, what is your view? Where are we going?
Okay, so obviously premature ovarian insufficiency is a big issue, and usually once you exclude the genetic component and you exclude obvious reasons such as radiation or chemotherapy, you're essentially left
Это
with the
исключаем, это
unexplained
исключаем.
etiology. I don't see a role of surgery in those cases. There's some centers that are now trying PRPs with some limited success. I personally don't use on a regular basis PRP. And usually those patients will have some success with just attempt if they're still ovulating. We're quote about 3 to 5%. So that will be the first conservative approach. But once they have reached that 1 or 2 years mark of attempting, that usually when we'll introduce third-party reproduction. But I don't see a big role in both PRP or surgeries in patients who have FSH in the hundreds who have premature ovarian insufficiency.
То есть
So you cannot activate those ovaries, right? At this point.
можем активировать.
Correct.
Хорошо.
Good. And one more question. Well, in reproductive medicine, in the United States, in New York City, well, how often do you use artificial intelligence in reproductive medicine? I know there is a time-lapse camera. Well, we look at genetics, but in general, well, how often do you use artificial intelligence? But don't tell us about simple things. Tell us about sophisticated things. What do you use in terms of artificial intelligence? Yes, a plane is flying autopilot. Well, there may be driver-free cars, but in reproductive medicine, where can we use artificial intelligence, like in New York City?
So the two main areas where artificial intelligence can help us is really in the prediction of outcomes and the selection of embryos. So a patient that comes in and basically presents with a certain AMH, FSH, enteral follicle count, or pelvic ultrasound, we can incorporate that along with the age and have some kind of a prediction model of what the best protocol to use in either ovulation induction or in an IVF. The second aspect is really where a lot of the companies and the biotech companies are putting their effort in the selection of the embryos with doing essentially omitting PGTA or more of a eliminating the need for PGTA. And that's really where the time lapses you had mentioned, trying to replace the experience of your experienced embryologist that you worked for 20 years. We're not there yet, but I can tell you that it gets the junior embryologist to a level of a very senior embryologist when they have that co-pilot, using the analogy that you gave from the airline industry. And I think that whenever I do a transfer, and I have several transfers today, I would like to have an AI system that will tell me, hey, Dr. Singer, even though those two embryos look the same, this one has a better track record than the time lapse, or with this specific feature, maybe we should freeze the embryos and bring the patient next month because her progesterone is elevated or the lining is not ready. So that's where AI will really change reproductive medicine. I think that the future is very bright when it comes to that, but we also have to be the gatekeepers and not let computers replace us altogether.
No, computers cannot replace people. Well, people think, well, a computer, well, it depends on how you teach it. Well, thank you very much. And thank you for your questions. Maybe they were not quite convenient, but it was a pleasure talking to you. Thank you very much, and all the best. Dear colleagues, now I would like to give the floor to a genius, a member of NRH, a person whom I met 40 years ago at Yale University. Well, that's Frederick Neftalin. Thank you for staying with us. And the theme of this presentation, it's a new topic, non-invasive pacemaker for electrical regulation of myometrial activity. We know that myometrial activity could mean premature births, pregnancy loss when the uterus has poor mechanics, so to say, but Professor Neftalin says it can happen during pregnancy or outside pregnancy. He's a professor at the medical department of New York University, New York City, the US. Please, Dr. Neftalin, the floor is yours.
Good morning. Thank you so much for inviting me to participate in this comprehensive and excellent meeting. I want to talk with you this morning about the future. That is the possibility of inhibiting myometrial activity during gynecologic conditions such as dysmenorrhea and adenomyosis, et cetera, et cetera. Uterine pain is a common electromechanical problem, which causes painful uterine contractions and is often treated with aspirin or other stronger anodynes. But this is temporary and generally not very successful against severe uterine pain. Attempts at hormonal blocking of the cycle in order to avoid things like dysmenorrhea has been problematic because of the endocrine aspects. There have been attempts to use pharmacology against this, such as calcium channel blockers, and nifedipine is one, but it's really difficult to get.
Sorry, we have no sound from you.
Я слышу.
We have a technical problem. Sorry about that. We'll get in touch very soon.
Today I'm going to talk about the future, which is the possibility of using electrical inhibition of a myometrial activity for gynecologic conditions such as dysmenorrhea and other causes of uterine pain. Uterine pain is a very common problem with electromechanical difficulties in the uterine contractions being treated with aspirin or other anodynes. This is a temporary and not a very successful way to treat severe uterine pain. Hormonal blocking of the ovarian cycle has been problematic because of endocrine aspects, and there have been attempts at pharmacologic treatment against uterine contractions, such as the calcium channel blocker, nifedipine, but the pharmacodynamics do not allow therapeutic levels for uterine pain to occur without accompanying dangerous cardiovascular effects. So it's necessary to develop a means of directly inhibiting uterine contractions to treat uterine pain. And we propose to test the possibility that electrical inhibition of uterine contractions can be used for this purpose. In order to, now let's see, why is it not going forward? So in order to understand our proposed approach, one has to understand the uterus itself. And here you see on your right some cartoons and some data, and on the left is some text that I thought might be useful for those who are not English speakers. The uterus is a dome, which is composed of involuntary smooth muscle that is aligned by the glandular endometrium. Everything in the uterus comes down to the area of the cardinal ligaments, which invest the uterine tissue and there hold the uterus in place and allow the uterus to rotate around it. So the cardinal ligaments are holding everything. The globe of the dome of the uterus is attached to the cardinal ligaments. It's kind of like a parachute with some strings coming through. And as that dome is shrunken down, one can expel its contents. Embryologically and functionally, the uterus, it really has two parts: the cervix, which is separately developed and has separate innervation of the uterus, and the dome or the corpus. And both the cervix and the corpus are populated by neural structures, particularly the Pacinian corpuscles, which are sensitive to pressure. So if the uterine contractions are not well synchronized, or if they are in some wrong direction or overly stimulated, one gets crushing of the Pacinian corpuscles. And you can see on your right some pictures of Pacinian corpuscles and some data from Tingaker about the presence of these in the uterus. One gets crushing of these corpuscles, which is the cause of the sensation of pain for the patient. The uterine muscle itself is an electromechanical tissue that's controlled by levels of intracellular levels of calcium, and the calcium generally enters through calcium or potassium channels and is regulated also by the endoplasmic reticulum, sarcoplasmic reticulum of the cells. And the issue is to maintain a proper level of calcium in order to get electrical activity on the cell, the myometrial cell. And so each time you have a contraction, you spend calcium, and therefore it has to be replenished or repleted. The intracellular pathways are regulated by many different signals, but as you know very well, prostaglandins and oxytocin, relaxin, etc., are the main ones that regulate the function of not only the calcium in the cell, but the intracellular pathways that regulate whether the tissue will contract normally or not. Production of an area of contractions in the uterus is dependent on intracellular tunnels called gap junctions, which allow cells from one endometrial cell to talk to the other, and thereby allows the setting up of what, let's call them, waves of contractions. And those are the productive contractions that you're used to in during labor, and as you know, during early labor, not infrequently, these contractions are not well synchronized. There may be problems with gap junctions, and then you have unusual pain rather than, and not productive, not very much effect on the cervix. So this is actually, in a way, the same thing that's happening with dysmenorrhea. Estrogen induces gap junctions, and progesterone blocks the formation of gap junctions. And so you have a duality there. That is the way that the wave of contractions is controlled. And during the normal cycle, one has similar issues about estrogen and progesterone in the luteal phase, and some sort of dyssynchrony may be at the basis of problems like dysmenorrhea. The result is that you get electromechanical activity that would normally occur during the normal cycle, but because the uterine muscles are smooth muscles, they have no direction. They're not like striated muscle. They don't pull only one direction. They have no Z lines, and therefore they can pull in many different directions and cause little areas of dyssynchrony, which, as I mentioned, would crush the Pacinian corpuscles and result in pain. So this pain is probably the result of dysfunctional electromechanical activity of the uterus. And therefore, it's possible to block it by stopping the uterine cycle. We talked about it as being something that works, but has many endocrine problems that attend interrupting the ovarian cycle, or one could attempt to affect the electromechanical activity of the myometrial cells themselves. We have been using electrical inhibition to interrupt uterine contractions during preterm labor. This is generally the theory of Jeffrey Carsden, and is widely published. And basically, we have been using this kind of a device, as you can see it in front of you. That is, that there is on your far left, there's a little box with that gives a duty cycle of 10 seconds with only about 2 seconds of individual small pulses of electricity that come through the red cable, go into a catheter, which is the purple catheter, and the catheter is inserted into the vagina. Here you see in the center a drawing of the vaginal anatomy, and you see where it goes into the posterior fornix. This catheter has electrodes on it. If you look closely, there are little stripes of white or blank stripes. Those are where the electrical activity is placed into the posterior fornix. And you can see how being next to the posterior fornix, being next to the cervix being next to the endometrium, next to the corpus, one might expect that activity to go up along the uterine corpus. I'm showing you on the right the present apparatus that we have, which is much smaller and actually could be carried on the patient's belt while the treatment of preterm labor is ongoing. Here you can see, looking at the electrical activity in the lower segment, which is around the area where the posterior fornix has given us access, and the electrical activity at the bottom in the top of the uterus or the corpus or the fundus, in this case, call it. And you can see that when we put in electrical pulses in the vagina, you get pulses with a little time offset in the top of the uterus. So the pulses that go into the posterior fornix actually reach the upper uterus. Here is a typical study of a patient who is being treated. We use a protocol that has a control to see that there are contractions, and you can see the contractions at the top is a tocodynamometer record, and in the center, the golden is the EMG record, and you can see the control period, the experimental period. So in this case, it was 20 minutes of control, 20 minutes of treatment, and 20 minutes of control. We want to be sure that when we stop the electrical activity or stop our treatment, the uterus is not harmed and it goes back to having contractions. And you can see in the center frame where we have blocked one contraction with the electrical activity coming from the posterior fornix, you can see that a contraction that would have been there, you have the beginning of electrical activity, but on the tocodynamometer, you can see that the contraction has been blocked. The other frames are just the electrical or the evaluation of electrical activity, and I don't think it's necessary to go through the details of that. If we look at, here are 11 patients at that point were studied, you can see that the peak to peak interval, which is the top line, is increased. So that means the contractions are spread out by the use of this of electrical inhibition, comparing control 1 period with the electrical inhibition period in the center, and then of course the follow-up control period. And you can see that the frequency of contractions falls, and the other is the electrical activity. But this is to show you that in preterm labor, this electrical inhibition is powerful enough to inhibit the uterine contractions, but does not harm the uterus. So up until this time, we have had no adverse effects. We have the patient says she feels something kind of like static electricity. Maybe when you put your car key next to the car and you get a little static electricity. The fetal heart rate is unchanged, and the APGARs of the patients of the newly born have been quite good. So in conclusion, again, in this case, using electrical inhibition, we have been able to show that a small electrical burst into the posterior fornix is conducted throughout the corpus and inhibits uterine contractions. we think that this same logic and the same approach can be used to inhibit uterine contractions during such times as the normal cycle or the cycle, and thereby inhibit uterine pain sensed as dysmenorrhea or the pain that is caused by adenomyosis and other causes of uterine pain in the non-pregnant uterus. Thank you very much for your attention.
Dear Professor Naftalin, thank you very much. I've been listening very attentively to your lecture. It seems to me that once upon a time in our life we used to have this. We had Dr. Hasin on our staff. He kept trying using electricity to stop both the excitation of the uterus or contractions. It's some kind of different electricity that is not harmful, or was it? What sort of electric current is it? Is there probably a case here of some kind of reasons for anxiety? When a woman is non-pregnant, it's okay. It's like something like physiotherapy, okay? Which seems to be decreasing these contractions, this peristalsis, because uterus is not like a tube or like a pipe. It's just an organ that also contracts. So it seems to be relieving these bioelectrical contractions of the uterus, right? But during pregnancy, probably that could be also done. But what about the uterus? Or what about the fetus, sorry? I suppose there's something standing behind him, especially given that we have 11 patients. I'm so happy that you shared your data with us. But probably one has to think hard before it. I don't suppose that for non-pregnant women it may do some bad, but for a pregnant woman, may I please ask you, just for 1 minute, please give us a minute of your time. Tell us, please, in greater detail, what sort of current? How does it come to the posterior fornix? And it doesn't seem to be fixed somewhere. Is it kind of vibration, or is it a touch, or whatever? What is the reason that transmits this wave that's supposed to sort of tackle the natural peristalsis of the uterus, which is impaired in case of a pathology, but in case of an attempt of the uterus to expel the baby, if you will, when we have early preterm birth, or in case of habitual pregnancy loss. It seems to me we had something in Russia. I'm sorry, it may be a very much strictly professional question, but some 20, 25 years ago, I seem to remember we did have this physiotherapy, which was widely accepted. Thank you. What sort of current would you like to explain? How does it influence? And why should we not be afraid of this? Thank you.
Thank you very much, Leila, for mentioning Kasem's work. It was published, and in fact, it was revolutionary at the time. However, there were no trials or other follow-up that was published, so we don't know whether it ever was applied in a larger number of patients. But in fact, there are 2 publications. I would call them like an abstract, and I think that was the first publication of the use of electrical inhibition to try to interrupt uterine contractions. The placement of the catheter is extremely simple. Any well-trained professional, and certainly obstetrician gynecologists or midwives, could just take the catheter, which is basically like a cardiac catheter. That it is a cardiac catheter, the one that we use, which is made to be put into an artery and run into the heart to be part of the cardiac pacemaker's apparatus. And so you take this small catheter, you put it between your fingers and slide it up into the posterior fornix. The posterior fornix has enough moisture in the posterior fornix so that there is the current that is passed up the catheter can jump across into the tissue. from the tissue, it goes into the uterus, just again because of proximity. And so, as I showed you, the current reaches the fundus, either the current itself or a wave of current that it starts. We don't know whether it's the actual pulse that's reaching. We think probably it starts a line of activity that can be measured at the corpus. So it is. So that's the physical part of it. It is only on for 2 seconds and then off, and then on for 2 seconds and then off and on for 2 seconds over a period of 10 seconds. That is our duty cycle. And during that time, the way that we understand this is that the wave of contraction that has been started in the corpus, which is starting from many places, they meet together. And if we put our current in before the normal wave of contraction reaches those cells, they cannot contract. We call that hyperpolarization. Probably our current has depleted the calcium from the cell that is now receiving that wave, so it stops there. In terms of safety for the uterus, this is really kind of mimicking normal uterine contractions. And so it should be quite safe for the uterus, and it is safe for the fetus as far as we can tell. We want to follow these fetuses for a longer time, but they are preterm fetuses, so it becomes complicated to actually say that we didn't hurt it or whatever, because these are preterm and they have their own problems. In terms of how to apply this to non-pregnant uterus, we intend to use a very similar protocol and very similar electrical protocol, and see whether that will work in a non-pregnant uterus. If not, we will change the height of the amount of electricity we're putting in, or we will change the duty cycle to have more or less little pulses during each duty cycle. I think that answers your question. I'm not sure.
Yes, very much so, dear Fred. What I want to say that you brought me back to 1995, where I defended my doctor's thesis in Russia. Doctors also have 2 theses after doing their medical degree. So the condition of benign tumor, reconstructive surgery, post-op rehabilitation. It seems to me this is a very exciting and interesting topic. If this is indeed feasible on a new level to stop these pathological pulses, this activation of the uterus, that would be fantastic. And in this way, we will save. We won't be using a lot of gestogens, we won't be using spasmolytics, we would minimize pharmacopoeia. This is fantastic. I will look up literature and I will get back to you. Whatever is related to you, Professor Neftalin, it's always simple and it's work of a man of genius. Please give my regards to Sylvie. Thank you. Very best.
Much for inviting me, and it's of course a pleasure just to see you and see that your meeting is going so well. Thanks again and good luck.
Thank you. Thank you. All the best. Thank you. Dear colleagues, right now we'll listen to a presentation by another superhero whose name is Andrea Vidali. New York City Medical Director of New York Clinic for Reproductive Health, largest clinic there. Clinical application of an artificial intelligence model in immunological testing in a patient population with reproductive failure and recurrent pregnancy loss. Andrea Vidali, in my life, appeared not so long ago, but so much I've heard people talk about him, that he's indeed a real superhero, a macho. He has good command on the questions of immunity, and he is well aware of the artificial intelligence. Dear Professor Vidali, our center is led by director of our center, academician Sukhir. His name is Gennady, first name Gennady Tikhonovich. Some 30 years ago, we did the first 4 PhD theses which we were supervised, which had to do both with innate immunity, team B cell immunities, experience of our center in myoma, in endometriosis, and they kept referring to our publication, to Sukhisto Anamian publication, Domovsky, Acosta, all those big names in the 1990s. OB-GYNs. I'm looking forward to your presentation. The floor goes to you, please. Dr. Vidali, the floor goes to you.
Good afternoon, good evening, Professor Adamian. I would like to thank you for the kind invitation. Of course, following Professor Naftalin is a very tough act to follow. Nevertheless, I will try my best. Let me just start sharing my screen. Just 1 second. Sorry about that. Here we go. And good morning.
И нас ждет, и нас.
And ahead of us, we have to look forward to Professor Monroe, who is online after you, his 2 keynote addresses. Can you imagine, after Professor Naftalin, before Monroe, look, Dr. Vidali, that is a challenge. Sorry for interrupting.
It really is. I see Dr. Professor Monroe over there. Today, my presentation focuses on a topic which I think very much fits today's title of the conference, which is about innovation. It is indeed a surgical conference, but as we know, there's also aspects that in what we do, which is also in endometriosis and infertility, that go outside of the realm of surgery, but affect also surgeons as well. And indeed, I am a surgeon, but I'm also a reproductive endocrinologist. I trained at Columbia University. And also I've dedicated the past decade to reproductive immunology, which is a field which is still, despite the fact that it has existed since pretty much forever, is still a matter of controversy, mostly because I feel there's just not enough science and research that goes into this field. Today, the purpose of my talk is to present some of the work. It's only a small part of the work that I've done in my center over the last few years. And this specifically deals with the creation of a model using artificial intelligence. I'll go more into the details in a minute. One of the issues that I think is probably very crucial today in IVF, I feel that we all agree that IVF has reached sort of a plateau in the sense that with the recent progress, we arrived at this sort of 50% pregnancy rate, a little bit greater than 50% pregnancy success rate. But we're kind of stuck, and most of the advances that are made are very slow. And what we're stuck with the minority of the patients are responsible for the majority of IVF failures. And currently, most of these patients are identified after multiple failures because, especially with PGT testing of embryos, the ongoing strategy has been to try again, sort of like a brute force type of approach. But there's tremendous frustration on part of the patients, mostly because the patients, especially now with PGT testing, sometimes it takes a couple of retrievals to create 1 or 2 normal embryos. And when a transfer fails, it becomes an absolute tragedy. The patients go back to the doctors and they're like, why? And the doctors are like, well, we don't know. And, protocols are changed, but it's interesting. Last couple of weeks ago, I was giving a very similar presentation to this at the Brigham. And I was in front of a lot of esteemed doctors and I watched them doing their IVF results. And a lot of the changes they were making to their protocols were purely cosmetic because the patient did not want to have the same protocols. They were like, the doctor was like, okay, she failed. Okay, let's do something different. Okay, different protocol. But it was really a change that was not based on data. A lot of it is cosmetic, really to appease the patient, even at top centers. So we know we are in an impasse. The question is it the egg or the chicken? I'm taking this title from a presentation recently on fertility and sterility. Is it the patient? Is it the egg or is it the patient? Is it an immunological factor? But there is no doubt, no matter what we say, that, can we be quiet, guys, please? I'm giving a presentation. Sorry. I apologize. I'm in the hospital, unfortunately. Guys, can you be quiet? I'm giving a presentation. Sorry. I apologize, guys. A patient with a history of 3 or more pregnancy losses, the data is very clear that there is a good chance of conception, but the problem is many of these patients with pregnancy losses of fair implantations don't have the 5-year times, which is the average time to live birth, the natural average time to live birth. Although the chances are good, the timeline is difficult for some of these patients with multiple pregnancy losses or implantation failures. And the other part of it is that, especially in IVF, although success is visible in patients who persist with IVF, many patients quit after the 3rd try. And 34% patients quit after the 1st try. And these are data from a large trial in the UK where there's actually very good access to fertility treatment. Pregnancy is indeed an immunological paradox. We're all aware of that. I'm not going to stop on that, but I mean, we always have to imagine that with a given differences, the fetus is considered a semi-allograft. This goes back to the basics of immunology and reproduction, and I'm not going to waste too much time going over this. But the reality is that analogies have been made between an organ transplantation and the semi-allograft, which is the fetus, with obviously some differences. The field of reproductive immunology is fraught with problems. And the reason why it's fraught with problems is because it is a holistic science. And what this means is that there's so many different elements in immunological testing, and you go from autoimmunity to endocrinology, histocompatibility, nutrition, inflammation, metabolism, genetic. How do you put all of these pieces together in a simple and actionable way? This is the really big question. And this is the question that we try to address with our research. We took 700 patients who were younger than the age of 45, only couples, with a median duration of follow-up of 29 weeks after follow-up, after dropout or success, and utilize the definition of recurrent implantation failed with either failed 3 transfers with good quality embryos or 2 transfers with PGT normal embryos, and recurrent pregnancy losses defined between 2 and 5 losses, and severe recurrent pregnancy losses more than 5 pregnancy losses. And when you look at the patient distribution, you could see that some of the patients in our study had up to 20 pregnancy losses. So really big numbers. And we created a predictive tool. You know, the issue with machine learning, which I think is really interesting, is that, which is, you know, a lot of people are talking about machine learning today. And I think that there's a lot of fears about it. But, you know, one of the things that as I've been working in artificial intelligence and machine learning over the last 3-4 years, is that the fact that you don't have an a priori assumption, that you don't need to have your hypothesis does not have to be as tight. And it really gives you the freedom, a lot more freedom in your research. And I think that there's a tremendous value in that. Initially, what we did, we started working with originally we started working with a logistic regression model. That's how we did our prediction, using our immunological testing in patients. And subsequently, as you know, we use the area under the curve as a predictor, to define the accuracy of our model. And then Then I started working with an AI company, which utilizes what's called a white box type of model. The problem with any sort of machine learning model is really the great tension between accuracy and intelligibility. What happens is that the models which are the most intelligible, the most easy to understand, are the ones which have the less amount of accuracy. Whereas the models that have the greatest accuracy are the hardest to understand. And this is a problem, especially for us working in medicine. Luckily, as I started doing research and trying to find different models, with my statisticians, we discovered Microsoft's EBM, which stands for explainable boosting machine. If you go to YouTube, you can find some great lectures by Dr. Caruana, who is the chief scientist for Microsoft in the area of artificial intelligence, which gives a very good explanation of explainable boosting machines. And what's really interesting about this explainable boosting machines is that it gives you it's still a boosted tree, it's still a boosted machine. So there's every single event is analyzed in a tree-like fashion, but the output is actually much more understandable in the sense that, like every attitude model, each feature adds to the other, create a final output, but the output is much easier to understand. How does, for people, sorry if I'm keeping it very simplistic, but how do these validation machine learning models work? The way it works is that you take your data set of, in our case, of 705 patients, and you divide your data set randomly. One part of your data set, usually it's about 90%, is used for your creation of the model. And then you create your model with that 90% of your patients. And then you leave the other 10% model for validation. And what happened is that you test your model on the 10% of the patients left. And some other models use nested models where the data set is divided randomly in small little pieces, and you can test and you create new little data sets and new models and then retest into different pieces. But the great thing about this is that the machine is naive to the percentage, to the 10% of patients that you're using for validation. And I think this is really important. In this case, the model that we created had a average precision of 0.81%, which is I would say when you're looking at many of these models, it's actually quite precise. I'm going to give you an example of what an output of the EBM looks like. In this case, it looks like you could see that we're testing the age. And remember, because it's a nested model and it's obviously corrected for every other single factor. And in this case, you could see that the pregnancy rate, the score for pregnancy goes down according to age, which is really what we expect normally. Now, this is an example of one EBM, explainable boosting machine model. These are the different all the features that are present in the model, right? And you have age, platelets. In this case, it's testing it's pulling out of all the different immunological testing, all the different parameters like live birth, miscarriage, regular T cells level, Th1, Th2 versus Th1, Th2, NK cytotoxic activity, HLA-B mismatches. It pulls the key elements in the model, and then you have an output. I'm sorry, but obviously this is a lecture on how using this modeling, so I'm not going to spend a lot of time talking about immunology. I'm talking about the technology, right? So how did I test this model? What I did, I went to the SART, the Society for Advanced Reproduction and Technology, the American Society. that to which every IVF center reports its results. And SART has a model which is based on the clinical factors of IVF. It's not based on immunology. And I tested my models, and I want you to focus your attention on the right graph. I tested my model, which is the light orange model versus the SART model, which is the orange model. And the area under the curve for SART was 0.66, and the area under the curve for our model was 0.74. One thing that you see when you're looking at the prediction of probability of success and you're comparing the two models, you can see that our model, when in the low prognostic value, was 100% correct. We predicted no success in most of the cases, whereas SART had a percentage correct, but also two in which they predicted no success were successive. The same thing at the other extreme, where you could see that our model predicted more success in the success area, in the 0.75 to the 0.75 to 1 high probability, whereas SART was much more conservative. It was not accurate enough at the extremes where you really want your model to function. Ultimately, we created a model which predicts outcome of success with a certain level, what I think is a acceptable level of accuracy in patients utilizing immunological testing. And I think this is very important. Why is this important? It's important because I don't think that in immunology, the big problem in immunology today, and in general in medicine, the doctors take a lot of parameters together and they make a gestalt type of decision. They look at the factors and they use their mind, they use their brain to make a decision. But whenever you're looking at 20, 30, 40 lab tests, it's impossible to make a gestalt decision. This is a problem. This is a big problem of why people say, oh, immunology testing is not good because doctors make this random decision. So I believe that this is the direction that we need to go into. Unfortunately, we don't have a lot of time today, so I can't present the extensiveness of our data. But what I can tell you is that I firmly believe that this is going to open a lot of learning and understanding on how we can use immunological testing for prediction of IVF outcomes. And I also have additional data where we can show that applying the findings utilizing this modeling has helped us make further decisions. Of course, I conclude my lecture with Dr. Sagans, Carl Sagans, who's like a big idol for me, because obviously the greatest thing about science is that you can always change your mind. And this is my last words for you. And I would like to thank Professor Adamian for the kind invitation and open for a question if you have any.
I've been waiting for your presentation, thinking that there will be like an algorithm, like first I will say this or that, but you said that all the figures should be loaded into the model. But what is a model? What do you mean by the model? Well, I am far from artificial intelligence myself, but I want to learn. Let's say we have 705 patients, we have more patients. What's the take-home message? Tomorrow, or say on Monday, I'll come back to my center and I say, well, Professor Vidali said that we must use all this data, all this figure, and load them into the model. So each model for every patient, or every model for every surgeon, or for what? Just in a nutshell, Vidal, what the model is for, so that we could have a better understanding of what the model is for whom this model is intended, for a patient, for a surgeon. What's the essence? What's behind this model, in fact? Just be more specific.
Sure. Whenever you, let's say you're doing what we do today, let's say that we're doing an analysis, right? And utilizing logistic regression. Logistic regression will give you put all your data, let's say that whatever parameters you check. Let's say I'm going to show you for a second right now. I'm just going to share my screen for just 1 second to show you just one simple slide. which is, sorry. This is an example of all the tests that if you did an immunological testing panel. You see that if you look, you guys see my slides? I think so, yes? Right.
Yes.
When you're looking at this panel, it's an immense panel, right? If you're a doctor and you're looking at this panel and you're looking, oh, this is positive, this is negative, this is high, this is low. There's no way that just looking with your eyes, you can say that one abnormality, let's say one elevation in antiphospholipid antibodies, to give an example, or KIR-AA, or any other elevation Th1, Th2 ratio, any of these different immunological patterns are elevated. You can't really make a decision because you got like 100 tests there. There's no way that a human being with their brain can do that. So what we use normally up to now, we use logistic regression, right? So we throw in all those parameters, we run a logistic regression, and we get a response, which is, in our analysis, we get a statistically significant result, which shows us that, I don't know, antiphospholipid antibodies is predictive of a miscarriage in this population of patients. This would be what a regression would give. And using that, and sometimes there are 3 or 4 things that are statistically significant, say we put those together, we get an output. What happens with a artificial intelligence model is that you throw in all the data inside the machine, okay? And the machine runs an algorithm, which is still based on logistic regression, because let's not forget that it's still a form of logistic regression. And it creates an analysis where basically the output is going to be the analysis of all those different parameters. And at some point I had a slide, and the machine tells you, based on my analysis, these are the factors that are statistically significant. And sometimes it could be individual ones or combinations of ones. And it throws out this output. There's 2 different forms of machine learning models. There's the white box or the black box. The black box is the one where you don't know how the machine arrived at that decision, okay? And that one is the one that's used, for example, for visual learning. Like you basically give a million pictures of a car to a machine, and after a while, the machine figures out and tells you, I think this is a car. And then you don't know how the machine arrives at that, but the machine tells you that. With this type of modeling, which is called white box, the machine tells you, I think this patient has a higher risk of having a miscarriage based on your data. But it shows you how. It tells you, I think because this parameter is high, this parameter is high, and this parameter is high, and this parameter is low. And this is what I call the output of the model. So this is how this is going, and this is, I think, the future. Sorry for the lengthy and verbose explanation, but I think it may be helpful for some of our listeners. Thank you for the very pointed question, Professor Adamian.
Дорогой профессор.
Dear Professor Vidali, I'd like to say that I am very happy that I asked you this question. In fact, it looks like, judging by your picture, we should have a lot of data collected. We just load this data concerning this patient, and the machine will tell us, well, this is the first patient, patient number 10, number 15, has a certain set of parameters that might lead to pregnancy loss. Patient number 40 has a specific situation, and we can make a diagnosis. Now I understand. Thank you very much when I can ask questions like that.
Perhaps with your incredible data that you have in your institution, we could do a collaboration and, maybe produce some amazing information and, new data with the kind of model that we have.
Dear Professor Vidali, I promise you, first of all, I do not exclude the situation that Professor Suchik is listening to your presentation right now because he's an immunologist, he's a geneticist. Well, fundamental sciences are very broadly used at the Kulakov Center, but if he did not listen to this presentation, I will introduce you to Dr. Kolokov, Dr. Suhik, and we'll discuss this possibility of cooperation. Thank you and good luck. Dear colleagues, now I'd like to give the floor to our next presenter. And we have a big audience right now. Right now, we have at least 3,000 people watching this streaming from 8 a.m. until 9 p.m. Professor Malcolm Monroe, he is a legend. He developed the classification, palm coin, classification, especially as far as hyperplasia is concerned. I do not want to waste your time, Professor Monroe, and he is a professor at the Department of Obstetrics and Gynecology, the School of Medicine of David Gerfen, California University, Los Angeles. There will be 2 presentations at my personal request and at the request of the audience. So today you'll make 2 presentations, one by one. The first presentation is the baseline presentation, and the second presentation is devoted to specific questions for discussion. Hyperplasia of endometrium. What is it today is the first presentation, and then endometrial pathology in questions and answers by Malcolm Monroe.
Sir Damian, for the opportunity to speak to your audience. It's very much appreciated. Let me share the screen and then check that indeed you can see. Let me know if not. What we're going to talk about today in this next 20 minutes or so is endometrial hyperplasia. I'm going to just show you the disclosures there for a moment. Really, when we're talking about endometrial hyperplasia, what we're really talking about is the risk or the concern of endometrial cancer. And endometrial cancer, of course, is increasing. These are the US data between 1999 and 2015. And by the way, as we go through, every time you see a QR code, that will take you to that paper or website so that you don't have to be taking pictures, etc. So at any rate, we have this increase. And of course, this increase is in many ways related to the increased prevalence of obesity. These are US data, but they're pretty reflective of what's going on in much of the developed and developing world. When we ask what does obesity have to do with this, it really comes down to unopposed estrogen. So the obese individual aromatizes more androgens peripherally to estrogens, and indeed, in relation to that, they have a high prevalence of anovulation. So if we look at what does that really mean, and this is from the University of Edinburgh crew, where we have an endometrial cell here. Normally what happens is we have a promoter, which is estradiol, and a suppressor, which is progesterone. But absent progesterone, eventually being bombarded with this estrogen day in, day out, month in, month out, year in, year out, one gets a mutant clone. And of course, then that clone then can reproduce, and we have a clonal development of these genetically abnormal cells that are really destined to become malignancy. And indeed, after some time, of course, that varies, we have a cancer, but it all starts with unopposed estrogen exposure. And then, of course, there are genetic predispositions and other factors, but think of it as unopposed estrogen in most instances. And of course, that simplicity in some way provides us with an opportunity to intervene by simply preventing endometrial hyperplasia by ensuring that there is progestin exposure on a regular basis, we can largely suppress this process. Or when this process occurs and prior to mutation, we can treat endometrial hyperplasia medically. And then even then, there are potentially some opportunities to treat before this malignancy becomes an issue that the patient has to deal with in different ways. So this is really a basic introduction to what we're going to go over in the next few minutes. So the first is really to talk about what are these disorders? And I say disorders, not a single disorder. And so if we look at endometrial hyperplasia from a simple perspective, it's really a disordered proliferation of endometrial glands. And it has some gross appearances, as you can see here in this hysteroscopic view. And it's really thickened and often an irregularly thickened endometrium. But that perhaps oversimplifies the process. And direct visualization is not particularly useful in making a diagnosis. And so it's the histologic change, which is largely what is responsible for us understanding these differences in endometrial hyperplasia, and of course, how it evolves to an endometrial malignancy. And traditionally, we have these architectural changes and cytological changes that we'll talk about. But what we do understand is that cytological atypia is the hallmark of a current neoplastic process, be it invasive or intraepithelial. In other words, is it a cancer now, or will it become a cancer? And of course, what is cytological atypia but the pathologist's subjective assessment of what's going on genetically? And so that leaves us with a circumstance that you should know. Pathology is not a pure science. There's a lot of subjectivity, a lot of artistry to it. So let's look at these systems that have been used, and sometimes it's confusing. And if we start out, the system that was first developed was the WHO system, which really derived largely from Scully et al. At Harvard, and really looking at two things. One is the architecture, simple or complex, and secondly, the atypia, with or without atypia. And so this is how certainly I was brought up, but it was found that there are some issues. And so in about 2000, George Mutter, also from Harvard, really simplified this into two, those with and without atypia. And called it the EIN, or the endometrial intraepithelial neoplasia system. And then subsequently in 2014, there's a bit of a merger of these two concepts and the WHO. Hyperplasia without atypia, atypical hyperplasia. These look the same, they're not quite the same, and we'll show you why. And subsequently, there have been some revisions, but these are fundamentally what is being used. And of course, what we're trying to do is determine who is at risk for developing endometrial cancer. And those that fit into this green group are generally currently at low or virtually no risk. And those, of course, in the pink have had this genetic change, this genetic mutation, and they may actually have endometrial cancer. Certainly, they're at great risk for developing it. So that's really where we are. Now, let's go back and just try to understand what was going on with WHO 1994. And if we look here, this is the percentage chance of having a cancer compared to what a group of pathologists who are experts determined. So this is a typical endometrial hyperplasia. And about 40% of the time, when the uterus was taken out, these women actually had a cancer. And using this system. And then even with less than that, even without atypia, there were individuals who had cancer with this system. So this made it pretty obvious that something had to change. And so this is the beginning of the EIN system. And you can see it's pretty simple. Endometrial hyperplasia, it's an estrogen effect, as we talked about, treatable with hormonal therapy. And endometrial intraepithelial neoplasia, a precancer, okay, that might respond to hormonal therapy, but certainly would respond to excisional therapy, and then adenocarcinoma. So basically, these three criteria, and this is how they compare to the WHO system at the time in 1994. Now, this is not exactly correct, and we'll try to explain that to you because, as you remember, there were some individuals who actually, with EIN, actually were called non-atypical hyperplasia, but actually using the EIN criteria, actually had EIN. So this line isn't exactly drawn properly in this paper. So let's try to understand what we're talking about. And I think one of the issues that we, and certainly I, when I was younger, thought is that endometrial hyperplasia is a field change. In other words, if you take a sample of that endometrium, it will be representative of the whole endometrium. And with simple hyperplasia, that might be true. But we talked about, remember the clonal change, that mutant cell. And so what happens is you get a clone. And so if we look at this particular picture, we have this sort of standard simple type hyperplasia with these dilated glands, and they're nicely separated from each other, okay? And you examine them, and there's a monolayer. So this is simple hyperplasia. But let's look over here. This is the same patient, but right here is this clonal proliferation of these back-to-back, nearly back-to-back, with proliferation, stratification, pseudostratification of these endometrial cells that is a hallmark of EIN. So you can see that there's a variable amount of these clonal cells. And of course, what this then tells you is that random sampling may not pick this up. It also tells you that if you're a pathologist, you've got to look incredibly carefully at everything, because up in one little corner of your slide, you might have EIN, and you get focused on this particular issue at all. So this is an example of both of these being present in one individual. So what happens, and if we look at this study comparing EIN with WHO 1994, and this is the probability of remaining without progression. So how many of these are stable? So using the EIN system, if there's no EIN, then it's very likely that there'll be new EIN if you follow them up for a long time. But if it does have EIN, then it will likely progress, or not likely, it has about a 60% chance of progressing, or 40% chance rather, of progressing to a cancer. Whereas you can see that even without atypia, with the WHO system, there's some progression, and it's not. And even using their definitions of atypia, you had even a lesser chance of progressing. So this shows you how this EIN system is perhaps superior. And then I mentioned to you that WHO in 2014 with Dr. Mutter and others basically came up with these two criteria, and they're not purely like the EIN system, because all of these have been put into this one bucket, hyperplasia without and with atypia. And you can see EIN is here, as are complex and simple with atypia. And so the difference here is that these really don't have mutations, so the chance of a cancer is very low. But with this group, there are a lot of mutations, PTEN, KRAS, et cetera, and they have about a 60% chance of having a coexistent malignancy. And if not, they have a risk of, in this case, 14 to 46 times chance of developing a cancer. So cytological evaluation is subjective, and expect that you're going to have some interpretative variation, sorry for the spelling mistake, until there are available validated genetic tests. So how do we diagnose? And this is the FIGO system. And of course, in the premenopausal years is what this applies to. Malignancy and hyperplasia are one of our criteria. And of course, the individuals at risk there are those that have the irregular onset of menses that heralds an ovulatory disorder. And so these individuals are at risk. And if we look at the other risks, so we have individuals postmenopausally on unopposed estrogen therapy, their risk is 2 to 10 times, depending on the duration and perhaps the dose of the estradiol, tamoxifen, slightly increased risk, obesity. Of course, this is the big one. And if you look here, for type 1 endometrial cancer, okay, this is type 1, it's 7 times increased risk for individuals who have a BMI of over 40. Now, type 2 malignancy is a little bit different. It's only 10% of the endometrial cancers or so, and it doesn't quite follow the rules that we've talked about with estrogen exposure, but nonetheless, there's still have a 3 times increased risk if they have a BMI of 40 or more. And of course, let's not forget Lynch syndrome, which is hereditary non-polyposis colorectal cancer. These individuals have a much higher lifetime risk, and it may well be back when they're much younger. So one has to be very careful about taking a history. So I don't have time to go through all of these, but these are the kind of individuals who you should be thinking about. And so when we look at more detailed assessment of who do you need to evaluate, anybody who is postmenopausal and has postmenopausal bleeding should be assessed. Now, the exception to that could be or is an individual who's on cyclical hormone replacement therapy. That would not be an example of such an individual. But if somebody's on hormone replacement therapy and they're breaking through, especially after only 6 months or the first 6 months or so, then it's worthwhile thinking about them. And typically, in most guidelines, they talk about abnormal bleeding age 45 to menopause, and fair enough. Abnormal uterine bleeding probably should fit, but individuals younger than 45, of course, can be at risk. So those individuals with the high BMIs, right? Individuals who or suspect have had long-term ovulatory dysfunction, and not to mention the Lynch syndrome, Cowden syndrome, and some others. And so this mentions the premenopausal patients. And then, of course, we also sometimes find that there's cervical cytology that shows atypical glandular cells, or any kind of glandular cells in women over the age of 40. You have to think about it, although I think it's probably best not to be evaluating these people over 40, more likely postmenopausally. And then, you may be monitoring people with endometrial pathology, et cetera. But this is the group who probably should be evaluated. So how do we do this? Well, I think that ultrasound is certainly in the United States seems to be undervalued, and measuring the EEC from EMJ to EMJ at 90-degree angle is a highly effective way. This is the typical postmenopausal individual not on hormone replacement therapy. If there's an ultrasound and you're comfortable with identifying the uterus, this is a very effective way of screening these individuals. So the question is how do you screen them? And this is from our guidelines that were published a number of years ago from the Kaiser system, and using EEC thickness. And of course, we have sensitivity and specificity. And if we use a 3 millimeter measure, then we have a very highly sensitive test, but it's not that specific. And then if you drop to 4, the sensitivity goes down a little bit, the specificity goes up a little bit, and if we go to 5, we continue on, et cetera. So the American College has settled on 4. I believe in other environments it's 3, and still others it's 5. But you have to make a decision in your environment about balancing sensitivity and specificity. So, of course, this begs the question of when you do this and you say, well, you don't have evidence of endometrial hyperplasia, you have a thin endometrial complex with a first episode of bleeding, what is the chance that those people have an endometrial cancer? Because some can, especially with type 2s. And so if we look at this study, these are people with recurrent bleeding. And so over a period of 250 weeks, which is roughly 5 years, in this study, about 10%, 10% had further bleeding. And of that group, 7. These are people with endometrial thickness less than 4, had a malignancy. So 10% of the patients had recurrent bleeding, and about 8.3% had endometrial cancer. So the number that actually had an endometrial cancer, it evolved over time, over that period of time, is about 8% of the total. Now, what about endometrial sampling? And this is from my friend Justin Clark from Birmingham in the United Kingdom. And this systematic review, to me, actually still applies, even though it's more than 20 years old. They had 10,000 studies. There was a failure rate to get a catheter in of about 7% and an inadequate specimen rate of about 15%. All right. And in those, there were 2 cancers. And then when the specimen was deemed to be adequate, the sensitivity was 99.6%. So depending on how you look at this, you can say, well, it's inadequate or it's highly adequate. And I think endometrial biopsy is probably highly adequate if you take all of this into account and manage them properly. Now, depending on where you are, I want to bring up this work that Hilary Critchley did and others in the University of Edinburgh a number of years ago, looking at things other than the PiPal, particularly the tau brush, which actually uses cytology as a medium, not H&E, not fixed tissue with formalin and H&E stains. And so what they did, and Alistair Williams, who's the pathologist, what they showed was that particularly in the postmenopausal individuals, the individuals with the PiPal was far or less likely to have an adequate specimen. And so, while it wasn't more sensitive, these women who failed to be sampled and had to get something else done, operating room, DNC, hysteroscopy, dropped significantly. So this has, to me, substantial cost implications. And then we talk about hysteroscopy, and the appearance of cancer is variable, as is hyperplasia. We can talk about all these appearances, but in the end, we have to have endometrial biopsy associated with hysteroscopy to actually make a diagnosis. And so if we look again at Justin's study, the overall sensitivity was 86.4%. Now think about this. Remember those clonal foci? Well, if you're actually trying to capture those by a directed biopsy, how accurate is that? And it may not be. Now, certainly hysteroscopy can identify polyps and focal lesions better than a blind biopsy, but I would submit that hysteroscopy is no better, and these data suggest that it isn't. So I question this move to move everything to hysteroscopy for sampling, and particularly in any country, but especially a low-resource nation, suggesting that that should be the standard, to me, is a step too far. So this is how we work this out. We gave 2 options. Some women come in hemodynamically unstable, and so they have to be stabilized. But if we start with ultrasound initiation, if the EEC is 4 millimeters or less and the bleeding resolves, we don't do anything. If the answer is yes, and it could be right in that session, we do an office endometrial biopsy, okay? And then we manage them according to the biopsy. If the bleeding doesn't resolve on the ultrasound, we do the biopsy, right? And if we can't get into the cavity or we don't have an adequate specimen, then those are the people that we go to for hysteroscopy in an office environment, removal of a target lesion if seen, okay? Now, one option is contrast hysterosonography or sonohysterography. And this is how I teach my guys, is that if the answer is no, they put the catheter in and then they do a sonohysterogram. And then if there's a focal endometrial lesion, they go to hysteroscopy, and if there's not, they have their biopsy. And then of course you can flip this around and start out with endometrial biopsy, right? And then if you can't assess it sonographically, which happens not infrequently, then those individuals would get sampling and hysteroscopy, etc. So there are a couple of ways to do this that integrate hysteroscopy, but don't use it as a primary assessment. Now, briefly for treatment, and I don't want to spend a lot of time on this, but obviously progestins are the key, and there are sort of two classes, the C19s and the C21s. I might add that a progestin is not a progestin is not a progestin. They're different. And it doesn't take much to get these guys into an estrogen, and about up to 1% of norethindrone acetate gets converted to ethinyl estradiol, something to remember. But these can be administered in many different ways, continuously, cyclically, systemically, or locally, right? And so this is from the SOGC guidelines, the Canadian guidelines, and you can see with MPA, various doses, et cetera, megestrol acetate, generally relatively high doses, cyclically or acyclically, norethindrone acetate, progesterone itself, and LNGIUS, which we're learning is probably the most predictable. Something relatively recent is the use of Dynogest versus norethindrone acetate. This is a small RCT published out of Egypt this year, and suggested that Dynogest given cyclically might be superior to norethindrone acetate given cyclically in terms of the certainly the regression of the findings. But certainly the LNGIUS is the 52. We don't know about the others, the 52 milligram, which is 20 micrograms a day. And you can see in this Cochrane review, it was favored over the oral progestins. This is the LNGIUS is the progestin in this meta-analysis. Now, you can get some guidance. You can go to the Royal College. I don't agree with everything that they've said here, but it can provide you with some guidance so that the individual who has no atypia, so they have benign changes, address their risk factors, lose weight, look at other factors, but losing weight is a big one, and they might be observable just with simple hyperplasia. And then, or LNGIUS or the oral progestins that we talked about. Now, if they have atypical, remember, they've got a good chance of having a cancer, and it could be missed. And so if their childbearing is complete, probably total hysterectomy is where they should go. But many of these people, the younger women, may want to preserve fertility. And so you're going to have to address these risk factors, but also probably use LNGIUS. And there are other approaches that we can't get into today that may be added to LNGIUS in some instances. And then you have to follow them up to look at resolution. I'm not concerned too much about benign hyperplasia, but with atypical, you want to look probably 3 months, and we use hysteroscopy to follow them. And then, as I said, there's a lot of circumstances downstream that get into details of management that we don't have time for. With respect to future directions, there's work on using aromatase inhibitors that have been demonstrated to be as effective in some studies as megestrol, GnRH modulators, and these are some data showing that there's a high initial complete remission, although there's some recurrence, not insignificant, but some of these individuals have been shown to have successful pregnancies. And some of these have been combined, as you can see here, with aromatase inhibitors or with the LNGIUS, as I mentioned to you before. Metformin, a lot of work being done on metformin because it actually has some anti-neoplastic properties. And so this is a study in the Cochrane Library that kind of looks like it's a negative. It says, well, it wasn't much better than megestrol acetate, but it almost was. So there are a number of studies now looking at combining metformin with other progestins. So there is what I wanted to go over with you to summarize. Endometrial hyperplasia is generally a preventable consequence of unopposed estrogen. EIN, AAH, when you get that diagnosis, endometrial cancer is frequently present or will evolve. You can use ultrasound to effectively evaluate the postmenopausal individual, not postmenopausal individual who's not on hormone replacement therapy. And if the EEC is less than or equal to 4, that really minimizes the risk. It doesn't eliminate them, but it minimizes the risk. If you have the opportunity in your country and your jurisdiction, think of brush cytology-based testing. It may well reduce your false negatives. Hysteroscopically directed sampling has limitations, but it should be integrated into your approach. And of course, it's better for focal lesions, be they benign or malignant, but certainly benign ones like endometrial polyps. It looks like the LNGIUS is the most effective single approach for benign hyperplasia. And hysterectomy appears to be the best approach for those with EIN who have completed the childbearing. So thank you very much for this time. And I'm not sure if there's some questions at this point.
Dear Professor Monroe, thank you so much for the fantastic presentation. You once again showed us how clear you can give the gist of what it takes. Tell me, please, we prepared with you several questions based upon for discussion. Maybe would you like to take them right now, not to lose the thought and the time? Or do you think you put it all together?
However you want to do it.
Well, I suppose let's do it right now after this presentation, and then we'll finalize, okay? So the questions that you've got, that we sent to you, that I asked to you, so that it would be more convenient for you to listen, please, would you like to cover those questions, please? Hyperplasia in myoma, in hyperplasia in young ladies. Do you remember we gave you 2 presentations, if I will. One presentation was hyperplasia, what it is. And secondly, in Q&A, remember?
Sure that I sent you a bunch of questions, a list of questions and answers, but I'm happy to if you just pose the question. I may have missed something here in translation. But yeah, this is the list. Yeah. Do you want me to show this?
No way. No, please don't. Right now, if I may, I will orally ask you several questions, probably the questions that are most frequently asked by our audience. For you, it doesn't mean anything. Okay. So, dear Professor Monroe, well, very often we see combinations, both myoma and adenomyosis and hyperplasia, all in one in a young lady, young woman, and infertility. How do you manage such patients, this complex of these comorbidities? Does it not change your approach, or does it? Because their unilateral, this all has to do with hyperestrogenia, is both myoma and adenomyosis, if there is combination both of myoma and adenomyosis and hyperplasia in combined pathology. What's your take on this? How do you manage such patients?
Sure. So in the in the FIGO system, we would call, and these women are generally going to present, not always, but generally going to present with abnormal uterine bleeding. They may not, but given what you said about hyperplasia, they may well. So let's look at it. So from a FIGO perspective, if we've evaluated her with her abnormal bleeding and taken a structured history, we've determined that she's got irregular bleeding, so she likely has an ovulatory disorder. And we've imaged her with imaging that's generally well-resolved ultrasound, and we found evidence of leiomyomas and adenomyosis. So we call her AUB A, L, O. So we have 3 contributors or potential contributors to the bleeding. Now, if we look at let's start with the L part. If the L, if the leiomyoma is not submucous, then we don't believe that leiomyoma has anything to do with her abnormal bleeding. With respect to the A part, if that individual has only a single feature of adenomyosis, and based on Joel Naftalin's data from the UK, it's unlikely that it has anything to do with the bleeding. And so if it's a regular onset of bleeding, she likely has an ovulatory disorder, and that's likely the contributor to her hyperplasia. Now, we want to know if she has benign hyperplasia or EIN. And if it's benign hyperplasia, that's incredibly common, and it's very reversible. And so the first issue with her is to try to determine what her desires are next regarding fertility. And if she has infertility, then the likely next step, if she has benign, right, is ovulation induction. So, and however that's done, it can be with clomiphene citrate, aromatase inhibitors, et cetera. However appropriate it is, it might be that she would consider IVF embryo transfer if she was older, but we deal with that. Now, and we would also think that if she did not have a submucous myoma, including type 3s, so she didn't have a type 0, 1, 2, or 3 myoma, it's very unlikely that there's any impact on endometrial receptivity. We need work to prove all of that, but we would not consider that endometrial receptivity would be altered, and so we wouldn't look at treating the myoma. The same for the adenomyosis, although one could argue that to a degree. So what we would do is probably go straight to ovulation induction. Now, there are all kinds of exceptions to that, but that would be our general approach. If she didn't want to get pregnant at the present time, then we would also look at using progestin therapy, and in all likelihood would suggest an LNG-IUS, although something as simple as cyclical oral contraceptives or other progestin therapy would be an approach. So that's, I don't want to go into, you can go a long way with this particular story, but that's how we would initially look at it.
Professor Monroe, tell me please, at first sight is cancer of the breasts, breast cancer, that is the biggest killer. Second killer in women of a certain age is endometrial cancer. As of today, there is no such thing as screening for endometrial cancer, right? And if we could, you and I, if we could say, look, we should lower the numbers of prevalence in incidence of endometrial cancer and mortality, which is the second biggest killer after breast cancer. How would you see how could we organize screening? Because sometimes endometrial cancer is also in atrophic endometrium. I'm not speaking about cancer per se, but how we arrange the work in such a way so that preclinically, how could we improve diagnostics of endometrium? Any suggestions in this regard? How would you put it? Thank you.
Well, let me take it as let me answer I'll rephrase the question and then try to answer that, and let me know if that's what you're asking. So what steps could we take in our society, our medical organizations to reduce the risk of endometrial cancer? Of course, the first thing is to make individuals, clinicians, aware of these genetic predispositions like Lynch syndrome. But that aside, the key is to avoid unopposed estrogen and starting early in life. We already know that individuals with using birth control pills in a prolonged fashion, just in a population basis, have at least a 50% reduction in endometrial cancer, and there's probably much more reduction in the higher risk individuals. So by the identification of individuals who have AUBO early on, ensuring that they understand why, and having a policy of recommendation of the use of progestins would likely drop this risk substantially. Of course, we can talk about changing our nutrition, et cetera, and of course we want to do that, but the likelihood of that type of thing being effective is low. So I really think that it largely relates to exposure to progestins. Now, you mentioned breast cancer, and so the question is, or a question is, would that recommendation, that suggestion, increase our breast cancer risk? And I think the answer is we're not absolutely sure. It's probably, if it does, it's probably very low. And I would surmise that if it was cyclically administered, which is all you would need, or infrequently, and that even could be once every 3 months, there's some data on that, that you probably would not alter your breast cancer risk at all, and you would drop your endometrial cancer risk quite substantially. So, in simplistic terms, that's what I would look at.
Well, sorry, if a patient really has infertility, true infertility, and we speak about menorrhagia, young woman with infertility and menorrhagia, still, should we rather go to stop the bleeding? In which way? Or what you think comes first is to take samples, to do curettage, send it for histological review, long-term management with progestins. Will it save us from this situation or not, Professor Munder? What's your take on this? Or do you think in any way we should first try to understand that we should do histological evaluation? To which extent, I would rather put it this way, piping, pipel, and hysteroscopy, pipel, how reliable is this? Is it reliable? What is robustness of pipel in biopsy? Thank you.
Yeah, well, first of all, we don't use the word menorrhagia anymore because we don't know what it means. So if we use the word heavy menstrual bleeding, and heavy menstrual bleeding that has associated with normal frequency and regularity, those individuals are getting exposed to progesterone on a cyclical basis. They're ovulating. And so the chances of those individuals having endometrial neoplasia, there's no zero, but it's probably as close to zero as you can be. So if they have that symptom, then you have to evaluate them for the actual causes of heavy bleeding associated with ovulation. And that go back to palm coin. And so that's adenomyosis, leiomyomas, coagulopathies, which are present in perhaps as many as, depending on how you define them, 13 or more % of individuals, and primary endometrial disorders. And this is something that I, probably for the rest of my life, I'll try to get people to understand that for example, it may be that half of the women on this planet have a primary disorder of endometrial hemostasis. They have heavy menstrual bleeding, they're iron deficient, they produce babies that suffer from their iron deficiency. And so if we talk about the symptom of heavy menstrual bleeding associated with ovulation, we don't have to worry about them. And with malignancy, we have to worry about them about other issues. With respect to the sensitivity of blind sampling with Pipel, we just went through that. That's really what I showed you. And with respect to Pipel, specifically, about 15%, plus or minus, women, the clinician can't get the Pipel into the endometrium, into the cavity. And another percent of the time, maybe it's 7%, according to Hilary Kutcher's work, there's not a specimen. Why isn't there a specimen? Well, in many instances, the woman has hypotrophic endometrium. She's just had a little blast of GnRH, a little blast of estradiol at the age of 53, and so she's had a bleed. And so she's got an unsatisfactory histologic exam. So, but if you take those out and you get a satisfactory specimen, as we pointed out, the sensitivity for endometrial cancer and hyperplasia is probably closer to 99%. If you include those, the sensitivity is probably more like about 80%. But I don't think it's fair to say that 80% if indeed you do a quality assessment of your specimen. And that's where the brush takes away a lot of those difficulties with access and a lot of those difficulties with an inadequate specimen, because you're avulsing cells from the atrophic endometrial surface as you rotate it. Of course, this means you have to use thin prep or equivalent cytological preparations rather than tissue preparations for the analysis. So I think I hope you're okay with me making this point about bleeding and using the right terminology, because this is where people get very, very confused. I would recommend we just stop using this term menorrhagia, stop using this term oligomenorrhea, stop hypermenorrhea, stop all of these, because we've shown and we recommended with a large international consensus 16 years ago in the literature, multiple papers, that these terms are not very useful and they can be counterproductive.
Dear Professor Monroe, one more question with your permission. A woman ovulates or not ovulates. Is she ovulatory situation or anovulatory? How would you choose the therapy of the care for such young women, for those who have ovulation and for those who don't? Where is the difference in management in young women, in your perspective? Thank you.
Yeah. Well, first of all, ovulatory disorders are a spectrum. They're not an absolute. So it isn't that you're ovulating or not ovulating. There's a range. Most women have an anovulatory cycle once a year. Siobhan Harlow showed that. We published it in our revisions to the FIGO systems in 2018. And so some women ovulate infrequently. As many of you have found, don't tell a woman who's got irregular bleeding that she's anovulatory, because she may ovulate periodically. So I think when you try to address this issue, there's a lot of nuance to it. So she has an occasional late period, and she's concerned about that, and she's wondering what this means. You can have that explanation. It can be stress. It can be exercise. It can be unexplained, having an occasional late bleed. But for the individual who is chronically anovulatory, who you and especially or including in the obese individual, that's the individual who over time is going to be much more likely to develop endometrial hyperplasia. And so you say, well, what about time? And we don't really know the right answer to it, but they likely can develop it, a hyperplasia histologically, even in 6 months of anovulation. So I think that the first thing is what's their concern? How often is it? What's the background context of potentially of unopposed estrogen? What's her risk? What's her age? And what does she want to do right now? Is she trying to get pregnant? That's a key question, or not? Does she want to get pregnant in the near future, or is she uncertain? So one has to sort all those issues out. But fundamentally, if she's not trying to get pregnant currently, and we think she has chronic anovulation, then we want to expose her to progestins. And most of the time, people are going to pick either a cyclical progestin preparation. It could even be with oral contraceptives, or they're going to pick an intrauterine. And again, I'm talking about benign hyperplasia. They're going to pick an intrauterine contraception, and I don't think it matters which one of those that they have. There's some other circumstances we can talk to you about. What do you do with the young girl who's between the ages of 13 and 18, who's got these very irregular periods? How do we handle that? And again, it's probably exposure to progestins. It could be contraceptive steroids, etc. And there are a lot of nuances to how you handle that. But hopefully that answer can be useful.
Yes, and this would be the very last question. You give us brilliant answers. Very many people wanted to listen to what you say. You see, many of our physicians in outpatient clinics, in, frontline, who are facing patients with uterine bleeding. What are the conservative methods of therapy for this uterine? We don't like, in Russia, it's just a matter of use. We dislike the word this abnormal uterine bleeding, AUB. Is it tranexam? Is it contraceptives? Is it agonists? What is in your order of preference? Conservative therapy for anomalous uterine bleedings, AUBs. And that will be the end of our questions. Thank you.
Okay. Well, first of all, AUB is a symptom, not a diagnosis. So one has to, and back to FIGO system 1 and 2. So in order to do this in an ideal fashion, we believe that we should do the structured history so we can determine who may have an ovulatory disorder, who's likely ovulating, who's had heavy bleeding their whole life, and may have other features suggestive of a bleeding disorder, and who isn't. And then adding to that as appropriate imaging. So one has to go through this structured history, which is FIGO System 1, and then an evaluation that will include imaging, but may also in selective cases include an endocrine evaluation. So if somebody's got an ovulatory disorder, irregular bleeding from FIGO System 1, then we want to know their thyroid function. We want to know what's going on in their life, what kind of stress, what kind of exercise, etc. We want to know about features suggestive of PCO or hyperandrogenic circumstances or galactorrhea. We want in the ovulatory group, the group who have irregular bleeding, who have ovulatory disorder, there may be other factors either in their endocrine makeup or in their social, personal life that may contribute. And then, of course, particularly for the women who have ovulatory disorders, who are ovulatory, we want to look to see, is there a submucous myoma? She could have that at the age of 20. Does she have adenomyosis, particularly multiple features? She can have that as a teenager, as has been shown by Katerina Axel-Kustos from Rome. So we want to do this structured exam, and there's nothing, the exam is structured history and then an appropriate exam. And then you're going to break it out into that PALMCOEIN, and then you handle them as appropriate for each of those categories. You're going to find women with von Willebrand. And so you're going to need to have a hematologist involved. And some of the treatments are going to be similar, but she's going to have some issues if she gets operated upon. She's going to have issues that relate to her children and her family. They need to know. So each of these diagnoses is very specific. If she has a type 6 leiomyoma and she's got ovulatory bleeding and nothing else, then she's probably got AUBE. And you got to think as well, what's her iron stores? Not just by measuring hemoglobin, but by looking at TSAT and ferritin, because iron deficiency alone without anemia can cause all sorts of issues with respect to physical function, with respect to cognitive function, and with respect to what happens in pregnancy. So this structured approach, abnormal bleeding is not a diagnosis. Abnormal uterine bleeding is not a diagnosis. It's a symptom, just like headache is a symptom. Pruritus is a symptom, but these are not diagnoses. And so one has to go through the diagnosis. And then, there's lots of treatments, tranexamic acid for AUBE. Tranexamic acid may be effective for AUBL or LSM, and on and on and on. But you've got to have a diagnosis before you're treating.
Дорогой профессор Монро.
Dear Professor Monroe, I'm very grateful to you. Right now we have about 3,000 people watching this Congress online, and that's why they asked me to ask these questions. Well, everyone knows your classification, both classifications. You are behind this classification, and I'd like to boast myself. We do have good results as far as this issue is concerned. That's why we invited you. Thank you very much. Well, we stole 40 minutes of your time.
My pleasure.
Спасибо.
Okay, thanks so much.
Спасибо.
Dear colleagues, now the floor is given to, hold on just a minute. Who is going to speak next? Hold on. All right. Maria Yarmolinskaya, endometriosis-associated pain syndrome and adhesive process. Treatment and prevention. Maria, you know my approach to your presentations. Do not overrun your time because it's almost late evening here. Well, Maria Yarmolinskaya is president of St. Petersburg Society of Endometriosis, the professor at the Russian Academy of Sciences, who's been dealing with the issues of endometriosis and uterine myoma for a long time, as well as other pathologies related to endocrinology. I'm very grateful to you for what you've done, and you have a nice alliance with the Kulakov Center for Obstetrics and Gynecology. Please. Well, Leila, it's a great honor for me to speak at this Congress. This is already the 36th International Congress, and we have a very interesting program, and we have fantastic speakers. Well, as for the theme of my presentation, I would like to talk about adhesions associated with endometriosis. We know that in 60% of cases, well, genital endometriosis is associated with the formation of adhesions, pelvic adhesions. These mechanisms are also very important because adhesion formation in case of endometriosis can be a de novo process. We know about the local inflammatory response, about pain, about an increase in the volume of peritoneal fluid, about an increase in iron level, which is a pro-accident, and of course adhesions can occur after different surgical interventions. As a result of that, because of adhesions, well, organs will be shifted. They are not in a physiological position. That is why their function changes. There is a hemodynamic and there is a chronic pelvic pain in women, and sometimes it can lead to very unfavorable complications such as central sensitization syndrome. Pain is the main syndrome which has a negative impact on the quality of life of women with endometriosis. According to statistics, 9 in 10 women suffering from endometriosis have different manifestations of the pain syndrome. If we do not diagnose it timely, we cannot start pathogenetically justified therapy, and there will be a progression of disease. There should be a pathogenetic justification of treatment. For endometriosis and for drugs that we administer to treat this disease, and of course, this drug should have an impact on the reduction of the level of estradiol production by ovaries, but also there should be the estrogen stimulation, and also there should be the reduction of apoptosis, and in this case, the drug will increase apoptosis, it will have anti-proliferative activity, and it will be the drug that has an anti-angiogen action. All hormone-modulating drugs used to treat endometriosis correspond to these requirements, but as for prevention of adhesions, it is known that only one group of drugs is effective. These are gRNH agonists, and the duration of treatment is limited to a specific period of time. In 2020, Krina Zondervan, together with co-authors, published the following algorithm of endometriosis pathogenesis. Of course, endocrinic lesions play a very important role, but besides endocrinic factors, a lot of attention is paid by the immune factors. Leila Adamian often emphasizes that our guidelines of 2020, there is no immunomodulating therapy, but if the drug is justified in terms of pathogenetics, I would like to show the results of our trials to see how it can impact the immune system and prevent the adhesion formation. What about immunomodulators? Well, the immune system, in case of endometriosis, monitors the proliferation of cells, controls mechanisms of neoangiogenesis, and regulates the apoptotic processes. There are numerous interactions occurring between endometriosis and the immune system, but also there are other aspects involved. Well, the reduction of the cytotoxic activities of NK cells, and there is another nuance, of course, the theory of retrograde, blood flow, and most patients with patent fallopian tubes have this kind of flow with the more aggressive endometrial potential. Naturally, we must counter this trend, and the first protector are peritoneal macrophages. They want to deal with those unbeaten guests, but they are hyperactivated and they are functionally inconsistent. They start this cascade of pro-inflammatory cytokines, T helpers type 1, and unfortunately the level of anti-inflammatory cytokines, T helpers type 2, is higher than T helpers type 1, and in this case, pro-inflammatory reaction is not effective. This inflammatory focus persists all the time, and the organism tries to counter it, but not quite effectively. There is the inhibition of fibrinolysis, and there is the proliferation of fibroblasts in this case, and the final component is the formation of scars and adhesions. Well, I should note that in 2022, Fertility and Sterility proposed a new view on pathogenesis of endometriosis. Fibrosis is the final result of the chronic tissue damage and leads to the growth of the connective tissue generated by myofibroblasts. According to this conclusion, in fertility and sterility, fibrosis is considered as a molecular marker of endometriosis, regardless of the type of the proliferation of disease. In 2014, the European Society on Gynecological Endoscopy came up with recommendations on the use of anti-adhesive drugs to prevent adhesions associated with endometriosis. Here are the results of our first study published in 2015 regarding the assessment of efficacy of the drug that you are very well aware of, that has the anti-adhesion mode of action. This longidase drug regulates the synthesis of inflammation, and it can lead to the development of fibrotic tissue, but without damaging the connective tissue. In 2015, we published the results of this study, the efficacy of this drug in the treatment of patients with endometriosis. I should say that in 2015, the WHO gave this drug the international non-patent name, and 50 patients were included in the study. Well, the diagnosis was confirmed histologically. These were patients with stage 2 and 3 of prevalence, and according to AFS, the main criteria was the adhesion formation type 2 and 3. The first group got GnRH agonists, and the second group was on monotherapy with gonadotropin-releasing hormone agonists. This scheme is very interesting. We administer both hyaluronidase isoxamer in the form of suppositories, 3,000 international units, then one suppository once in 5 days. The duration of treatment, 3 months. We assessed the pain syndrome on the basis of VAS, visual analog scale, and of course it's difficult to assess non-interventional methods or non-invasive methods, the manifestation of the adhesion process. And here you can see the results of immunological tests. In the combined group, when both hyaluronidase azoxime or Longadase was used, well, the pain syndrome was reduced by 95% as compared to monotherapy by GRNH agonists, where the pain syndrome was also lowered, but only by 88%. And here you can see the results of our immunology trial. The level of interleukin-8, the pro-inflammatory cytokine, its level was much lower in the combination group, when we could see that the inflammatory reaction was less manifested. Such chemokines as MCP1 and RENTAS, responsible for the synthesis of fibrotic tissue, their level was 10 times less when women were on the combination therapy. And such chemokine as IP10, its level increased 10 times, and that means that this drug has an angiogenic effect. Long-term results were very interesting for us. As far as the reproductive function is concerned, again, our priority was combination therapy. When combination therapy was used, the pregnancy occurred in 41% of cases. In patients on monotherapy, it was 37%. These were patients with stage 2 and 3 of adhesion process. And the first conclusion we made on the basis of this study is that above hyaluronic nidase azoxime is accompanied with the reliable reduction of the pain syndrome, the spread of the adhesion process, and the results of our immunology trial showed that when Longadase was included, it led to the more effective treatment. A reduction of the inflammatory reaction leads to the inhibition of neoangiogenesis and has a protective effect on the fibrotic tissue and adhesions. According to our clinical guidelines of 2020 and ASHRAE of 2022, the first line of therapy is progestogens. That is why in 2021 we published the results of the study Ireland, a multi-center non-inferiority study. We compared the effectiveness of using Longadase as part of the comprehensive therapy with Dynagest 2 milligrams as compared to monotherapy with Dynagest, which is very important in real clinical practice. And I would like to focus on the fact that just using visual analog scale to assess pain is not enough. We used different types of assessments using different scales. Of course, the quality of life is another important aspect on the basis of standard questionnaire, SF36. I'm not going to cover all of the aspects, but the major goal is how quickly we can control pain during the first 30 days. We did the assessment not on the basis of VAS, but also Bergman scale and also the quality of life using SF36. Only women with intraoperatively confirmed endometriosis were included, as well as confirmed bifrozen section. And the first part was the same as in the first study. We used suppositories with Longadase once in 3 days, but then not once in 5 days, but once in 7 days for 17 times. Adenomyosis was the exclusion criteria, and we had 2 groups of patients. The first group was on combination therapy, Dynagest plus Longadase. The control group, Dynagest monotherapy. In the combination therapy group, when Longadase was together with Dynagest, well, pelvic pain was reduced according to VAS after 30 days. And it was more significant than in the control group on the basis of Berlow-Bergman scale. The pain syndrome was reduced in the group of monotherapy by Dynagest, but in the combination therapy, pain was reduced much more significantly. As we conducted the quality of life analysis, such as SF36, how much time do you need? Well, I think I need 1 more minute, Leila, and then I will wrap this up. All right, so the group on combination therapy had better results. So on the basis of our multi-center study, and we described it in our recent publication together with Leila Damian. It was published in the Problems of Reproduction journal. It shows the efficacy of treatment of endometriosis and the diffusion process. Thank you very much. Thank you, dear colleagues, not because I'm against something, but we've had a wonderful Congress. We've had wonderful 3 days. If you have specific data, so there is no need to mention them many times. Well, thank you very much. Try to just present the data precisely and just go straight to the point. Dear colleagues, the floor is given to Professor Asia Shahukoeva, Adhesions and Intrauterine Synechures. Professor Hashukoeva, you know the subject very well. Please be concise and straight to the point. Well, esteemed Professor Damian, allow me to express my gratitude to you for the possibility to speak at this 36th Congress. Well, thank you for the wonderful organization of this Congress. I'm not going to talk about the frequency rate of synechures. The only thing I'd like to mention is that the trauma of the basal layer of endometrium and the healing of the tissue takes place due to the adjacent endometrium on the adjacent side of the uterine wall. There are adhesions being formed, fibrotic tissue, and that leads to serious complications leading to intrauterine synechures. I should say that the diagnosis of synechures is a difficult process. How can we achieve a better effect so that we could avoid adhesion formations, and how to treat patients who have such adhesions when the reproductive function is very poor, when we have a fibrotic endometrium? Sorry, we have no slides. All right. I should say that the first problem, we have no slides. Asia, sorry, we have no slides on our screen. We just see you, but we don't see the presentation. I have it on my laptop, but we do not see it on our screen. Okay, continue. Anyway, you know what you're saying. All right, sorry about that. Well, I will just continue. However, there is one problem, polymicrobial microbiota in the cavity of uterine. The second serious problem is antibiotic resistance. Well, you should share the slides. Share your screen. I clicked on this menu. Share the screen with us. You have lots of flowers behind you. Flowers, that's good. Well, I click on share the screen. Well, all right, now we can see the slides. All right, now full screen. All right, continue. Well, antibiotic resistance is another problem, and it's a marker of chronic endometritis. I should also say that those patients who have antimicrobial resistance, and usually this means poor reproductive process. That means the formation of biofilms such as Gardnerella vaginalis, which is not properly treated in most cases. There are also studies showing that while lagging behind in prevention of intrauterine adhesions on the one hand, but on the other hand, we do not treat such conditions properly, especially when we're talking about patients with reproductive failures and intrauterine synechures. Then the question is, what should be done in this situation? Wait until synechures are formed, or we can prevent such synechias, or just wait till the fibrotic tissues disappear? Well, we use Longidase. It's a two-component drug to treat such women. It showed very good results in the treatment of patients with chronic endometritis and implantation failures. I should say that the algorithm of treatment, which suggests the introduction of this drug, Longidase, as you can see it here, is not always effective, especially when it's lyophilized, and maybe we cannot achieve the proper effect after the drug is taken 10 or 12 times. Well, but the long-term administration of this drug is more effective in such patients, such as patients with genital endometriosis, and we can see that long-term adjuvant therapy with Longidase leads to a more significant eradication of pathogens, restores endometrial receptivity, and improves the uterine blood flow. And right now, there are thousands of doctors watching this presentation, especially in inpatient hospitals, and I should tell them that we should start the treatment of such patients as early as possible. And also, in this case, we'll be able to restore the reproductive function as soon as possible after we treat these adhesions. Hysteroscopy is usually used in this case, and not in all cases we can restore endometrium, but adjuvant therapy is a must in this case when we add right after our manipulations, after minimally invasive procedures. Longidase should be administered right away. I should say that the effect of Longidase is multiple. First of all, we can reduce the pro-inflammatory process, we can prevent the excessive fibrillization, and also there can be the reverse development of the fibrotic tissue without damaging normal tissue. This improves the vascularization of endometrium, and this improves long-term results. As you can see it here, according to some authors, the morphological condition of endometrium is improved, and there is a decrease in the number of recurrences caused by synechias. We restore the endometrium, and there is a 6-time decrease in the formation of synechia after this kind of treatment. Here you can see the comparative effectiveness of the drug. It's quite high. Why does it happen? Once again, this is an anti-inflammatory effect, microcirculatory effect of the drug, and of course, this is also an anti-fibrotic effect that the drug has. Well, there are 2 stages of treatment. At stage 1, we use local therapy. At stage 2, together with antibiotics. At stage 2, we can use only Longidase vaginally, and of course, usually the duration of treatment is 3 months, so that we could achieve good results. Dear Leila, thank you very much once again. I wish you every success at this Congress and good health. I hope we will see more and more congresses like this. Thank you very much, Asiya. You've always been a wonderful presenter, and thank you again. Well, dear colleagues, the next speaker is Antonina Smetnik. Antonina, now this is the time for your presentation. Antonina Smetnik, head of the Department of Endocrinology at our center, the influence of sex hormones on the mammary glands and methods of their correction, how to achieve the best results. Well, please, the floor is yours. Well, Esteemed Leila Adamian, thank you for the invitation to participate in this Congress. Dear colleagues, I'd like to start by saying that the mammary gland is the target for many hormones and growth factors: estrogens, progesterones, androgens, prolactins, thyroxines, well, different growth factors, glucocorticoids, mineral corticoids, and even vitamin D. What is interesting to say that in the epithelium of the healthy mammary gland, estrogen receptor positive cells, usually proliferate slowly, unlike negative cells, which are mitotically active. And as a result of it, in the tumors of positive cells, mitosis are being regulated by their own endocrine mechanisms, and there may be a switch over from paracrine to endocrine mechanism. It's an important part of the tumor process. As for androgen receptors, they're present in 70 to 80% of breast cancer and are expressed more often than the estrogen and progesterone receptors, and in 1/3 cases, in case of triple negative cancer, whether it's good or bad depends on the population. There are also data that targeted approaches are being developed, such as SERM, selective androgen receptor modulators, as well as selective histogens, as well as glucocorticoids. They can stimulate the growth of the tumor due to the commonalities in the structure of their receptors. Of course, the mammary gland is a unique organ. It has all the necessary enzymes for its own synthesis and estrogen metabolism. In speaking of the role of menopausal sex hormone and the risk of breast cancer, the concentration of local estrogens in the tumors after menopause, it is 50 times as much as compared to plasma due to the local conversions of estrogens. There is no difference in the concentration of estradiol in blood in case of breast cancer or in the tumor in case of cancer in the reproductive age or post-menopausal age or after post-menopausal therapy. Thus, we can say that the tumor concentration of estradiol does not depend on its concentration in plasma. According to the results of the all-Russian questioning of doctors, the fear of onco-diseases due to menopausal therapy is one of the major fears of patients when we start this treatment. Also, more than 10% of doctors fear that there could be a higher risk of development of oncological diseases due to menopausal hormonal therapy. In fact, as for the position of the North American Society on Menopause says that the higher risk of breast cancer is not high due to menopausal therapy.
Or less than one additional case per 1,000 women per year of use. And this level is similar or lower than high risk that have to do with such factors as lower physical activity, alcohol use, obesity. Data is available that the risk may go down in the use of microgenized hormones, unlike synthetic gestogens, and the risk is going down after its cessation. As to the role of COCs, the results available of the Danish National Prospective Cohort Study that showed the relative risk of 1.2 in higher risk among women who have COCs for no less than 10 years, but highest risk elevation was not big. For 7,600 users, only one additional case of breast cancer was seen. Prolactin, as it activates receptors to steroid hormones, can sensibilize the tissues of the breast to endo and exoestrogens, which may provoke proliferation of epithelium 2-4 times more intensive than under the influence of progesterone alone. And under the higher progesterone, prolactin may increase proliferation up to 17 times and may provoke inefficient therapy of breast cancer and promote higher risk of recurrence. Double-blind RCT, drug placed upon the extracts of Vitex mustardinone statistically significantly decreased, and it could be compared to bromocriptine, then controlled. 17 100 women of reproductive age showed that over half have mastalgia. Mastalgia rate correlates immediately with age, larger size, lower physical activity. As well, reports were made that 41 and 35% spoke about negative influence of mastalgia on their sexual health and sleep, respectively. 10% spoke about tender breasts, in a problem in over half of their life. It's not clear whether oral contraceptives leave cyclical mastalgia or alleviate it, so the impact of COPs and menopausal hormone therapy on pain in breasts may depend upon their composition. Besides, they may influence women in a different way. As to mastalgia, today it is known that long cyclical mastalgia over 3 years may significantly increase the risks of breast cancer. As placebo-controlled trials showed, after 3 months of use of the drug based upon Vitex has shown Vitex agonist castus showed better well-being of the women. Mastodienone also relatively well arrests the symptoms and improves X-ray in immunotherapy and may influence several risk factors for breast cancer because lower density of the tissue, lower edema, lower mastalgia, higher rate of prolactin normalizes the correlation of 2-OHEY to 16-alpha-OHE1, and randomized clinical trials show high effect of mastodienone in lowering mastalgia alongside with COPs and MHT. But at that we realize that low adherence to the therapy remains key obstacle that prevent the patient from getting best benefits. And preliminary precondition for a patient to be compliant is to make sure that the patients would more likely take the therapy if they can recognize their disease. For example, lengthy mastalgia can significantly decrease the quality of life and elevate the risks of breast cancer. Whether the patient understands what is the rationale, if there is a need to interrupt hormonal therapy in case of symptoms by the breasts, or if you have to cope together with the herb or with a proven efficacy. Practical things also come into play. We must remember, we cannot forget about taking the drug several times, and then we can recommend this drug. Negative expectations about the effect of the drug may decrease the therapeutic efficacy and enhance side effects. And side effects that have to do with psychological factor, they're known as nocebo. For example, some patients have an attitude that hormones may provoke breast cancer, and this certainly makes them feel worse, may enhance mastodenia, and probable prolactin elevation may lead to discharge from breast. Clinicians may explain the desired therapeutical effects, have to make sure that the patients understand that side effects are transient, and for example, that the leaflet increases to a large number but means that the drug was well used on large samples of patients for many years. And this does not mean that some of them will necessarily be seen in you. Seeing how to fight side effects rather than stop taking the drugs. For example, Vitex agonist castus in pain and insignificant rise in density. You must give clear-cut written instructions to the patient, and you will tell us if you understand it all well. Otherwise, the patient may not be listening to you carefully and may worry that she may not remember good recommendations. Think about continuing to improve pharmacotherapy in no less than 3 months, but to make sure that you need to take it for at least 6 months. And the drug works for women both in reproductive as well as in peri and postmenopause. Well, supported with the results, please note that your bad symptoms have been removed, but also you have realized positive effects of hormonal therapy. In modern practice, it would be ideal to use motivational counseling to ensure better adherence. Ask open questions, focus on patients' preferences, their personal situations, rather than something that matters for the medical workers. You need not take the patient as an expert. It helps the physician to understand how to better to have better outcomes, give advice that would be more probably taken by the patient. So from this position, the drug mastodinone should be seen as a way to improve adherence to hormonal therapy, which helps achieve better outcomes in patients with gynecological profile. And distinguished colleagues, allow me please to invite you to attend our regular schools of endocrinological information. It's all information is available on the website. Thank you very much for your attention. Well, thank you, dear Antonina Alexandrovna. Very clear cut and very much to the point, very good, useful information. Thank you so much. Dear colleagues, the floor goes to Andreeva Elena Nikolaevna. She will discuss the role of gestogens as part of HRT and menopausal hormonal therapy. Case study. We must look at clinical cases, dear Elena Nikolaevna. I could not reach you at all. We know this huge amount of work that you did. You know that you should present it, but nevertheless, please report it to us. Be more laconic if you can. Thank you. Thank you very much, Leila Vladimirovna. Thank you for the opportunity to attend the 36th time of your congresses alongside with other brilliant speakers. I can imagine I would like to be as brief as I can to discuss the situation I've discussed today. And if possible, I can discuss gestogens when we speak about improving or rather maintaining the quality of life in senior women. How progesterone predefines woman life is woman of woman's calmness. And this is true not only in their productive age, but also in elder age groups. May I remind you that progesterone is endogenous steroid. It's a sexual hormone that influences not only menstrual cycle, pregnancy, and embryonal development. This was discussed at this congress, but plays key metabolic in-between link in production of other endogenous steroids. It has a number of physiological effects that are enhanced in presence of estrogens, and higher progesterone cuts down the activity of aldosterone that withholds sodium and leads to natriuresis and decreases the amount of intercellular fluid. On the other hand, higher progesterone means higher sodium, higher amount of fluid, and compensates the production of aldosterone that fights the blockade of mineralocorticoid receptor. This is the biological role of progesterone that we use as we prescribe gestogens in reproductive age. To ensure development of alveolar in breasts, decrease the tone of uterus in pregnancy, and most importantly, impact on hypothalamus. We must significantly rise the temperature of the body and dynamics of basal temperature. Progesterone is a neurosteroid. It is produced both of the tissues by our ovaries and nervous system too. It's a neuroactive steroid. It works immediately on the tissues of the nervous system. For that matter, nervous system is done both by glias, and progesterone is considered to be an antioxidant. It decreases oxidative stress, decreases the production of radicals, and stimulates the activity. We know there are a number of pool of gestogens that are divided in different groups. And this is data, and we realize that we can use any of them at any age maximum that suits the needs of any specific woman to ensure we can get the effect that both she and we as treating physicians want to. Menopause is impaired mood, impaired sleep, sexual dysfunction, problems about concentration, attention, and intensity of vasomotor symptoms depends upon ladies' personality. They may be active or they may be non-existent. At that, we may see psychological trauma, regular stresses, unfavorable social structures, poor self-esteem, poor self-respect, poor satisfaction with life. Women feel they didn't fulfill their meaning, they're not happy with their sexual life, and they may have other psychological disorders. You see that in mental sphere, especially in perimenopausal a woman comes up with a number, with a bunch of impairments in emotions such as memory, attention, higher fatigue, irritability, aggression. We may see anxiety, depression manifestations, emotional lability. This is sort of like premenstrual syndrome that works for quite a while. But at that, the women already were diagnosed with a depression given their low level. Potentially, the risk of negative impact of menopause. As you heard today, the previous speaker said that stress works against many problems, including gynecological practice. Please remember that cognitive decline is something that can be seen maybe a normal part of aging. Today, we're saying that in line with the evaluations of the UN, the number of senior citizens in the world by 2050 will rise to 21%, which will account for over 2 billion people. And then we have a problem not only about the climacteric syndrome, but global problem across the world about sarcopenia. This condition has to do with a progressive generalized loss of muscle tissue and strength with high risk, unfavorable events such as poor quality of life, disability, and it is a reason to speak about epidemiology of sarcopenia. As to the Russian population, it is seen up to 13% of patients older than 80. Etiological sarcopenia is divided into primary and secondary. Primary is seen in age-related change in muscle body, but in secondary, a number of pathological conditions. They're both cancer pathologies, endocrine disorders such as diabetes mellitus, such as chronic heart failure, as well as impact of iatrogenic effects. Sarcopenia today is a multi-etiological syndrome with difficult pathogenesis where endocrine factors are playing only leading roles. The situation, well, pathogenesis is not well studied, but it's clear that they matter the level of sexual symptoms, insulin resistance, and the growth of vitamin D. If we speak about this, the substantial role in menopausal syndrome, and then different conditions that have to do the deficiency of estrogen and progesterone come into play. As to something hyperestrogenia that is done in premenopause, the higher tone of sympathetic nervous system, insulin resistance, compensating hyperinsulinemia, and role of pro-inflammatory cytokines, something that may later lead to sarcopenia. And many colleagues are saying that if she would have done it, but nowadays she doesn't have any strength. So we see muscle body is at best, comes at 30, and then we see decline, especially after 50. We see subcutaneous layer go down, and we see redistribution of tissue in the visceral type, and by 80, strength goes down, is halved. So as you see the hierarchy of loss of physical function, muscle, productivity and performance, and later you can see daily activity decline in every person. We perfectly realize that menopause stands for deficit of estrogens, and they play a current role. And physical exercise, although they need to be clarified. But we're not gerontologists. They actively use estrogens or so that they could help preserve the quality of life. This, as you see, American consensus, and prevent, amongst other things, sarcopenia. Sarcopenia is not an indifferent condition. This is something that today, the combination, such as loss of weight, when woman is shaking, impaired hearing, impaired sight, and this is called as frailty syndrome. In 50% of cases, is seen as an inalienable part of this aging, of this frailty syndrome. What can a gynecologist do about their menopausal hormonal therapy? As of today, we clearly write that modern ideas about perimenopause have to do with women's well-being, high fatigue, weakness, poor performance, and a number of other symptoms in emotional disorders that I've already discussed, cognitive, vegetative impairment. We see pain syndromes. You remember, I hope that pain, it works, it all hurts. Besides, endocrine disorders, dysomnia, libido going down, dysmenorrhea, as well as hypostasia with higher sensitivity for sounds and others. In many patients, this goes hand in hand with poor sleep. And reactive asthenia in many women, even in transition, stands for compensatory reaction that depends on healthy persons when they get this sort of pathological, physical, and psychological factors, such as flights, seasonal work, exams, and reactive asthenia may be provoked by anything that has to do with decrease in adaptation. What can a gynecologist do? We know there is a positive connection between lower muscle mass and estrogens. Besides, it was shown that modern estrogen may have an anabolic impact on muscle tissues because they have estrogen receptors. For example, before you have one of our patients. Well, standard, you've got all this. For example, lady 45 complains that up to 20 times she has hot flushes, night sweats, sleeplessness, poor mood. She overreacts. Her premenstrual symptoms are back. And she works as a manager that has huge emotional stresses. And her complaints do stand in her way. She now cannot perform. She lost weight, 10%, because of stronger stress. Reproductive anamnesis is not at all impaired. And follicles have not going down, and small myoma over 2 centimeters. BMI is normal, 20%, so that's why we're not speaking about excessive body mass. When we examined the patient, VSH showed over 45, estradiol under 40, RA, prolactin, and others. So these changes are in lipidogram and other indications for biochemical blood supply were not caused. Oncocytology indications of liquid cytology are nil, in normal coagulation in coagulogram. In line with further investigation in mammography operations PR1, as the patient had menstrual delay 63 days, you see her uterus is somewhat higher than it should be. Echographic small myomatosis nodes. In ultrasound, we see that a woman has some kind of diffuse changes, and there's so much about her thyroid gland. We diagnosed her with perimenopausal climacteric syndrome and adenomyosis, although there are no complaints, in myoma, and as we say, ultrasound data stand for this. Benign breast pathology, and amongst other things, we diagnose the patient as ISD with asthenia and asthenic syndrome. We can dose the patient with fatigue and her disorder, ailments. The patient was prescribed MHT to support her quality of life. May I remind you that our clinical guidelines say that we prescribe MHT to partially replace the lower function of ovaries. So we use minimal doses of hormonal drugs, which improve the patient's general condition, ensure prevention of later metabolic impairment, and would not be accompanied with side effects. May I remind you that myoma is a relative contraindication for MHT, but in these women the nodes are under 3 centimeters, even under 2 centimeters, and at that we're saying that we require ultrasound control in 6 months, and when there is no positive change, negative change, we can continue. Which drug would suit this patient best? In theory, we could use contraceptives, but she doesn't have sexual life now. She has active work, and she focuses on work and other aspects. So we choose for menopausal hormonal therapy. Then we use a gestogen that is part of this therapy. Given her complaints, preference would be given to her derivatives of the progesterones that I've been quoting, that identified in this table. They are 19 norandrosterone. In this situation, the winner would be levonorgestrel. Given that this is a two-phase estrogen drug, we have an original drug, we have an analog. As you know, right now we're doing input substitution. We see a number of Russian drugs, and the best for women is Digest Klima, that has adequate dose of, and all in all, for 7 days, levonorgestrel in a very small dose, and further on it's followed by classical 7-day break, and cyclical therapy is repeated with menstrual-like reaction. Then we speak about the levonorgestrel, given that it has anti-estrogenic, anti-proliferative activity. It is typical for production of noradjusterone that is actively used, amongst other things, to treat hydroplastic processes in androgens. Estrogens may counter estrogen-produced high glycerides, may lead to absolute decline in triglycerinemia. Well, they are effectively correlating the activity of the vascular walls. They normalize the aggregation properties of platelets and improve best indicators in hemostasis in women with climacteric syndrome. What's important to remember about trans fats? May I remind you that they are unsaturated fats that, under the impact of chemical reaction, have changed their configuration. As a result of the change, this, when they get into the human body together with food, may no longer work. Trans isomers of unsaturated fatty acids enhance the risk of cardiovascular and atherosclerotic disease. This is a study that was published in 2005 about using it for Agence Klima in women, where they could use drugs, combined therapy, estradiol with levonorgestrel, and a separate group that used estrogen therapy alone. And this is the data that we get. The long use and long therapy of hormonal replacement therapy in reproductive age may decrease the trans fats in the plasma that can be used only in the use of gestogens. And it's important to prevent metabolic impairment. Here you have characteristics of 50 women that took part in a prospective open multicenter study for 6 months. Per os use of estradiol plus levonorgestrel in peri and post-menopause. May I remind you that drug that has 2 milligrams of estradiol LLRite can be used to up to 55 years. This is a cutoff point when from a cyclical we should move for continuous intake. It was shown that it removed classical vasomotor complaints, and most importantly, total cholesterol went down, and low density cholesterol also went down. Endometrium was not changed. Well-tolerated drug. No clinically significant changes in body mass. You listened to the presentation by Antonina Smetnik that women fear gaining weight, and such indicators as pathological changes were non-existent, and adherence was very high, 95%. Apart from that, we keep speaking about the impact not only systemic, but if possible, maximum local. We should remember about genitourinary syndrome. It was proven that the use of 2 milligrams of estradiol valerate with levonorgestrel is a good method to prevent and treat genital urinary syndrome when we speak about systemic therapy. This is a prospective study of women where the index of vaginal health has gone considerably up. The vagina went down, pH went down, and it showed estrogenous effect to correct chorionic index in a good percentage. It was proven that against the backdrop of MGT together with estradiol, valerate and levonorgestrel, may I remind you, we started as early as we can in perimenopause. We see improved signs of vaginal atrophy. Well, the pH went down, the wall was thickened, and morphology of vaginal wells is improving. When we speak about the studies that are dedicated to per-os drugs, we always remember how they impact the liver, whether it can be used with and its androgenic effect in women who have this propensity for problems with cholesterol. It was proven, you see that in the slide very well, no data are available for dependence on oral or it is intravaginal administration, intrauterine administration of levonorgestrel in combination with estrogen. No difference was shown whatsoever. We didn't see registration of any in-kind in triglycerides. And globally, total cholesterol went down, which I already mentioned, and low-density lipoproteins did not change, and low and high density cholesterol was seen in both groups. So the use of Mediana with estrogens, or the use even Esclima, when we speak about per-os drugs, gives us a very good effect, both also in terms of treating dyslipidemia. A number of studies were run on the use of levonorgestrel with different doses. Low dose that is available in Russia, and other drugs are available that have microdoses. As of today, it was proven that we need to use both, and I very much hope that the Russian Federation will come up with drugs for continuous intake with levonorgestrel, because in this cohort of women, where they have emotional lability, and there are quite a lot of women, levonorgestrel per se seems to improve the quality of life, but at that it doesn't influence, as I was saying, dyslipidemia, it doesn't influence, they're not gaining weight. Psychologically, complaints are going down. Right now, by over 30% in 6 months. These are not, of course, antidepressants, but agree 30% is a good indicator in terms of menopausal therapy. Besides, in women who had problems with libido in this senior group, because of androgenic effect of gestogen, it gives us a very good anabolic effect, and the sexual disbalance is addressed. Women are saying that their sexual activity has gone up. Another important effect is seen, we can use it in levonorgestrel in a number of endocrine disorders, because they're getting more and more them with age. You see the data of a chronology center that moderately expressed a moderate activity of levonorgestrel can help us use climacteric syndrome in women with chronic adrenal failure or insufficiency. Given that we're speaking that in women we see high level of thyroxine-binding globulins, therefore the free thyroid hormones going down in hormone. But if we do give them this hormone therapy, it helps decompensate, it may address the correction of levothyroxine. So when we use high dose of levothyroxine in women with hypothyroidism, we may see a substantial higher risk of osteoporosis. So this correction has to be used best.
Histogen-containing drugs should be used in perimenopause with a slight androgen effect, excluding drugs containing levonorgestrel together with calcium and vitamin D drugs. That's Galina Chapman's work. Colleagues, I'm talking about osteoporosis. 200 million people are involved in this epidemic. As you can see, and about 14 million people in Russia suffer from osteoporosis. That means every third woman in Russia. Estrogens have the anti-resorption activity. Estrogens prevents the loss of the bone mineral density, and well, you know, bones have receptors for all hormones, including estrogens, and of course, here, estrogens can have a direct impact on osteoblasts and indirectly on the glucocorticoid receptor by reducing the inhibiting effect of the latter, a positive impact on the bone tissue. Progesterone stimulates the proliferation of osteoblasts, thus increasing the production of insulin-like growth factor 2, going back to Galina Afanasiou's work, we can say that as of today, long MHT in case of osteopenia, the risk of osteoporosis is feasible. Well, and the histogen component is usually represented by androgen neurosteroids, and it has also the effect similar to C19 histogens. We can prevent the development of osteoporosis, and usually they contain 1 or 2 milligrams of estrogens, but as for histogens, only levonorgestrel can achieve this effect and prevent the development of osteoporosis. And here we remember that we have also osteosarcopenia. That's a new concept which includes, as I have already mentioned, low BMI and a reduction in mineral bone density due to aging and to the common pathogenesis. Osteosarcopenia develops due to the low physical activity, a deficiency of estrogens and vitamin D. The muscle mass drops, the mineral bone density drops, along with the comorbidity of elderly patients. It leads to an increase in the number of fractures. And of course, MHT cannot be offered to this cohort of women, unfortunately. And once again, I'd like to reiterate our goal is to partially restore the deficiency of sex hormones using the minimal dose if there are no contraindications. Well, bringing to bear issues related to safety of this drug, the treatment must be personalized as far as MHT is concerned, taking into account the risk of breast cancer and postmenopausal osteoporosis, as well as we should take into account the different types of comorbid conditions in women 45 plus. Thank you very much. Thank you, Helena Nikolaevna. You made a wonderful presentation, but it was longer than other presentations at this Congress. Thank you very much, dear colleagues. And I should say that I am very satisfied, and I would like to wrap up our plenary meeting for today. Over the last 3 days, we've seen wonderful presentations. There were wonderful speakers, surgeons, scientists speaking here from Russia and other countries. And we also have live surgeries from different countries. And we had a look at different new technologies. We've had more than 3,000 participants, 3,200, 3,500 at times. Even early in the morning, we had 1,300 people, and that was at 8 o'clock in the morning. That's great. That means you trust us, and we are very grateful to all of you. I'd like to thank our participants on behalf of the organizing committee. Tomorrow is June 9th, and we start at 8 o'clock sharp. So we start with the Young Scientists contest. We sum up, and you will hear the key presentation after this of our Russian scientists during this Young Scientist contest. Then there will be international presentations starting from 9 o'clock. Dr. Bari, colpo suspension, Dr. Delormer, the vaginal surgery, Professor Genozani will be speaking, and Professor Arabin, to mention but a few. Dear colleagues, please be here at 8 o'clock. We'll have the Young Scientists contest, and then there will be the key presentation starting from 9 o'clock. Thank you very much. That's all I wanted to say. Thank you, and thank you for being with us all these days, the entire organizing committee. Would like to thank you once again. Good luck and see you tomorrow.